Good morning, esteemed chief guests, doctors, respected dignitaries, faculty members, technologists, students, and company sponsors who have joined us from Tamil Nadu, Pondicherry, Andhra Pradesh, Telangana, Kerala, and Karnataka. We are also delighted to welcome all the students and fellow technologists who have joined us online via YouTube from Delhi, Maharashtra, Chandigarh, and Punjab. It is my absolute pleasure to welcome you all to 17th Annual SDTP Conference. Today, we gather to explore the latest advancements, share knowledge, and foster collaboration in the field of nephrology. We are happy to announce we are planning to conduct 18th SDTP conference as an All India Summit over 2 days next year. We have exciting day ahead, filling with insightful presentations, engaging panel discussions, and opportunity to connect with some leading minds in nephrology. Before we commence the proceedings, let us take a moment to honor our heritage and seek the blessings of our motherland. Kindly rise for Tamil Thai Valthu and followed by Shri Has Anthem. Thank you. Please be seated. To ensure uninterrupted and focused environment to our deliberations, I kindly request you to silence your mobile phones. Let us also maintain respectful environment throughout the conference. Thank you for your cooperations.
It is my distinct honor to invite our esteemed chief guest to join us on stage. Your presence today is a testament to your dedication and invaluable contribution to the field of nephrology and healthcare. Please join me in welcoming each of them with a warm round of applause. Dr. E. Ram Prasad, Professor and HOD of Nephrology at Sri Ramachandra Institute of Higher Education and Research. Dr. V. Chandrasekharan, Senior Consultant and Head Department of Nephrology at Apollo Specialty Hospitals, Vanagaram and Petron, SDTP. Dr. T.V. Ramakrishnan, Principal at Sri Ramachandra, Faculty of Allied Health Sciences. Dr. B. Jagdishwaran, Principal and Professor at Saveta College of Allied Health Sciences and Advisor, SDTP. Additionally, we are honored to have the key leaders of SDTP today with us. Mr. L. Sivanani, following the SDTP patron, Mr. R. Sendil, founder and secretary of SDTP, Mr. T. Jayseelan, president of SDTP, Mr. Y. Aroki Das, joint secretary of SDTP, Mr. A.T. Sri Mukund, Treasurer of SDTP. Let's give them all a warm round of applause as they join us on stage. Thank you. I request all participants to move forward. We have a lot of empty spaces over here. Knowledge is power. Let this lamp ignite the spark of innovation and inspire us to reach new heights in nephrological care. It is now my privilege to invite all the chief guests to light the lamp, symbolizing the illumination of knowledge and the commencement of our conference. Let us applaud as we commence this auspicious ceremony.
to officially inaugurate the conference, it is only fitting that we begin with the words from someone whose vision, mission and dedication have been instrumental in bringing this event to life. His passion for advancing the field of nephrology and his unwavering commitment to improving patient care have been the driving force behind the success of SDTP. Under his leadership, SDTP has grown into a vital platform for knowledge sharing and professional development in our field. I cordially invite Mr. R. Senvil, the founder and secretary of SDTP and the manager of dialysis at Cedar Hospital to deliver the welcome address. Please join me in welcoming him to the stage with a warm round of applause.
அனைவருக்கும் காலை வணக்கம். வருகை தந்திருக்கும் சிறப்பு விருந்தினர்கள் டாக்டர் ராம் பிரசாத் சார், டாக்டர் சந்திரசேகர் சார், டாக்டர் ராமகிருஷ்ணன் சார் மற்றும் டாக்டர் ஜெயதேஷ் சார் அனைவரையும் வருக வருக என வரவேற்கிறேன். மற்றும் வருகை தந்திருக்கும் மருத்துவர்கள், டயாலிசிஸ் துறை சார்ந்த நண்பர்கள், டயாலிசிஸ் பேராசிரியர்கள் மற்றும் நண்பர்கள், நண்பிகள், மருத்துவ மாணவ மாணவிகள் அனைவரையும் வருக வருக என வரவேற்கிறேன். மேலும் இந்த கருத்தரங்கம் இனிதே நடைபெற உங்கள் அன்பும் ஆதரவும் வேண்டுகிறேன். மீண்டும் ஒரு முறை அனைவரையும் வருக வருக என வரவேற்கிறேன். நன்றி, வணக்கம்.
Nandri sir, we have just witnessed an inspiring welcome speech. Let's give Mr. Senvil another round of applause for his insightful words. Thank you. We are honored by the presence of eminent personalities who have made significant contributions to the field of nephrology. To kickstart our deliberations, I invite our chief guest, Dr. E. Ram Prasad, Professor and HOD of Nephrology at Sri Ramachandra Institute of Higher Education and Research, to share his invaluable insights. Let us accord him with a warm welcome.
Respected dignitaries in the dais, a warm welcome from Sri Ramachandra and from Department of Nephrology. It's an immense pleasure to participate in such a massive event. We all know the burden of CKD is on the rise. So we as healthcare workers has to be trained to cope up with it accordingly. So the CME like this are very important to update our knowledge. I appreciate the effort made by the organizers to conduct this event in such a massive scale. And I thank everyone for welcoming to this event and best wishes. Thank you.
Thank you, Dr. Ram Prasad, for your enlightening address. Continuing the series of esteemed speakers, we have Dr. V. Chandrasekharan, Senior Consultant and Head, Department of Nephrology of Apollo Hospitals, Vanagaram, and the esteemed patron of SDTP. Let us welcome him with a round of applause.
மேடையில் வீட்டிற்கும் அனைவருக்கும் மற்றும் இங்கு வருகை தந்திருக்கும் டயாலிசிஸ் டெக்னீஷியன், பேராமெடிக்ஸ், டயாலிசிஸ் நர்சஸ் எல்லாருக்கும் என்னுடைய காலை வணக்கங்களை தெரிவிச்சுக்கிறேன். இந்த எஸ்டிடிபி வந்து 17வது கான்ஃபரன்ஸ். அது ஐ திங்க் 19 இயர்ஸ்க்கு முன்னாடி ஆரம்பிச்சு நடுப்புற 2 இயர்ஸ் கோவிட்னால நிறுத்தினோம். ஃபர்ஸ்ட் ஒரு 15 பேரை வச்சு தான் ஆரம்பிச்சாங்கன்னு நினைக்கிறேன். ஸோ ஐ ஜாயின் செகண்ட் இதில் ஐ திங்க் டிசி மேனர் இல்லையா, அதில் மொத்தமே 30-40 பேர். இப்போ வந்து இந்த அளவுக்கு இந்த ஹாலே நிரம்புற அளவுக்கு லாஸ்ட் இயர் பார்க்கும்போது ரொம்ப அதிகமாக இருந்தது. இப்போ முதல்ல சென்னை, அப்புறம் தமிழ்நாடு, அப்புறம் இப்போ மற்ற ஸ்டேட்டுக்கும் போயிருக்கிறது ரொம்ப சந்தோஷமாக இருக்கு. வந்து I think we have to commend the hard work put in by those people and you. I think we have to congratulate them. And இன்னைக்கு பொறுத்த வரைக்கும் இது வந்து ஒரு ஆஃப் டே ஜாலியாக இங்கே உட்காந்துட்டு அரட்டை அடிச்சுட்டு போயெல்லாம் நினைக்காதீங்க. இங்கே வெரி வெல் கியூரேட்டட் ப்ராக்டிக்கல் டாபிக்ஸ் வந்து சூஸ் பண்ணியிருக்காங்க. அதை எல்லாம் சீரியஸாக இன்ட்ரெஸ்டோட அதை கேட்டு அதுலேருந்து கொஞ்சம் லேர்ன் பண்ணிக்குமாறு நான் கேட்டுக்கணும். இந்த ஏன்னா பிகாஸ் மெடிசின் வந்து ஒவ்வொரு நாளும் வளர்ந்துட்டே இருக்கு. நான் ஃபஸ்ட்டு டயாலிசிஸ் எப்போ 1945 இந்த வேர்ல்டு வார் 2ல் ஆரம்பிச்சு இப்போ எந்த அளவுக்கு டயாலிசிஸ் சிகிச்சை முறை வந்து நாள் வளர்ந்துட்டு இருக்குன்னு நம்ம பார்த்துட்டு இருக்கோம். ஸோ இந்த மாதிரி கருத்தரங்கத்தில் வந்து நம்ம எந்த அளவுக்கு நமக்கு கற்றுக்க முடியுமோ அதை கற்றுட்டு நம்ம அதை வந்து ப்ராக்டிக்கலாக டே டு டே அப்ளை பண்ணணும். ஸோ இந்த நெக்ஸ்ட் டைம் என்னோட கோரிக்கை என்னென்னா, இது வெறும் கருத்தரங்கமாக இல்லாமல் அடுத்த வாட்டி இப்போ நிறையா கோர்சஸ்லாம் ஆரம்பிச்சிட்டாங்க நிறையா இடத்துல. ஸோ அந்த பட்டிங் ஸ்டூடெண்ட்ஸுக்கு ஏதாவது ஒரு குவிஸ் ஒரு எஸ்ஏ காம்படிஷன் மாதிரி நெக்ஸ்ட் இயர்லேருந்து நம்ம அதை இன்ஸ்டியூட் செய்யணும்னு கேட்டுக்கிறேன். ஸோ இந்த வாய்ப்பு அழுத்தமைக்கு SDTP SDTPக்கு என்னோட நன்றியை தெரிவிச்சுக்கிறேன். நன்றி, வணக்கம், ஜெய் ஹிந்த்.
Thank you, Doctor. Now I invite Dr. T.V. Ramakrishnan, Principal at Sri Ramachandra Faculty and Allied Health Science, to address the gathering. Let us welcome him.
Good morning, everyone. Respected friends on the dais and off the dais. I hope you can see me now. I was asked to stand on this. I thank you for inviting me for this conference. I just want to let you know that Sri Ramachandra University was one of the first to start the Faculty of Allied Health Sciences as early as 1995. And dialysis technology started in 1996. More than 250 undergraduates have passed out. The post-graduation was started in the year 2006, and we have more than 50 postgraduates who have come out of this university and gone on to find laurels in academics. And we have our own Dr. Jagdishwaran here, who is the principal of the Faculty of Allied Health Sciences at Savita. So we are very proud of your alumni. The work that you're doing is extremely important, not just taking care of dialysis patients, but actually finding out problems in them, reacting early, and treating them. So good knowledge of medicine is extremely important for you all. And I wish the SDTPCON 17th Annual Conference the very best, and may you have very good deliberations the whole day. Thank you again for inviting me.
Thank you, Doctor. Before moving to next speech, I request Mr. Ruben, Vice President of SDTP, to the stage. Finally, we have Dr. D. Jagdishwaran, Principal and Professor at Savita College of Allied Health and Science and Advisor to SDTP. Let us extend a warm welcome to him.
Respected dignitaries on the dais, off the dais, dear students, friends, members from the industry, ladies and gentlemen. I would like to take this opportunity to first thank the organizers for giving me this wonderful opportunity to stand in front of you. I know we are already running late and we have a tight academic schedule. I want to make my remarks within a minute or so. as a dialysis professional, I have some 2 or 3 key information which I feel it is necessary for this community. The first is, before starting this, I could see that there are a lot of outstanding, vibrant young minds still standing outside. Hope they will soon join us. I could feel that there are a lot of students who have joined here today. I would like to remind of one important, that is the professional responsibility which they should hold to their entire life. That is to improve the quality of life of the patient and also thereby increasing their outcome. And dear friends and colleagues, we are all aware that there is an increasing prevalence of chronic kidney disease in India. There is a great need for creation of awareness among the general public about its prevention. Our country has only 3,000 or more nephrologists, and nephrologists alone cannot handle this crisis. So there is a great need as a professional, as a student, you also have a professional social responsibility wherein we should go to the community periodically, create awareness about the risk factors and sensitize about the problems associated with the chronic kidney disease. And the students can maybe go with a lot of activities like UBA, Unnat Bharat Abhiyan, or through other camps, work along with the other healthcare professionals, identify the patient at risk, refer them to the nephrologist at the early stage for their timely care. And we all agree that dialysis therapy is evolving rapidly. Now, from dialysis therapy, we are moving into the terminology of extracorporeal therapies. So, which involves both the renal and non-renal indications. So, there is a great need. Conference like this will create an opportunity to upgrade yourself and to be on par with the world standard. And I wish all the participants a fruitful and a productive experience today, and I take this opportunity once again to thank the organizers. Thank you.
Thank you, Dr. Jagdishwaran, for your expertise and guidance. Mr. R. Sindhu, founder and secretary SDTP, will now honor our chief guest with a token of our appreciation. This momentum symbolizes our deep gratitude for his valuable contributions and for taking the time to be with us today. As we conclude this enriching first segment, I would like to express our sincere gratitude to all the esteemed speakers for their invaluable contributions. To formally convey our thanks, I invite Mr. T. Jayseelan, President of SDTP and Senior Technical Officer, Nephrology at Apollo Specialty Hospital, Vanagaram, to deliver the vote of thanks.
Very good morning and happy Sunday to one and all. On behalf of Society for Dialysis Technology and Paramedicals, I take this opportunity to thank our chief guest, Dr. E. Ram Prasad, the Professor of HOD Department Nephrology, Ramchandra Institute of Higher Education Research, and Dr. V. Chandrasekharan, Senior Consultant and Head Department of Nephrology, Apollo Specialty Hospital, Vanagaram, and Patron of SDTP. Dr. T.V. Ramakrishnan, Principal, Sri Ramchandra Faculty of Allied Health Science. Thank you, sir. And Dr. V. Jagdishwaran, the Principal and Professor, Savitha College of Allied Health Science, and Advisor of SDTP, for sparing their precious time to take part in this event, in spite of their busy schedule. I would like to thank Mr. Sendil, founder and secretary of SDTP, for 17 years organizing this conference. It is noteworthy to mention that only with his dedication and efforts, we have been able to expand this conference to other states beyond the Tamil Nadu and Pondicherry. So Kerala, Karnataka, Andhra Pradesh, Telangana, and Punjab, Delhi, Maharashtra, and Chandigarh. And not say they are watching through the online. Thank you. I'd like to thank Mr. L. Sivamani, patron of STDP, Mr. B. Ruben, Vice President of STDP, and Mr. Y. R.A.K. Das, Joint Secretary STDP, and Mr. Steve Muganda, Treasurer STDP, for the valuable support. I would like to extend my heartfelt gratitude to all the speakers who have taken time amidst their busy schedule to be here and share their profound knowledge and expertise with the participants. I would like to express our sincere thanks to the management of Sri Ramchandra Institute of Higher Education and Research for providing us with all possible support towards organizing this event. And thanks to IT, Maintenance, Housekeeping departments. And thanks Ms. Hemalata, Assistant Professor and Faculty in Charge, Renal Dialysis Technology, Sri Ramchandra Higher Education. And students of Renal Dialysis Technology for the coordination and the support. My special thanks to Executive Committee members and Organizing Committee members of SDTPCON 2024. I would like to extend my sincere appreciation to all who generously helped us make this event together become a grand success. My special thanks to all the companies for generously sponsoring this education program, and thank you for your continuous support always. Finally, I would like to thank the organizers and volunteers making this program a resounding success. Thank you all once again.
Thank you, Mr. Jayseelan. So, our first technical session is on UPDF, HDF, the need of the heart. I am pleased to invite Mr. V. Jairam, Deputy Manager, Clinical at Fresenius Medical Care, to share his insights. Let's welcome Mr. Jairam with a big round of applause.
Hello. Good morning. I see a lot of cross-talking. Can we maintain silence? Please. I still can't start the talk unless I see the silence, because it's going to be an important topic. Okay? Still I don't see a little bit of cross-talking going on. Before I start, you all must be thinking, what is this? Do I have ultra-pure dialysis fluid? Here we go. When I walk through, you will really understand what is that. When I did my course recently in the US regarding a trainer, 7 minutes our brain can only concentrate, and I still see people cross-talking. What is UPDF? Its benefits, a little bit of question and answer I'll keep at the end. What is HDF? A bit of features required to deliver for the better quality of life. And a little bit on the latest study. I will also talk about different studies which you can find in PubMed, many of the journals that's published, and last, the summary. So what is UPDF? It is not this company that has come with this UPDF. It's an ISO document which talks about various parts, and in that, narrowing down to part 3, ISO 23500, part 3. That clearly states what should be your water quality. Then it must be pondering your mind, back of your mind. Do I have? Here we go, and you will come to know at the end of the slide whether my unit matches that. So how do you achieve this? Is it possible? Why not? When you have water that feeds into your RO system, it need not be imported. It need not be imported. It can be your local RO, but just because you have an imported RO, you just leave it like that and come into your unit and you walk and you do all your work. No. It's how you maintain the system, regular backwash, regular rinsing, and finally regeneration. Of course, you also have to do the right disinfectant with the right dwelling time. And finally, when you see the water hits the membrane and what comes through the pore size of 0.0001, and that's a micron meter. Once that water that comes out through the reverse osmosis membrane, and that's going to match ISO 23500 part 3. Sounds good? Yes? Doesn't end there. You need to have this UPDF and you want to hit that bullseye. You need to have the right concentrate. Acid, you will never have any growth. Why? The pH is so low, you will never have any growth. But then where is the culprit? Where is the culprit? The mixing of the bicarbonate in the bicarb mixers, which you might think that it's a conical shape, but then you have a L shape, which is going to be the reservoir for the growth of bacteria. And then, what should in the ISO document that recommends? It can be a liquid, aqueous or a dry bicarbonate, but as long as you mix it in a right proportion, right RO water, and then when it mixes inside the hydraulics, the machine should be disinfected with the right disinfectant, with the right dwelling time, and with the right disinfection mode. Finally, when it comes out, before it hits the dialysate compartment, you need to have the endotoxin retention capacity filter, and that's a 0.2 micron. What comes out through the pores of that tiny, you will see that the dialysate is going to be UPDF. So my question to you all, do you think we have this? Have you met it? I leave it to you. Last but not least, what that comes out through the endotoxin retention capacity filter needs to pass through another endotoxin retention capacity filter to prove that you have, which is mentioned in the ISO document 23500 part 5, page number 19, you will see that this value, what do I mean? It matches your saline, which is sterile and non-pyrogenic. I am an international certified auditor. I am also an IPC linked nurse. Many parts of this country, somewhere around 9,900 hospitals I have traveled. I have visited, I have audited even a couple of days before. I will not mention the hospitals, but I have seen the RO that is stored in the tank. I am not going to tell you about the chemical analysis, the bacteria or the endotoxins that is seen in the value inside the report. So what I am going to say is the chemical analysis should be not only the RO water, you should also have chemical analysis of the raw water at least once a year if I come as an auditor. So if I think the next topic, if I am right, we have about complications. I am not going to narrow down to all these and explain. You will have more discussion there. What I am trying to justify is patients that receive the dialysis treatment, it is very, very critical if these are found in the values found in the water. So finally to end, the dialysis fluid should be of the highest purest fluid. If not, there will be complication, and that's going to have a direct impact in the clinical outcomes of all the patients. So ISO document I'll quickly run through. We have part 1, which is general requirements, and this is about the medical equipment standards. Then we have the RO water standards. Then we have the powder that is being mixed. It should be the European or medical grade whatever. And then lastly, it is the replacement or the substitution fluid that is going to be CFU 0.1 per ml and endotoxin 0.03 per ml. Where do we stand? So to a nephrologist, I always say an ultra pure dialysis fluid is going to maintain or preserve the residual renal function. No inflammations you will see. For a biomedical engineer, if you are sitting here, I would say you need to have the IEC standards, which is International Electrotechnical Commission 60601. Part 1 is the electrical standards, and part 2 will be for the safety of you all. If you go and touch, you should not get the electrocution, or that electricity should not pass into your body. That's the standard. And then for the technical people here, if you are a nurse or a technologist, you need to see that just putting an RO doesn't work. You need to go and work there, and you need to surveillance, monitoring, recording, all these should be there if I come and audit your unit. Last but not least, if there is a purchase manager sitting here or any other or in the management side, I would say the RO should be very compact and it should deliver what is required for that patient for that shift. Yes, UPDF benefits for many of the patients. It preserves the residual renal function. Any company who gives the mission, probably you might be having an endotoxin retention capacity filter. It lasts for at least 100 treatments. Probably you will see that for that X number of months, you will see the residual renal function maintained. After that, the endotoxin will go and hit or cause the endothelial damage, and then the blood supply, the GFR is going to reduce, direct impact in the residual renal function. What else you require? And inflammation and infection. Most of you, probably the students, might not be knowing what goes in and causing, and what is the reaction in the body. That's called an inflammation. So why I put that slide is there is no inflammation. I have not seen since 94 I have been using the endotoxin retention capacity filter. None of the patient had interleukin triggers nor admission. Reduced risk of dialysis related amyloidosis, sorry about that. Before there was an endotoxin retention capacity filter. After 1 month of using the endotoxin and up to 6 months, you can see the beta 2 microglobins slightly better removal. Whereas they stopped the endotoxin filter and they saw the things rising up, and this is what the slide talks about. This is not Fresenius one. This is published in the journal. The next one is UPDF versus the standard dialysis fluid. The survival rate is better with ultra pure dialysis fluid. Freshness is there to help you out. If you have an XRO system, we are there to guide you, to take you forward and reach the ISO standards. Sounds good? The y-axis versus x-axis, the number of liters the substitution fluid goes into the body and automatically removes becomes a big question mark in India, because automatically the substitution fluid or the replacement is calculated by the machine. So the higher the substitution fluid or the replacement, the better is the survival. So the answer is in your hands. The blood flow is most important in a hemodiafiltration. Summary of the UPDF is, you need to have the right RO system, maintained properly, disinfected properly, and then you should have the RO water passing through the machine which is properly disinfected, and then you have the ratio of 1:32.775 is to 1.225 or 1 plus 34 is to 1.83. Either whatever is it, you need to see that it passes through the endotoxin retention capacity filter to match ultra pure dialysis fluid. But if you push it to the second endotoxin filter, then you will see that it becomes substitution fluid. Now my question to the audience, is your dialysis sterile? Is your dialysis sterile? No, your dialysis is not sterile. Why? Even if you have 0.1, 0.2, 0.3, you must be knowing the reports, times your dialysis fluid in ml per minute. This is ml, that is ml per minute. Now you will have the answer. Straight away I am going to go through many of the features of online HDF. I am not going to read the slide and bore you all. We know in hemodialysis, it's just a diffusion, not a convection. Maybe probably a little bit of ultrafiltration can lead to the solvent drag. But I am trying to justify that in hemodiafiltration, you will see the middle molecule clearance better in case of hemodiafiltration, not much in hemodialysis. And we always look into beta-2 microglobins. That's the only one which is easy to measure and cost effective. But there are many other, around 24 substances like leptin, which is the hunger syndrome, and that is going to retain in the body and cause anorexia. Why do we need HDF? In HD, it's just diffusion, not much of convection unless you have. And you see the improved survival is slightly less. If we have one chart there, one study which will show you about the improvement of survival. The other one is the beta-2 microglobins. We have natural cleats, it can throw out, but for the poor dialysis patient on hemodialysis, it's not going to be removed. You need to have the clearance by using a therapy called online hemodiafiltration to have a better efficacy and a better leading outcomes in terms of not only survival, in better outcomes of that patient. So hemodiafiltration is the best available therapy for all your patients. So improved stability, response of the inflammation is less, beta-2 microglobins almost, we have the latest dialyzers which can remove up to even 100%, latest dialyzers. The available one at the moment in this company is around 0.9, we are coming soon with 100%. And the last but not least, we have anemia control, because the patient's nutrition value or the leptin is removed, they have good appetite, and then plus your professors or the nephrologist is going to prescribe the erythropoietin, the iron stores the liver will bind, and in the labile pool you will see the formation going into the blood gushing into the bone marrow and forming the erythropoiesis. But at the end of 1/20th day, for us no problem, for the patients it's again going to be a question mark. All-cause mortality as well as beta-2 microglobin level, if you see removal, it's only with convection. There are a lot of scientific study, not to bore you all, I'm just narrowing down to one word, volume. Volume that matters. Whether it is 21 liters or 17 liters, 25 liters and 20 liters. These were all within a small population, and I will not say it is a biased study, but though I have completed the academic writing recently from the government. But what I am trying to say is, these were all narrowed down and they have given it, it has been published, but I am going to present you the value that they have presented, which is only 14%. But I am now coming to a convinced trial, that is the latest, August 2023. 23 liters has been pushed into the body, or I would say convective volume. Convective volume is nothing but 21 liters of the substitution fluid plus the 2 liters of the ultrafiltration volume. This trial is not sponsored by this company. Lot of studies which you saw in the previous slide, it was inconclusive results. So what I am trying to say, the convinced trial by Dr. Peter Blankstein, 2023, August it was published, HD versus HDF. You can see 23 liters in 2023 it was published in the New England Journal, New England Journal of Medicine. And what they say, high flux dialysis versus post dilution of hemodiafiltration with 23 liters decreased in the mortality rate by 23. So 23, 23, 23, magic number. I was talking during the conference to Dr. Peter Blankstein, and I was telling this value is a really magic value. He also didn't strike him that time. So coming to the places where they have done these studies, Fresenius also participated but not sponsored. And we also had our competitors like B. Braun and other companies from various European places. And a lot of inclusion criteria was there. And I'm not going to run through this. It is available in your Google search engine. What I'm trying to say, they included all access, whether it is fistula, catheter, graft. But you'll have to keep back of your mind, the minimum blood flow was 350, not less than that. It was a post-dilution, and you see all-cause mortality, the post-dilution 23 liters, but 23% decrease in the case of mortality. Who can benefit? If you have a patient, most of the time phosphate is never removed in hemodialysis, then doctors have to prescribe phosphate binders. All these cumbersome process you can till down. So if you have a phosphate in patients, most of the patients, you can put them on HDF. Beta-2 microglobules more, you can put them on. Patients who are prone to orphan hypertension, of course, HDF is the answer. Few minutes before I was telling leptin is an hunger syndrome. It doesn't get removed because the value of that is 16,000 Daltons, doesn't come out easily. It has to be removed by a process called convection. And last but not least, calcium time phosphorus, which binds with the water, becomes phosphate, doesn't come out that easily. So you need to use convective method and maintain that. Anything more than 55 leads to renal osteodystrophy, metastatic calcification. Last but not least, I have never seen, since 2004 I have been using these machines, I have never seen even one patient blood pressure going high, nor one patient getting hospitalized. So the approach to, yes, that's the most professors and nephrologists will love to. For European patients, yes, they have good fistulas, everything. Simple. If they are twice a week, they can still be on HDF, but cost, of course, is a constraint. Look into that. But to me, the dialysis flow is 500. The principle inside is diffusion and convection. We have an auto flow factor where you can use that and play with it. So what I'm trying to say, a simple scenario, 500 ml per minute is the dialysis flow. I'll try to make it 1.5, and the dialysis flow is reduced to somewhere around 400. And that 100 I try to use for convective dose. So there is not much of usage or cost. I would say it is cost effective. So this is one which is available in the journal, Dialysis Transplantation, where you can pick up the convective volume for the weight of that patient. And this is the benefit, cost benefit. You will see erythropoietin dosage coming down, hemoglobin maintaining, and I'm not going to talk about the brand name of the phosphate binder. Phosphate binder tilts down, and hospitalization, I told you previous slide also, almost nil. Hypotensive episodes, yes, it depends. If the patient still gets hypotension, probably it's a dry weight and many other factors. You are all more knowledgeable in that. Summary of that is online HDF, you will see a better survival in most of the patients. But for that, you need to have a very, very good access. Not a sucking catheter or a fistula which is around 200 ml. It's rather don't do hemodiafiltration. Diffusion and convection both coming together, HDF. HD is diffusion, filtration is convection. And this is just a simple, you all must be known. So 23 liters, if you can hit that target, I think you will see better patient outcomes. How to hit that? The machine has an automatic flow, or you can go manually. You don't need to do that cumbersome process of calculation of CRRT dose, 25 ml per kg body weight up to 45. That slide comes, I will tell you. So you need to have a good needle, good size blood flow. Post dilution is for heparin. Pre-dilution, if heparin free, you can use HDF. How to manufacture, or how this machine manufactures? You cannot use the liquid one, you need to use a dry bicarbonate, because liquid bicarbonate definitely will have X value inside. Acid, you will never have any growth. So when it manufactures and passes through two endotoxin retention capacity filter, it will match the saline, non-sterile or sterile and non-pyrogenic. So most of the time dialysate is not sterile, but if it passes through another filter, I think it matches the sterile and non-pyrogenic. Features, you need to have certain features to get that HDF on dot and give a thumbs up. You need to have a temperature monitoring, because temperature can cause hypotension. Many times when I gone as an auditor to many hospitals, 37, 37.5 is the dialysate. The recommended one is 35.5, because back diffusion, the temperature can pass into the dialysate to the blood through the venous chamber, goes to the hypothalamus. From the hypothalamus, it goes to the core temperature. Then the core temperature goes through the vessels, and vasodilatation, blood pressure drops. Coming to the automatic substitution preparation, the next slide we will talk about. VAM is a venous access monitoring. These are all safety features recommended, and this is about BTM, where you will have nothing to program, just guide through the blood lines that is given to you. And the beauty of this software is auto as well as manual. I will say don't use manual, because this machine has an intelligent software where the arterial and the venous pressure always have a sync. Anything seen in this, you will see the stress levels in the fibers. We have, by the way, 13,754 fibers inside. I have broken and I have counted it single. So from the artery to the venous, 1,000 dynamic signals passes every minute, and the stress levels is felt. Immediately the blood flow gives a signal to the second pump, which is the substitution. The substitution rate goes down. This one is, if you see your venous monitoring, it is asymmetric. Anything 30 millimeters drop, then only it will give you alarm. This machine is very sensitive. 15 millimeters it drops, and it will give you, that means blood loss is very minimal. VANAC, you don't have it in India. This is one that goes into the fistula wing, below the fistula wing. Anything that touches here, the fluid or the blood or the plasma, the signal goes. This is not attached to the machine. From here to the machine, the signal is passed. It's an infrared. And the machine will stop the pump. More for a pediatric. Economical flow. When you see the dialysate flow while priming, it's still at 500. Your consumption of fluid is more. But when priming, it is automatic priming. You no need to have saline, no IV set, no bucket or pail, and no need to do the priming. Automatic priming, and the dialysate flow is at 100. Until the blood touches the OD optical detector, it doesn't change the dialysate flow. Amazing feature here. When there is a blood pressure drop, you go and switch off the UF, reduce the blood pump, check the blood pressure, give a bolus. The machine is going to do that. Jesus saves life, praise the Lord. You go and press that, and that is going to do all this. You will have to go to the patient, put the patient into Trendelenburg position. Whether it is HF, HDF or HD, you can do this. What else do you require? Heat disinfection is mandatory, automatic. That also is automatic. RO water should be maintained, and you should have a standard. 50 is action level, you can't start the unit. And if you want to do HDF, you need to have this value. 0.1 CFU per ml and endotoxin 0.03. That means time 500 will be your value. So in ISO document it states that if you have endotoxin in series, you no need to do a culture. But I come as an auditor, I want a culture report, because I'm going to safeguard you. If something happens, touch wood, to the hospital, that is, I'm going to safeguard you. So you need to have a culture report. Recently I was in Kolkata, I said I want the culture, then I start. Summary. All this is narrowed to one word called improved survival. Anemia control, yes. Hypertension under control, HDF. Intradialytic hypotensive you will never see. enhanced uremic toxin as well as beta-2 microphosphate removal. Finally, improved bone disease control. Sounds good? Last but not least, because of the ultra pure dialysis fluid, you will see that the risk of hospitalization is almost nil. But still the patient gets that triggers or anything in the body. You will have to narrow down, deep dive down to the root of the problem, and then look into the other things and see that the patient is admitted and treated. We have a free online education course which is AREP. I am the first. I know one person who was with Fresenius, he completed, but then I don't know whether he has done all the modules. I have completed all 100%. And it's from the California Board of Nursing. Whoever is interested, meet me in the stall, I will guide you. So I think 5 minutes is there. Can we go through a quiz question? I think Dr. Chandrasekhar was telling you need to have a question. Let me see how alert you were. What are the recommended blood flow for a high volume HDF? I didn't hear. Okay. 350 to 500. I usually go up to 480. Max Sakit, Dr. Kuller, very close friend of mine. Recently we had a chat before he went to Malaysia for a talk. The dialysate composition prescribed for HDF must be different from dialysate composition prescribed for HD. Again I repeat, the dialysate composition, it is different or is it the same? HD and HDF. False. It's the same. It need not be different. There are no contraindications specific to hemodiafiltration. Tricky question. Recently when I did my course in UK, this was one of the questions, and all 18 countries participated. They made it wrong. I'll give you the answer. It's true. Which of the factors influence the convective volumes delivered during online HDF? Read carefully and answer. Which of the following factors influence the convective volume delivered during online HDF? I'll give you the answer. Except dialysate. Dialysate flow has nothing to do, because I think many professors know that after 2.5 hours you will see it becomes plateau. So no point in keeping 500 versus 800, you will have not even few ml difference. Rather I increase the time by 15 minutes to achieve whatever Dr. Peter Blankstein. During the talk I was telling him, India we have not much good blood flows, but I still manage with 200 to 250, I increase the time. CVCs are contraindications in hemodiafiltration. I still see so much of talking. Never mind. Probably you have a better topic running there. Okay. So contraindications in hemodiafiltration is false. You don't have. Read carefully. I emphasize many times. Choose all that apply. Does not preserve the residual renal function, reduces the inflammation, increase dose of erythropoietin, increase the CRP, reduce risk of dialysis related amyloidosis, reduce risk of cardiovascular events. I purposely I know all of the above. Here is the answer. It reduces the inflammation, reduces the risk of dialysis related amyloidosis, reduces risk of cardiovascular events. Which of the following is the ultra pure dialysis fluid? Which one? 0.1 and 0.03. How does diffusion occur within the dialysis? I know it's very simple for seniors, no, for the students. The answer is all. What is the term tendency of a small molecular weight solute to be pulled across a semi-permeable membrane along with the solvent? Small molecular weight pulled across along with the solvent. Convection. I emphasized twice during my talk. Economic flow, that was almost second last slide. 100 ml, which helps in saving the fluid consumption and reduces the cost. True. Emergency button performs which of the following? I didn't give all of the above. It's all. Almost 2 more, we are done. Dialysate flow starts from 100 is the lowest, you go up to 1000. So you play with your patient's blood flow. Dialysate filter, it's not like your normal dialysis machine, you can't bypass it. So my answer will be to start a hybrid mission therapy, whether it is HD or HDF, it's true. You need to have. Thank you. All the best.
Thank you, Mr. Jairam, for your comprehensive overview on such an important topic. We will now open the floor for questions. Please raise your hand if you have any questions.
If you are new in this auditorium, new people, the word learning, I'm doing one course in Indira Gandhi National Open University, okay? It talks about learning. You know the magic word? Take off the L alphabet. The answer is in your hand. So please ask questions, open to you. Jude, after a long time I see you. Please, give him a mic so that.
Good morning to you all. Nice to see doctors are also with us, nephrologists. So this online HDF, some of the places it has been told that we can also use for acute cases. If in case the patient is little bit hemodynamically stable, because there are a lot of positive attributes of the machine. For example, the blood temperature regulation. We can give them a temperature, neutral dialysis, which will maintain the blood pressure.
Yeah, isothermal, you're talking about, yes.
Similarly, when you use a high flux membrane, there will be lot more ranges of uremic toxins also we can remove.
Yes.
Pro-sepsis compounds, anti-inflammatory, pre and pro as well. So with all this, what is your suggestion to use this online HDF machine, either for the sled or for the online hemodialysis?
I got your question, Jude sir. I see many professors sitting. My answer, right from the late 80s, I have been somewhere from 87 to this. I understood your question. My answer will be, it's like all fingers equal. You can't play with the patient by just pushing a hemodialysis machine, because you saw if my third slide talked about hemodynamic stability. So if you want that, because they are already critically ill, very good question. You put the patient with the dialysate flow lower and try to maintain the diffusion, and plus the drugs that are being dialyzed, there are certain drugs, you'll have to look into that also. If you do that and play with the dialysate flow, I think you will succeed. And the right dialyzer for the right patient, that was my last year topic, right dialyzer for right patient. There was just opposite.
That is something we are lacking, because the lower surface area for patients below 50 kgs or something, or to gradually include the higher surface area, which is not happening in our
What I would suggest is, keep the flow at 100. If at all you don't want the counter current, put the co-current.
Yes.
That type of dialysis you will have to, that's more, we have professors here sitting. Usually I do in my units. I take the role of the nurse and I try to do that. And I will not say all succeeded, because God is watching me. 90% yes, the 10% who had a pitfall, probably various other factors involved. It might be cardiac factor, it could be the liver, it could be the sepsis. So what I'm trying to narrow down and complete the question is, try to choose the right dialyzer. We are coming into the market soon. HD itself is enough. We have a EMIC2, EMIC, enhanced removal of middle molecules, the middle molecules. We are coming soon. The filters might be a bit expensive, but it is definitely by far superior in terms of efficacy, in terms of cost. That filter is already launched a week before. It is EMIC 2, which will remove everything.
In terms of
Yes,
absorption,
cytokine storm, you name the problem, it will remove.
protein bound toxins.
And it can run for 72 hours. It can run for 72 hours. Many of the filters have a threshold. The answer is there. Hope I answered your question.
Thank you, thank you.
Thank you. Any questions?
Thank you. Anyone has any other questions for him?
If no questions, thank you. Hope that was informative. We'll catch up next year.
Yes. Please wait on the stage, sir. I am inviting Mr. A.T. Srimugu, Treasurer, SDTP, will now honor Mr. Jairam with a token of our appreciation.
Just a gentle reminder before we proceed. To ensure an uninterrupted and focused environment for our deliberations, I kindly request you all to silence your mobile phones. Let us also maintain a respectful and conducive atmosphere throughout the conference. Thank you for your cooperation. Our next is a panel discussion on preventive of viral infection in HD units. This session will be moderated by Dr. E. Ram Prasad, HOD and Professor of Nephrology at Srihar. Please welcome Dr. Ram Prasad along with our esteemed panelists. Dr. S. Manikandan, Professor of Nephrology at Srihar. Dr. Sandhya Suresh, Assistant Professor of Nephrology at Srihar. Ms. A. Hemalata, Assistant Professor at Faculty in charge of Renal and Dialysis Technology at Srihar. Let us give them a warm round of applause.
Welcome everyone for the session, for the panel discussion on prevention of viral infections in a hemodialysis unit. Dr. Ram Prasad will be starting off the session. Over to Dr. Ram.
இந்த சைடு தானே
இது கிடையாது
எஸ்டிபி அது இல்லையா அப்போ ஸ்லைடு கொடுக்கல சார்
ஸ்லைடு கொடுக்கலையா
கொடுக்கல சார் ஸ்லைடு கொடுக்கல
இது ஒர்க் ஆக மாட்டேங்குது மவுஸ் அதில் ஒர்க் ஆகுது
பண்ணோமே அந்த இதுதான் இதுதானே எஸ் என்ன name?
So, good morning one and all. We will move on to our next session. Our next session is about viral infection in hemodialysis unit. So, to talk about this, we have 4 panelists are sitting. One myself, Dr. Ram Prasad, and then Dr. Manikandan, Professor of Nephrology, then Dr. Sandhya Suresh, Assistant Professor in Nephrology, and Ms. Hema, Assistant Professor in Renal Dialysis Technicians. So what is this about? Prevention of viral infection in hemodialysis unit, why it is very important? You know, hemodialysis patients are particularly predisposed to infection. Even though the dialysis per se itself can cause infection, they have both innate and adaptive immunity disturbances. So they are highly prone for any infections. And especially in hemodialysis unit, you can, the most common cause for admission in these patients is bacterial infection, any infection. And it is second most common cause for mortality after cardiovascular disease. So it is very important to address this issue. How they will understand, now you have to understand how can they get infection. It can occur through bloodborne infections, by contaminations, and through air. So we are going to address mainly about viral infection. So I will be giving just a brief introduction, and other panelists will take over other topics. So most common reason for this infection is breakthrough of the aseptic techniques. So that's why it's very important to maintain an appropriate aseptic technique in hemodialysis unit. So as I told before, hemodialysis patient requires a consistent access through the bloodstream, which is achieved through catheter and needle. And invasive procedures, they undergo invasive procedures with several potential entry points for harmful pathogens, particularly when proper hygiene practice are not consistently followed. And this is also an important thing, the burden of dialysis, because as we talking in 2024, approximately 1.5 to 2 lakhs people are on maintenance dialysis. So this is the extent of proportion that we are going to handle. As a healthcare profession, we should address all the possibilities to safeguard the patients. Remember one thing, not only hemodialysis patient is not at risk, even the healthcare professional who is involved in the patient care is also at risk. So, as I told before, these are the ways the infection can occur, either by contact or by droplet or by airborne. And so, what is our role? Several societies, name it CDC or KDIGO, all have come with a proper aseptic phenomena, how to proceed with the dialysis patient. And we have to follow it 100% to ensure proper dialysis is occurring. So now we will go on to our next topic in our panel discussion. One is about hepatitis B and C infection. You know what all the virus we are handling? Mainly is B and C and HIV. Plus we are also going to handle about respiratory virus also. So thank you. I'll just hand over the baton to our next speaker.
Good morning, one and all. Thanks for this opportunity. We'll move in detail about the most common viruses which affect the dialysis patient. That is hepatitis B virus and hepatitis C. Both can cause acute hepatitis and chronic hepatitis, thereby causing sometimes hepatocellular carcinoma and thereby increasing the morbidity and mortality in CKD dialysis patients. So the introduction CKD is an immune deficient state, hence those who are on dialysis are more prone for bloodborne infection, particularly HPV and HCV infection. As earlier Professor Ramprasad sir has already discussed the modes of transmission. Patients on hemodialysis may be infected through blood transfusion, contamination of dialysis machines and equipment, and interpersonal horizontal transmission in the dialysis units. So HBV in dialysis patients, the incidence of HBV infection in patients on dialysis is around 5.5% in India, and HCV prevalence in HT in India is around 12.1. Incidence of new HBV and HCV infection has decreased due to the screening of blood products prior to the transfusion, implementation of infection control measures and vaccination. Especially after the invention of erythropoietin, the anemia has been taken care by injection rather than transfusion, where many patients were being prone to develop infection because of transfusion itself. And that the incidence has definitely decreased, and thereby the incidence of viral infection also has reduced because of that. So the risk factors, as sir already told, it's in this, having a positive patient in our same dialysis unit, and lack of dedicated HT machine for the positive patients, and low vaccination rates. These are the most important risk factors where to develop hepatitis B infection in our dialysis unit. So how do we prevent this? It is by screening and surveillance, immunization, universal safety precaution measures, and proper disinfectants of the equipments. So extending into the prevention measures like vaccination, WHO strongly recommends the vaccination of all dialysis patients and health workers workers to reduce the risk of transmission. And screening and isolation. Regular screening of HPV patients is crucial. Infected patients should be dialyzed in isolation using dedicated machine and equipment to prevent cross-infection. Infection control practices, adherence to strict infection control practices including proper hand hygiene, use of PPEs, and appropriate cleaning and disinfection of dialysis machine and surfaces is essential. So if you go into the diagnosis, it's like physical examination, ultrasound, and also all the blood donation should be tested for hepatitis B virus and C virus, and also the 3 months one screening for HBsAg and anti-HCV in our dialysis patient is very essential to find the patients. And if somebody develops jaundice, definitely we have to go through a LFT and other investigations to establish the diagnosis. This treatment in general, like we have antivirals to tackle hepatitis B virus, both have acute hepatitis and chronic hepatitis with cirrhosis. The most common drug which we use is tenofovir or entecavir, which is used weekly once and in dialysis patient. So, so how we monitor the treatment if the patient has been on treatment? So the hepatitis B surface antigen level should be less than 5 units per negative or and levels more than 100 is considered negative. Any value between 5 to 12 units is intermediate and should be repeated. So we go to the immunization. In normal adults, that's it's 0, 1, 2, and booster dose after 5 years. But whereas in dialysis patient, immunocompromised adults, a dosage of 40 microgram, that is 1, 0, first, second, and third dose. In the span of first month, second month, third month, and 6 months should be emphasized. And also we have to, yearly once we have to check the anti-HBs titer. If it is less than 10, we have to repeat the dose. So I'll skip. And this is not only for the patient, also to the staff who handle the dialysis patient has to be vaccinated, as well as their anti-HBs titers also should be monitored. So the implication for hemodialysis patient policy implementation, like hemodialysis unit should be implement strict policies for vaccination, screening, and infection control to reduce the risk of HPV transmission. Staff training, continuous education, training of healthcare workers on the importance of infection, prevention and control measures are crucial. And needle stick injury should be reported immediately and been prophylactic antivirals and has to be taken. Markers should be monitored frequently. So screening and surveillance for HBV and HCV infection. Acute hepatitis B in patients with dialysis 80% higher risk for developing chronic infection compared to general population. Screen all patients for HPV and HCV infection upon initiation of intercenter hemodialysis. It's very important. Some patients go abroad, go outside, out of station for some time and get dialyzed outside center, and come back and get dialyzed. So those patients, we have to be vigilant and ask them to for this history and get one more, like we have to screen them immediately. And upon, there is also a modality where such patients have been put in intermediate machines where after a month or so they can go back to that negative side. Upon transfer and from another dialysis, perform HbA1c testing every 3 months, as we all know. Anti-HB status greater than 100, then do every 6 months once. Anti-HCV antibody titer should be measured. In units with a new HBV and HCV infection, all patients should be tested and frequency of subsequent HCV testing should be increased. Segregation of patients infected with HBV and HCV. HBV infected patient dialyzed in area that is segregated from main dialysis unit. Healthcare workers handling them should not handle other HT patients. Dialyzed reuse should not be done. And same goes for hepatitis B, hepatitis C also. So these are the universal safety precaution measures. In contrast to other bloodborne infections, the circulating load of HBV can be higher in hepatitis B surface antigen positive individuals, and the virus can survive on environmental surfaces for a week or longer. So nosocomial bloodborne virus infection among dialysis patients has been related to inadequate infection control measures or technical breaks. To prevent nosocomial infections, standard precautionary measures must be rigorously followed. So universal precaution measures, barrier precautions, it's like washing hands after contact with potentially infectious surface or material, wearing gloves when contacting potentially infectious surface or material, wearing a mask, face mask and gown when exposed to blood or body fluids in the expected. In addition to standard precaution measures specific to hemodialysis are just like wearing gloves after contact with patients, routine steps in HT access care as followed in non-infected patients, use single dose vials whenever possible and dispose them immediately after use. Preparing and distributing medication from a centralized area to avoid moving from patient to patient. Avoiding the use of medication supply cards. Healthcare workers handling the dialysis of patients with chronic HBV should not carry out clinical procedure for patients without HBV infection as the same session. Isolation of patient with chronic or occult HBV infection during dialysis, and regular auditing of infection control policies and practices to ensure adherence. Thank you.
Thank you, Dr. Manigandan. Now we will move on to our next panelist to talk about HIV infection in hemodialysis unit.
So good morning everyone. So I'm going to talk about this human HIV virus in hemodialysis patients. So as you all know how HIV is transmitting and the sources and all. So HIV is a virus that attacks the body immune system. That is, if patient's CD count cells which is falls below 200, it is confirmed as patient as HIV. CD is nothing but a cluster of differentiation. Without treatment, it can lead to AIDS, which is acquired immune deficiency syndrome. So how this transmission is happening is that most people who get HIV get it through anal or vaginal intercourse or sharing of needles, syringes or other drug injections equipment. Only certain body fluids can transmit HIV, and some of the fluids are blood, semen, pre-seminal fluid, rectal fluids, vaginal fluids and breast milk. All these fluids should come in contact with the mucous membrane or damaged tissue or to be directly injected into the bloodstream for transmission to occur. There is no currently effective cure for HIV till now. Once people get HIV, they have it for their lifetime, but with the proper medical care and antiretroviral therapy, one can control the virus replication. Patients with HIV already have a compromised immune system, making them more susceptible to infections and complications, including those related to dialysis process. So progression to AIDS. So HIV is a preventable disease if patient is continuously taking their antiretroviral therapy drugs. Better antiviral treatments have greatly decreased deaths from AIDS to worldwide. Untreated HIV patient most often turns into AIDS in about 8 to 10 years of their lifespan. So transmission risk, as we have discussed this transmission routes, I don't want to explain it further. So now we'll go for infection control measures. As you all know, there should be a strict adherence to universal precautions. That is, we should separately dialyze this positive patients and negative patient. We should separately have missions for HIV, HBsAg and HCV positive patients to avoid the cross-contamination. Including the use of PPEs, safe handling and disposal of needles and sharps, and proper disinfection of dialysis machine. Regular screening of patients and staff for HIV along with appropriate precautions for those who are HIV positive should be maintained. The WHO, that is World Health Organization, emphasizes the importance of treating all patients as potentially infectious and following standard infection control protocols. So diagnosis is people develop antibodies to HIV within 28 days of infection and will call them as a window period to detect antibodies produced by a person as part of their immune response to fight against HIV. So now we'll see about the management of HIV positive dialysis patient. Antiretroviral therapy, based on the classification, patient should have the medications. Patients with HIV undergoing hemodialysis should be maintained on antiretroviral therapy to control viral replication and improve immune functions. The choice of ART may need to be adjusted based on the patient's renal function. And next is about drug interactions and the adjustment. Careful management is required due to potential drug interactions between antiretroviral medication and other drugs which are used in hemodialysis where the patient is taking. Dosage adjustments may be necessary based on the patient's renal function, which is important. Regular monitoring of CD4 counts, viral load and renal function is critical in managing HIV positive patients on hemodialysis. So now we'll see about prevention. As you all know, there should be we should adhere to the universal precautions. Like we should have a separate missions, and we should take a dialysis separately for positive patients, and we should strictly adhere for the wearing PPEs and follow the 5 moments of hand hygiene for the patient, and safe disposal of needles and syringes should be maintained. Regular screening is HIV positive patients should have regular blood tests to monitor their health and kidney functions. Clean dialysis machine, that is, ensure that dialysis machines are thoroughly cleaned and disinfected after each use to prevent the cross-contamination. Infection control in dialysis units, we should follow the strict hygiene practice like washing hands frequently and using sterile equipment to avoid the cross-contamination. Medication adherence is that it is important for HIV positive patients to take their antiretroviral medication as prescribed by the doctors to keep their immune system strong and reduce the risk of infections. Thank you.
Thank you, Ms. Hema. So now we'll move on to our final talk, which is quite important, the respiratory infection which are seen in dialysis unit.
We have dealt with mostly the blood-borne viral infections till now. Now we will be talking about the respiratory viral infections. So why is it important to include the respiratory viral infections? Because we know that dialysis patients are immunocompromised and they're at higher risk of all infections, and they're at higher risk of complications from infections. So we've actually found that studies have shown that there is a 14 to 18 times higher risk of mortality in dialysis patients with pneumonia compared to a general population person with pneumonia. So we know, like in a school setting, when one person gets a cold, everyone gets a cold. So dialysis center is something like that. 40 to 50 patients are undergoing dialysis at the same time inside a closed space. So there is a high risk of transmission of respiratory viruses. So most common viruses were strep pneumoniae, Staphylococcus aureus and Pseudomonas. These were the earlier bacterial infections, and the viral infections like influenza and COVID have also now taken precedence over these earlier bacterial pathogens. Patients on dialysis are also more likely to have other comorbidities like diabetes, hypertension, coronary artery disease, COPD, and that makes them even more prone to all these infections. Tuberculosis, also one of our endemic diseases in our country, is also very common in dialysis patients, and it's a very important consideration when the dialysis patients are planned for transplant, in which case they would be requiring immunosuppressive medications. So some of these, the CDC guidelines actually ask us to test for latent tuberculosis by using a tuberculin skin test for all dialysis patients. However, because of its limited sensitivity and specificity in dialysis patients, we don't do it routinely in our country, and we only do the tuberculosis screening only when the patient is asymptomatic or when we are planning them for a transplant. One of the important things, these are all vaccine preventable viral diseases are influenza and COVID-19. So we know that there are outbreaks from time to time in our dialysis centers. Most commonly we see is H1N1, that is influenza A, which spreads very easily in healthcare settings, not only for the dialysis patients but also among the staff looking after the dialysis patients. So these are all airborne droplet infections, so it is very easy to spread in any closed environment. And there will be seasonal outbreaks, especially when the dialysis takes place in very crowded conditions in some centers. COVID-19, we all saw the scenario in COVID-19, maybe the younger generation may not know, but we saw that technically in most studies they have reported 10% incidence in dialysis centers, but in real-time practice we have seen it could have been as high as 50 to 60% of our dialysis patients becoming infected, with mortality as high as 30% of all the dialysis patients in a unit. So COVID-19 became a very important problem in, among the dialysis patients because it spread very easily in a closed setting. So we already saw the spread of respiratory infections, which could be droplet or airborne. The main risk factors would be the crowded environment, patients with weakened immune systems. They are frequently visiting a healthcare center where there are other patients with infections. And most of these are transmitted every time a patient coughs or sneezes or talks, so it's easy to spread between patients. So how do we treat these infections? We know that there are antiviral medications, that are appropriate antibiotics. There are now viral antivirals like oseltamivir for influenza. For COVID, there are different drugs which came up at different timelines during the pandemic, which we don't use routinely these days. And of course, supportive care, treat them with, if they are hypoxic, we treat them with oxygen. We have to symptomatically treat them. And most importantly, how do we adjust the dialysis treatment? We should have some isolation facilities in our dialysis center when these patients are found to be positive for very highly transmissible infections like COVID or influenza, that an isolation facility should be available in a unit for these particular patients. Most importantly, these are vaccine preventable. Of course, dialysis patients, we have to remember that their vaccine responsiveness is reduced. They may not have their response to vaccine like how we would have a general population. So we should, but still we should ensure that they are vaccinated. The influenza vaccine is yearly. It is an inactivated injectable vaccine. The COVID vaccine, as we all know, has to be given in schedules of 2, and it also has to be given as booster doses. So we need to inquire about the vaccination status of all our patients. Among the bacterial infections, pneumococcal strep pneumonia is another vaccine preventable disease. We need to give them 2 doses. The first dose would be the Prevenar 13, which is a conjugated vaccine of 13 valent conjugated vaccine. And then 2 months later, we need to give them the 23 valent polysaccharide vaccine, which is Pneumovac 23. So this has to be given 2 months later, and a booster shot has to be given after 5 years. So this, according to the guidelines, it has to be given for all patients on hemodialysis. We need to make sure that patients have a sticker, vaccine sticker, which ensures the vaccination for influenza, pneumococcal and COVID vaccination. And patients who are going for a transplant should have a separate vaccine protocol where they are also vaccinated against other infections like varicella. Patients who are very sick with these infections have to be hospitalized. So how do we prevent? Whenever a patient comes into dialysis, we need to ensure that we ask them symptoms like do they have cough or cold or any runny nose, sneezing, any of these. And in these patients, preferably either try to get them into the side of the dialysis unit, a little isolated away from other patients. Make sure they are wearing a mask during the entire dialysis session. Distancing them from other patients. These are some things that we can follow for symptomatic patients. Hand hygiene, as we have already stressed, and vaccination, which I have already told you about. Screening for these patients. Sometimes there are some centers which follow this protocol, that when the patient is coming for the schedule, we call them and ask them whether they have these respiratory symptoms along with all their other conditions, fever and everything. So that is one type of screening that we can do, but may not be possible in a large unit. So in most cases, when we are checking their pre-dialysis weight, we can also ask them about their respiratory symptoms. And we should make sure that there is good ventilation even inside the crowded dialysis center. There should be adequate ventilation, there should be adequate spacing between the patients, and all the surfaces of a dialysis unit should also be disinfected. And another thing that we need to also ensure is that staff working should also be vaccinated, and the staff should also report to their supervisors if they have any symptoms of a respiratory viral infection, and should be treated appropriately, and should also be wearing masks during their work hours. And we already talked a lot about universal precautions, but it is so important that we have to talk about it one more time. So universal precaution is something that we talk about again and again and again, because it is, it has to be universal. It's not just for the infected patients, it has to be practiced for every single patient that we are managing in the unit, not just for the patient's protection, but also for our own protection. So the most important thing would be hand hygiene, hand washing whenever the hand is visibly soiled, or we should at least use a hand rub sterilium when the hand is not visibly soiled. And when do we do this hand hygiene? It has to be done before contact and after contact with any patient or any possibly infected surfaces, and before and after any procedure that we are doing for our patients. Personal protective equipment, as I already said, wear masks, and gloves should be worn. Clean non-sterile gloves are enough according to the Indian dialysis guidelines. Before and after every patient, we should not use the same glove when moving to the next patient. We need to change gloves between patients and also between procedures. When we're starting dialysis, we use one glove. We shouldn't use the same glove when you're finishing dialysis. We should put in fresh pair of gloves for that. And whenever we are expecting any spills or any splashes, we should make sure we are wearing goggles. We should wear gowns during that settings. Sharps disposal, very important. We should have a sharp container close to the dialysis unit, preferably in a mobile trolley or something, where we can easily dispose the sharps, so that we don't need to carry it a long way from the dialysis patient to the disposal. So then somebody will get pricked on the way. So it has to be disposed as close to the dialysis setting as possible. The equipment, the surfaces, the dialysis machine, everything should be disinfected. Other important thing, don't keep things on the dialysis machine, because that will again increase the risks of infections. And safe injection practices, avoid needle reuse, and whatever injections should not, any syringes should not be taken from one dialysis station to the other dialysis station. We should not allow sharing of syringes. One patient should have only one syringe, and that is very important to follow. Another important thing which we not mentioned here is transducer, because that is an other site where the infection spreads. So there are now transducer protectors which we need to insert wherever the pressure transducers are located, and that will serve as a filter for bloodborne infections. And we all already know the 5 moments of hand hygiene, which I've already said. And when do we perform the hand hygiene? So it has to be done whenever we are doing any procedure between patients and any contact with any kind of infected surface. And these are the personal protective equipment, and sure we are all come across it. And people who wear spectacles are not enough to protect against facial splashes. We need to make sure we are wearing goggles or proper face shields. And safe injection practices, one needle, one syringe, only one time. So this is another very strict universal precaution that we must all follow. Thank you.
Thank you, Dr. Sandhya, for your lecture. So we come to concluding our session. So only one thing I like to reiterate is, in this medical legal era, any outbreak of viral infection, especially bloodborne viral infection, mostly it will be very difficult to handle, and it is usually because of some human errors. So always make sure you strictly adhere to 100% of universal precaution, and form a team, multidisciplinary team, to regularly monitor your dialysis unit and take care of patients. So thank you very much. So with this we'll conclude our session. Thank you.
Thank you to our panelists for a highly engaging and informative discussion. We will now open the floor for questions. Please raise your hand if you have any questions. I have a question. So we spoke about many type of infection. So we'd like to know which is the most serious type of infection.
Regarding viral infection.
Yes.
Actually, all virus infection you should handle it seriously, especially blood-borne viruses like HCV, HBsAg, and HIV, because it will have a long-term morbidity on the patients. So those type of virus you have to handle it very seriously.
Thank you, sir.
Thank you.
I'm inviting Mr. L. Shivamani, patron SDTP, will now honor our moderator and the panelists with a token of our appreciation. Thank you. We will now take a short coffee break. Please be back in 15 minutes as we have more insightful session lined up. Enjoy your break. Welcome back, everyone. To ensure an uninterrupted and focused environment for our deliberations, I kindly request you to silence your mobile phones. Let us also maintain a respectful and conducive atmosphere throughout the conference. Thank you for your cooperation. Our next session is on hemodosophism, the frontier in blood purification, and it will be presented by Dr. S. Eril Nilavan, Senior Consultant and Transplant Physician and HOD of Nephrology at Sri Narayana Hospital and Research Center, Vellore. Please join me in welcoming Dr. Eril Nilavan to the stage.
PowerPoint pointer வந்து pointer work ஆகல. ஏய் பாயிண்ட் சும்மா லைட்டா தான் இது பண்ணு. வருது. இது வருது. ஓகே ஓகே. சும்மா லைட்டா பிரஸ் பண்ணு. காலர் மைக் யூஸ் பண்ணிக்கலாம். Am I audible? Very good morning to one and all. I'll be covering about hemoadsorption, the new frontier in blood purification. I don't say new frontier, it's been there for long years. So some of the slides will be very basic. My content of speech will be on this topics like definition of hemoadsorption, types of sorbents. So what are the principles of hemoadsorption and various hemoadsorption cartridges and its applications and disadvantages and advantages. So we all knew the principles of extracorporeal treatment comes under this three heading like diffusion, convection and absorption. Diffusion is the basis for your hemodialysis and high flux dialysis, and convection is the basis for your hemofiltration and hemodiafiltration, in which you have a transmembrane pressure that is dragging the water. So along with that, the solvents and solutes also do come out. So that is called a solvent drag. That is the basis for your hemofiltration and hemodiafiltration. There is something called as adsorption. That is the principle behind hemoadsorption and hemoperfusion, in which you have a stagnant solid phase, immovable solid phase, and there is a mobile fluid phase in which the solutes are coming into the gaps between the adsorbent. So these are all stuck together or stick together on the surface of these sorbents. So that is called as the adsorption. There is a slight difference between absorption and adsorption. This is for to understand the basic. Absorption, you absorb the entire fluid. Adsorption is nothing but you have a layer of matrix, that is adsorbent matrix, into which the solutes come and attach to it, come and bind to it. So adherence of an atoms, ions or molecules from a gas, liquid or a solid phase either into the surface or into the interior of the material is called as adsorption. So this is about the history of adsorption techniques. The first to start with is the zeolites or the aluminosilicates, which was discovered in 1950, that came into practice. They used this to exchange this ammonium and calcium. And 1935 we have the first organic polymer by the Adams and Holmes. That was the first organic polymer ion exchange resin. And 1948 the first published publication of usage of this organic resin in treatment of uremia, particularly in dogs. And these resins were used for many poisonings in 58s and 60, like barbiturate poisoning, salicylate poisoning, phenobarbital poisonings. And this also got its application in the treatment of various systemic diseases like vasculitis, liver disease, and autoimmune diseases. This is because this is the time in which the people started exploring more of hemoabsorption as well as dialysis, some kind of extracorporeal treatment for many diseases. So that led to the publication of various side effects of this treatment. So subsequently what happened, that there is a tendency to reduce the usage of hemoperfusion or hemoadsorption. And in early 2000s, we have newer dialysis membranes with an affordable cost, with a very better biocompatibility. So that led to the usage of this dialysis membrane in the treatment of poisonings. So what causes, indirectly it causes reduced usage of hemoperfusion or hemoadsorption techniques. And in 2010s, there is very great improvement in membrane coating as well as positive work on these newer sorbents. So that led to the entry of these hemoperfusion cartridges. Way back in 2019, wherein the COVID was very high, these sorbents got into the approval and patients were treated for all these inflammatory and septic states with the help of these hemoadsorption techniques. So how do you characterize these sorbents? So sorbents are usually classified as natural, as we already discussed. This is zeolites or porous carbons, which is a cellulose derived or cellulose coated, or synthetic resins or synthetic resins which are nothing but a polymers of styrene divinyl benzenes with a high surface area to volume ratio. Surface for 1 gram of the volume, you have nearly around 1000 meters square. So such is the surface area, very great surface area is being discovered or being in use. And most of these follow the mechanisms of absorption in the form of direct absorption, like the usage of the van der Waals forces or ionic bonds or hydrophobic bonds, or either an anion exchange or cation exchange. So anion exchange is, it exchanges for a negatively charged ion, and cation exchanges, it exchanges for a positively charged ion. And immunoabsorption is nothing but a binding of an antigen-antibody complex into the surface of the sorbent. So usually they are in the forms of granules, beads or spears. So most of the times are usually spears with a diameter of about 0.5 to 1.2 millimeter. And these are also classified based on structures like macroporous, microporous as well as mesoporous based on the structural size, pore size. And most of the sorbents which are in practical use come under this macroporous type. So this is the first generation hemoadsorption cartridge, that is nothing but the charcoal. Usually traps the solutes with the help of van der Waals forces. The main idea is to remove the small molecules. However, it has got a very poor removal of the middle molecules and got a very poor bioincompatibility. That causes poor biocompatibility. It causes activation of blood cells, it causes activation of coagulation factors, and it has got a very weak skeleton. So what happens, this skeleton gets broken off and can be circulated and produces embolism. So in order to avoid to improve the biocompatibility of these naturally occurring resins, so they suggested the cellulose-based membranes. This is nothing but a derivation of cotton. These are all small symmetrical wall structures with a thickness of about 6.5 to 15 micrometers. So this is, of course, is also associated with very poor bioincompatibility, being that these structures can activate your thrombocytes, that way it can produce thrombocytopenia, it can bind to your leukocytes producing leukopenia, causes complement factor activation. It can also cause hypoglycemia, hypocalcemia, hypofibrinogenemia, as well as hypophosphatemia. So these are all the various side effects of this conventional first generation resins. So we have synthetic resins like double crossed styrene divinyl benzene copolymers, and it's got an excellent high mechanical strength, and it's got very stable as well as, stable, very like thermal stability is also very good, and got very high selectivity to solutes. And it's got a very wide, large absorptive surface area. As already mentioned, it's about 1000 meters square per gram of the volume to surface area. So quite a very large available absorptive surface area. And the one important improvement is that it's got an excellent biocompatibility. So there is not much of activation of your coagulation factors, not much of disturbance of your blood cells. There may not be severe metabolic complications unlike the first generation resins. So in that way it is too good. Basically it is importance were given to the coating of the membranes by the help of collard albumin, so modified polyvinyl acetate or modified polyvinylamide. So these are all the coating materials that help to improve the blood compatibility. It also improves the anticoagulation properties of the membranes. It also reduces the damage to the blood components. So these are the basic principles of hemoadsorption. Lies between the adsorbent as well as your adsorptive material. So whenever a solute has got a low volume of distribution and less lipid soluble and more hydrophobic and high protein bound, tends to stay in the vascular compartment. So the removal should be very easy. If it is in water soluble and it's got a low water protein bound or low protein bound and has got a high volume of distribution, it may be very difficult to remove it. So in that case you can rely upon this hemoadsorption for better removal. If you have a less lipophilic solute or a more hydrophobic in nature with high protein bound, and molecular weight, we can adjust the type of resin based on the molecular weight of the toxins or the substance you want to remove. So basically this is the structure which is telling about the hydrophobic nature as well as hydrophilic nature of the solutes. So hydrophobic natures, if it is more hydrophobic, there is a tendency to have an increased affinity of the adsorbent and the absorptive. And the hydrophilic nature is usually, hydrophobic nature is usually described by the organic ring, that is the benzene ring. Suppose if you have a benzene ring that gives more hydrophobic nature to the solutes. So these are all the drugs that contain the benzene ring, like your morphine, cocaine, dopamine, phenobarbital, diazepam and tetramine is a rodenticide. So these structures have got a benzene ring or an organic ring which tend to put these drugs as the more hydrophobic structures which can be removed very easily by hemoperfusion. Next comes your molecular sieve. The greater the molecular sieve, you have binding of the more and more large molecules as well as middle molecules. So the porosity depends upon the size of the molecular sieve. So we have in the inside we have a lot of cartridges which are available here. We can see the molecular cutoff weight of the cytosorb is somewhere around 60,000 Daltons. So it can bind a very large molecule as equivalent to the size of a albumin. And so also other cartridges like HA130 is the hemoabsorption cartridge used for USRD. The molecular cutoff weight is somewhere around 5,000 to 30,000. And HA230 is used for detoxification, somewhere at 500 to 10,000 Daltons is the molecular cutoff weight. So molecular cutoff weight decides on the usage of what type of resins you want to use. Suppose if you want to remove a large molecular substance, you can go ahead with a membranes which has got a high molecular weight cutoff. And physical absorption has already told that you have van der Waals forces which is causing the absorption of the solute to the sorbent. So this helps in quick absorption. So physical absorption helps in the binding of the solute to the absorption. And electrostatic interaction is also very important because the opposite charges, ions easily get attracted. Suppose if you have a negatively charged center and it tends to bind with more of positive charge anions or positive charge the molecules. So we have BS330 membrane. This is an anion exchange resin which is used for the liver diseases. It is basically an anion exchange resin. So it has a center core of more of positive charges which tends to attract more negatively charged anions. So it is an anion exchange resin which tends to attract your negatively charged anions. So this membrane tries to bind more of bile acid. Bile acid is a negatively charged anion that tends to come and bind to this membrane. That is BS330 is the resin which is used for treatment of acute liver diseases. And this slide tells about the antigen antibody mediated reactions that tends to form some kind of agglutination reaction which is happening on the surface of the sorbent. This is the basis behind the technique called as immunoadsorption, which has been used in many of these conditions like ABO incompatible transplant or even autoimmune diseases treatment. So how do you prescribe a hemoadsorption? Hemoadsorption technique, all you need is a good vascular access and there is a blood pump with which can run from about 100 to even 350 ml per minute, and you need a cartridge which may be of anything. It can be a natural cartridges or the first generation cartridges or newer sorbents, which helps to remove the target molecules and the proper venous line. So this is the basis which is required to have to successfully run a hemoadsorption without the need of any dialysate or without the need of any RO water or without the need of any complex hydraulics. So you have to prescribe the frequency, how many times you need to do, either 2 to 3 times in a day or 2 to 3 times of sessions you require, and suggested duration also has to be specified. Some of the sorbents, they say you should be run only for 2 hours because of the saturation of the sorbents, and some companies give the time duration of about even 24 hours can be run, and the blood flow should be kept between 100 to 350 ml per minute, and anticoagulation you can use heparin or regional citrate anticoagulation provided the patient should not have any tendency to bleed. So these are the indications of hemoadsorption. So traditional indications being toxins, to remove a toxin or a drug overdose, and there are novel expanding indications like it can be used in sepsis and SARS and liver cell failure, particularly a patient with acute fulminant hepatic failure and which you want to bridge it for a hepatic transplantation, you can use these techniques. And patients with COVID-19 in which you have a cytokine storm, you need to remove all the cytokines. So this is a wonderful treatment you can try with. And treatment of certain autoimmune diseases like your SLE with crisis in the form of any CNS lupus, or patients with severe bleeding manifestation, thrombocytopenia, or catastrophic antiphospholipid antibody syndrome, or patients with severe ANCA-associated vasculitis. So all these things you can try with this. And ABO-incompatible renal transplants, this forms one of the important treatment behind the successful ABO-incompatible treatments. You can bind the antibodies before preparing the patient for ABO-incompatible treatment. And of course, there are certain treatment available for even removal of uremic toxins, that is the protein-bound uremic toxins, so which we will be discussing in subsequent slides. So this is the adsorba filter, which is not available nowadays. I think most of the people who are in the previous, like about some 2 to 3 years back, it was freely available. So this is the 300 grams of cartridges. So it has got an excellent absorption spectrum. It can bind both lipophilic drug as well as hydrophilic drugs, hydrophilic toxins. Even you do not know what type of toxin the patient has ingested, you can use this adsorba. So it's got an exterior surface of only 40 meters square, but if you check the inter-surface area, that is the interior surface area, is somewhere around 3 lakhs meters square. So roughly about the what do you call that, the size of nearly around 30 the football grounds. So if you have a 30 football ground, that is the surface area here. One single football ground comes around nearly around 10,000 to 12,000 meters square of surface area. Whereas this has got an interior surface area about 3 lakh meters square. So it's got a very excellent, very good absorption spectrum. You can use whatever type of materials, like if the patient is ingested, either it is the lipophilic drug or hydrophilic drugs, and you do not know what type of toxin, whether the patient has taken it, you can try with this. Usually indicated for patients who, which can be removed by this technique. If the patient has gone into coma, or if the patient has got hypoventilation, or hypotonia, or hypothermia, this is one we can try with. These are all the drugs that can be used in this technique. These drugs can be bound with a very high efficacy, like barbiturates, meprobamate, paraquat, organophosphates, and bromocaromate, and even the phenacetin and salicylates can also be tried. So now it is not available. Previously it was there about 2 to 3 years back. We had used it very freely. Now it is not available by the Gamero. I think probably they want to promote the Oxidus, so that's why they have stopped using it, but it is available outside the Indian countries. So how do you do the priming? Priming you need to do with 500 ml of dextrose first, because there is the inherent risk of developing hypoglycemia. That's why the manufacturers say you should need to prime with 500 ml of dextrose followed by heparinized saline, and usual blood flow is somewhere around 150 to 200 ml per minute, and you can run it for about 4 hours. And you need to terminate it. So usually if you start terminating, you invert it and start with upside down technique, like you need to invert it and then start terminating it. So this is the Gamero cartridges which were available, but now it is not there. The next comes your selective hemoabsorption cartridges called as toramexin. It's polymyxin B based hemoabsorption cartridges. There are two numbers like 20R and 05R is available. Main indication, it is used in gram-negative sepsis. It binds only your endotoxins. It do not bind any other materials. It binds only your endotoxins. So endotoxins are very well bound. So how do you use it? You just connect it to the patient with a good vascular access. The arterial line, it goes to the filter, and the venous line goes back to the patient with monitoring. So the usual running time is somewhere around 2 hours. So you need to give rinsing, proper rinsing with the physiological saline. You can use any type of anticoagulants as usual with other methods, but the blood flow rate is usually kept at lower. So 100 ml per minute for 20 hours and 20 to 40 ml per minute, and usually it cannot be run more than 2 hours because these cartridges get super saturated. That's why you have to run less than 2 hours. There are certain the difference in opinions from various trials. This is the UFAS trial which had shown that there is an improved hemodynamics and lower 28-day mortality and reduce the risk of multi-organ dysfunction, whereas the other trial called as Euphrates trial, this is a North American trial in which they could not find any difference between the control group or test group. However, it showed there are better protection in some group of patients, that some group of patients are benefited with this usage of this drug. And there is one more trial which is still yet not available now. It's the ongoing trial that is called as Tigris trial, which is a multicentric trial. So this treatment is usually done when the patient has got a frank gram-negative sepsis and you want to bind only the endotoxins. It will not bind with any other drugs or it will not bind any other cytokines or other things. So this is the cytosorba hemoabsorption cartridges. This is there in the market for about nearly around 10 or 12 years or so. So it binds to molecules with hydrophobic molecules with the structures about molecular structures about 60,000 Daltons, and it mainly targets your inflammatory mediators, cytokines, albumin-bound substances, and pathogenic toxins. However, there is very less effective removal of your endotoxin. There is not much of removal of your endotoxins. It can bind your inflammatory mediators, and this became very popular during the COVID time. In which when there is a high intensity of cytokine storms were there. So cytosorb was very useful in many of these patients, and there is not much of alteration of your coagulation system or complement system, and there is not much of significant removal of albumin. Of course, there are mild reduction of platelets do occur with this treatment, and the certain antibiotics are also bound to this cytosorb. So you have to adjust the dose of vancomycin and gentamicin whenever this cytosorb is being used. And one of the most consistent effects they could demonstrate is that there is an improvement in hemodynamic status. That is, the requirement of vasopressors are minimalized after using this cytosorb. However, that did not translate into mortality reduction. There are a lot of studies giving very unclear results about the mortality reductions. It can be used as a standalone. So like the other techniques, you can just connect it to a machine. Not even a dialysis machine is required. You just connect it to a machine and just connect it to this, connect this to the cytosorb filter, and then the venous end should be connected to the patient. Or it can also be connected to a, this is the cardiopulmonary bypass circuit. That is during the, what you call like resuscitation of a patient with an ECMO circuit. You can also use that in series with your ECMO circuit. You can also use that. So this is the Indian's perspective recommendation on the expert recommendation on the usage of cytosorb. So there are about some 10 experts from various parts of India. That this is the article which is published in World Journal of Critical Care somewhere in March 2024, and they have given a statement that you can use this cytosorb hemoabsorption as an adjuvant treatment for patients with septic shock to achieve an optimal outcomes. Even the ADQI, that is the acute disease qualitative initiative also, quality initiative also has given a statement that you need not prevent from using the hemoabsorption techniques in patients who are in need. So that means indirectly they recommend the usage of this. That's not direct recommendation is there. So this is about the various cartridges from Jaffran. This is a Chinese company, Jaffran. So in acute liver cell failure, we have two cartridges. One is the anion exchange resin, that is BS330. The other is an macroporous resin, which can bind with other toxins also. In poisoning, HA230 is the cartridge which is available here. In ESRD, we have HA130, For pediatrics, there are HA60 and BS80. And for critical diseases like your sepsis, shock, you can use HA330 or HA380. HA380 is the cartridge which has got a very high maximum molecular weight. It removes whatever molecules we can try with. And there are cartridges which are available for immunological diseases like DNA 230, basically designed for autoimmune diseases. And there are certain equipments also, standalone equipments, which can be used for hemoabsorption. So this is a few words about the hemoabsorption cartridge with HA230, which is mainly targeted for poisoning. It usually has a molecular weight cut off about 500 to 10,000 Daltons. And these are all the various indications, like industrial toxins like 2,4 dinitrophenol can be removed, and rodenticides like tetramine, and the pesticides like your paraquat, OPCs, certain drugs like your the barbiturates, digoxin, carbamazepine, the methotrexate, imipramine, ticagrelor, as well as your rivaroxaban can also be tried with this. So you should start the treatment as quickly as possible. Whenever the patient comes to the hospital, you need to start the treatment as quickly as possible. And treatment time varies for the individual techniques. It's about 2 hours to 8 hours. And you can use about 3 to 5 cartridges for a patient. This is an average treatment cartridge recommendation. And you can use the whatever available anticoagulants, even the low molecular weight heparin or an regional citrate anticoagulation also can be tried. This is the treatment recommendation for HA230 by the manufacturer. For an organophosphate poisoning, they recommend about 6 times of the cartridge usage. That is, you need to do 2 times of hemoadsorption within first 24 hours of admission, and followed by we can repeat it after 3 to 5 days based on the condition of the patient. If the patient has got an AKI, you need to connect with the CRRT, or you can use it in serial with your hemodialysis machines. For a paraquat, you need to run for about 7 times. 3 times should be done within the first 24 hours of admission, and 2 times on the next day, and 1 time on 3 to 4 days. For a mushroom poisoning, that is fatal mushroom poisoning, you need to do a 6 times of hemoabsorption with this. First day it should be 3 times, and second day should be 3 times. That is, every 8 hours you have to run the treatment for about next 48 hours. For bee stings are also sometimes can be more dangerous. We have few case reports of bee stings induced acute interstitial nephritis. Of course, if it is more life-threatening, we can administer this cartridge about 4 times. You need to use every 4th hourly. 4 times you have to use this for bee stings. This is for life-threatening bee stings. And patients who are suspected to have a drug dosage, the usual average usage of this thing is about roughly around 3 times. The first day you need to do 2 times of this usage. I mean, you have to do every 12th hourly, you need to do. And with that, subsequently you reassess the situation and then repeat it if required. This is the aberrant, is a natural poison. Tamil Cholopona, it is called as Pillar Kanun Cholo. You don't have any specific antidote for this. So this poison can be very well removed with the help of hemoabsorption as well as the combination of CRRT. So this is helpful in treating the very fatal aberrant poisoning. This is a small case report of a paraquat poisoning in a pregnant woman who presented very late to the hospital, about 30 hours after the hospital, after ingestion. She was treated with HA230, that is the hemoabsorption cartridge which is used for poisoning. And along with that, they did about nearly around 120 hours of continuous veno-venous hemofiltration. Along with, they also tried the other treatment like cyclophosphamide, methylprednisolone, dexamethasone, and N-acetylcysteine. With that, they could achieve the maternal fetal well-being of the patient, particularly during the hospital. Till the end of pregnancy, they could prolong it. So usually what we had seen is that most of the paraquat poisons, they die within about 4 or 5 days time, or even after 2 weeks time, because of ongoing pulmonary fibrosis. So this is one rare case report in which they have tried to salvage both the fetus as well as they try to save the fetus as well as the mother. Can we combine the hemoabsorption with dialysis? Yes, that is called as coupled plasma filtration and hemoabsorption. You first use a plasma filter, you remove that plasma and then run it through a hemoabsorption cartridges and then return it to the hemodiafiltration cartridge. So you can combine both this, that is the plasma filter as well as hemodye filter combined in series. It is usually indicated for sepsis as well as for acute liver dialysis treatment. However, this did not prove any superior quality of mortality reduction in patients with septic shock. There are certain benefit of in reducing the hospital stay by the usage of this treatment. However, it has got a very complex circuit and there are a lot of clotting issues with the usage of this drug. So we can try the hemoadsorption along with in series with your hemodiafiltration as well as hemofiltration. So this is, I think everybody might be knowing it. This is an Oxyris filter. This is a 3-in-1 cartridge. This is the cartridge which helps the purification of your extracorporeal treatment. It does your diffusion, convection and absorption through a single cartridges. This is an Oxyris cartridge which has got a 3-layer. The first layer is the innermost layer is the heparin, which reduces the thrombogenicity of the cartridges. The second layer is the polyethylenamine. It binds to your endotoxins. It binds to your endotoxin. Apart from that, it also does your fluid removal as well as electrolyte imbalance also being taken care. And the next layer is the AN69 membrane, that is acrylonitrile 69 membrane, which absorbs all your cytokines. So the first one is an heparin layer, reduces the thrombogenicity. The second layer is the polyethylenamine surface, which binds your endotoxin. And third layer is an AN69, it binds all your cytokines. It also removes your the potassium as well as all your uremic solutes. So you have you can have 3-in-1 treatment, like you can take care of your uremic solutes, you can take care of your fluid control, you can improve your inflammatory molecular system. You can remove your inflammatory mediators like IL-6 or IL-8. It also does your endotoxin removal. So in that way, it helps to reduce your cytokine load in patients with critical illness. Small studies have shown a very great improvement in short-term mortality, like your 7 days and 28-day mortality, the length of hospital stay, your SOFA score, and improvement in vasopressor dose have been demonstrated in very small number of studies. But there is no difference in 90-day mortality or ICU mortality or hospital day mortality. There is not much of difference. But this does all the three processes like diffusion, convection, absorption in single cartridges. So in that way, it is more useful in patients who are very sick, extremely sick with high cytokine loads as well as endotoxemia. Is there any filter to bind the bacteria as well as virus? Yes, that is called as syrup 100 microbind affinity filter. This was used in COVID times, still in use. It directly binds your bacteria and viruses. It does not bind any of your toxins. It does not bind any of your cytokines. It just binds your bacteria and toxins. The main indication was in COVID, proven case of COVID-19 with ALI or ARDS or life-threatening disease. You can run this. Usually done with a 24 hours duration. The priming is around, you need to run the blood flow about 100 to 350 ml per minute, and you need to, if you want to repeat, you can repeat it again if required. So this is a standalone treatment in which you can connect it directly to the blood pump, and from the blood pump you can connect the filter that is called as a syrup microbind affinity filter, and the venous end goes to the patient after the venous chamber. You can also serially connect it with the dialyzer if the patient has got an acute kidney injury. You can also connect it with a dialyzer if there is a patient with the AKI with a lot of other metabolic derangements too. So this is called as double plasma molecular adsorption system. So this is something different from your MARS. MARS is molecular adsorption system. So this is something different from your double plasma molecular adsorption system. So in which the blood is run through a plasma filter. You remove the plasma, and that the plasma is run through two kinds of sorbents. One is BS330, that is the anion exchange resin. The next is an HA330, that is the macroporous resin, which binds the other substances like your mercaptans, phenols, inflammatory mediators. The anion exchange resins usually binds only the bilirubin and bile acids. This tends to improve your short-term outcomes in patients with acute liver cell failure. This is considered to be a bridge to hepatic transplantation. This is a video telling about the usage of the BS330 as well as HA330 in series. These two cartridges are connected in series. We have a plasma filter which is separating the plasma, and this is run through another machine in series. You have the BS330 which is binding only the bile acids and bile bilirubin, and subsequently then the next of the plasma is also run through HA330, that is the macroporous resin, which binds the other molecules like your inflammatory mediators, mercaptans, phenols, and all the other the solutes, which helps in temporary improvement of the patient condition. So by the time you can prepare the patient for hepatic transplantation. These are all the other blood purification system which is available for liver cell failure, because this itself is a very big topic. I am not telling about in detail with the other things, like usual method is a single pass albumin dialysis or a molecular absorption system, fractionated plasma separation, absorption and dialysis, plasma absorption and perfusion, and this is the coupled plasma filtration absorption system. So these are all the various other blood purification therapy which are available for the treatment of liver cell failure. The next comes your immunoabsorption. We have two immunoabsorption columns. So one is the Axopac, which is a Russian company. It can be reused. You need to regenerate the cartridges every time after the treatment. So you can use up to 20 times. And the next is a Glycosorb. This is from Sweden company, which has been widely available here in our India. And you can run the session for, this is a single-use cartridge. You have to run it for about 1 to 5 hours, and can be tried even in wide variety of age groups, even in children as well as up to people with more than 100 kg. Next comes your Immunosorba. This is the cartridge which is used for patients with catastrophic antiphospholipid antibody syndrome, or patient with severe SLE, with myasthenic crisis, or sometimes even vasculitis. You can try with this Immunosorba. So next comes your cartridges for ESRD patients. ESRD patients, you do not remove the protein-bound uremic toxins, because these are all left behind the hemodialysis. Hemodialysis will remove basically your low molecular weight toxins, water-soluble toxins. So your protein-bound uremic toxins are very well removed with this usage of this HA130, and middle molecules like beta-2 microglobulin, parathyroid, leptin, and IL-6 are also removed. So when you use this HA130 along with hemodialysis, there is some amount of improvement in quality of life. It reduces your pruritus, it improves your PTH levels, it reduces the risk of developing beta-2 microglobulin amyloidosis, and it also has very great improvement in hemoglobin levels, and sexual functions also do improve. So this translates into the improvement in quality of life, and also there are much improvement in sleep. The quality of sleep also improves in patients with chronic kidney disease. So you have improvement in sleep as well as improvement in your increase in nocturnal melatonin levels when this technique is used for about 1 to 2 times per week for about 2 years. However, whether it is translating into the improvement in survival is a very big question. So it is nothing but you need to serially connect it with a hemodialysis filter. So from that arterial line, you need to first connect it to HA130 cartridges and then connect it to a hemodialysis filter. So this is another which is there, another filter which is also available here, that is cellulose acetate functionalist graphene oxide beads for removal of your uremic solutes. So this may be somewhat quite cheaper also. This is the slide which is telling about the removal of the solutes. The uremic toxins are classified as water soluble like your urea and creatinine, and protein bound are like paracresol or homocysteine. The middle molecules like your parathyroid, leptin, IL-6 are somewhere between 10,000 to 500 to 25,000 Daltons, and large molecular weight toxins like your advanced glycosan end products or the lambda free light chains are somewhere around with molecular weight of more than 25,000. Kidney transplantation does all these three, like removal of all your toxins. That is excellent. When you combine with the low flux dialysis usually removes only your water soluble low molecular weight toxins, but does not take care of your middle molecules or molecular weight, higher molecular weight toxins. So when you bind a hemo absorption cartridge with the low flux dialysis, you can tend to normalize removal of all the toxins. So also high flux dialysis, you have removal of your small molecular weight toxins as well as middle molecular weight toxins. When you combine with the hemo absorption, there is a tendency to remove all your protein bound toxins. When you do an online HDF, there also occurs, there is removal of your protein bound toxins with hemo absorption. So in patients with ESRD, when you use this HA130 adsorption cartridge, however, you can improve the quality of life by removing your protein bound toxins. Whether that is translating in approval of survival is still a question. There are other potential uses of this hemoabsorption cartridges, like you can try with emergency surgeries. Suppose a patient who is on ticagrelor, or a patient is on novel anticoagulants, oral anticoagulants, you want to take the patient for emergency surgery, you can do a hemoabsorption for about 2 to 3 hours, remove these molecules and then take for emergency surgeries. And you can also try with children's, in children with septic shock and patients with cast nephropathy, hemoabsorption may improve their renal recovery. And it can also be tried with, in patients with high dose of methotrexate poisoning with an AKA. In nutshell, we have a cartridge in which the blood is run through. So what are the disadvantages and advantages? Advantages is that we have new membranes with excellent coating and with very good biocompatibility. It will not activate any one of your immune system. It will not activate your complements. So in that way it is more advantageous. Can be tried in series with other extracorporeal treatment. It can also selectively, it can be used to selectively target the toxins, whatever, like for example, you want to bind endotoxin, if you want to bind the cytokines, if you want to bind the entire, all three inflammatory cascades as well as the other things, you want to control the diffusion of your uremic solutes, all can be taken care with the help of this 3-in-1 toxins like Oxidis, 3-in-1 cartridges like Oxidis. So it's got a very good removal of your middle molecules as well as protein bound toxins. However, this got a very major concern is that there are no clear-cut guidelines on the usage of this, the therapies, like how many times you need to use, how many cartridges you need to put, or whether it has got a improvement in mortality of the patient. So all these guidelines are lacking behind. We need a lot of research work to tell about these information in future. And of course, it's got a very high cost. It cannot be available in many of the center. And the very important problem we face is the saturation of the cartridge. So the cost of one cartridge comes around somewhere around some 60 to 70,000. You need to use about 2 to 3 times. A single patient means nearly around 2 lakh rupees the patient has to spend. So the cost is quite high, and we can try with these various conditions what we have already discussed. Is there any hemoabsorption for animals? Yes, it is there. It is available in US. For beloved pets, this is by the name called as Vet Rescue. For veterinary usage, this is only available in usage. This is from the makers of Cytosorb. They have just applied the principles of Cytosorb in rescuing the veterinary, particularly your pets. These are all the indications like accidental toxin injections, crush injuries following and car accidents, MOTS and multi-organ dysfunction and heat strokes. So there are about 3 cartridges are available for. So even the pets also, they are also given the privileges in some of the countries like US. You can use hemoabsorption cartridges for your beloved pets. So I've come to my last part of the topic. Like I would like to summarize that there is very great advancement in the newer, in the synthesis of newer membrane with excellent coating. Newer, the sorbents are available, which has got a very good biocompatibility, and it will not affect any of your immune system or your blood cells. It helps its way in finding the newer indications in the field of medicines. However, we need a lot of research into this, usage of these molecules, usage of these cartridges, and there should be a clear consensus guidelines on how to use, how many we have to change, and all these guidelines has to be published soon after various lot of research works. And we are lacking behind a magic bullet in patients with sepsis, like a magic bullet to restore your immune system, particularly when the patient is very sick, is still required. Thank you.
Thank you, Dr. Ariel Naval, for sharing your expertise on this cutting-edge topic. Let's give him another round of applause. Time for some questions. Please raise your hand if you have any questions for Doctor.
No more more questions? No questions. Yes, yes. Mike, can you give the mic? Mic.
Is it compatible for hemodynamically unstable patient also? Filtration, double filtration adsorption, no?
Double filtration?
Adsorption is compatible for hemodynamically unstable patients like CRRT and all will do for hemodynamically unstable patient
No, we
only.
cannot use it for hemodynamically. You are telling about the coupled plasma filtration.
Because too much blood volume will be outside.
Yes, yes.
It's
For
not
hemodynamically unstable patients, it's not possible.
possible.
Only patients with hemodynamically stable you can use that.
The perfusion which we do with BS 330 and all, is it compatible?
Perfusion for BS 330, yeah.
It is compatible.
Yes, it's compatible.
Thank
right,
you.
yeah. Yes.
Especially you have been, I will ask two questions. HA 130 you told, no sir. How frequently we can do for the patients who are strongly indicated for that? Another question is, when you use all these type of extracorporeal therapies, do you also suggest the use of cryoprecipitate or something at the end of the session to replace its constituents?
Yes, sir. So when coming to the first question, like if you want to, your first question is like how far you use it, HA 130 in patients with ESRD.
Yes, sir.
So, like roughly you need to use it once or twice in a week for about 2 years.
Okay.
So that is the treatment they have recommended, like not recommended, they have studied actually. There's one study which had taken place for about 2 years. They have done 1 or 2 sessions in a week in patient who is routinely doing a hemodialysis. In that way it has improved the quality of life by reducing all the...
You have seen improvement in the vascular compliance.
I don't have any personal experience with HA 130, sir. Maybe in future we'll be using it. Anything else, sir?
Another question I asked is about the use of cryoprecipitates or something.
Yes, sir. If you expect to have a bleeding manifestation, this will be more in patients with the usage of conventional, like your the adsorb or this thing. Whereas the newer sorbents, they do not much alter your the coagulation system at all. In cytosorb, there is transient reduction of platelets have been had been described. Whereas in the newer sorbents, they do not have much of any alteration of your coagulation system. There might not be much of bleeding. Whereas in patients with who are been on adsorba, like so what traditionally being used, in that cases you can use cryoprecipitate at the end of treatment, provided the patient has got any significant amount of bleeding diagnosis.
Thank you, sir. Hello, கொஞ்சம் யாரும் பேசாம கேளுங்க. நாங்க தான் டயாலிசிஸ் இண்டஸ்ட்ரியில ரொம்ப வருஷமா இருந்து என்னமோ ஹோட்டல் சாப்பாடு செய்றவங்க அவங்களே சாப்பிட்டுக்கிற மாதிரி நாலேஜை வளர்க்குறோமே தவிர இவ்வளோ பேர் வந்து உங்க ஃபியூச்சருக்கு நீங்க என்ன பண்ண போறீங்க இதெல்லாம் இப்படி வந்து அட்டன் பண்ணிட்டு எதுவுமே கேட்காம நீங்க பஸ்ஸாம பேசிட்டு இருந்தீங்கன்னா எந்த மீனிங்குமே இல்லை. ஜஸ்ட் ஏதோ ஒரு கேதரிங் மாதிரி ஒரு பெரிய டாக்டர் வந்து பேசுறாரு, என்ன அட்லீஸ்ட் டிஸ்கஸ் பண்றாங்கன்னா தெரியுமா? இப்ப இருக்கிறது நம்ம 2024, another 10 yearsல எப்படி இருக்க போகுது ஃபீல்டு, அதுக்கு ஏற்ற மாதிரி ஆர் வி எக்யூப்பிங் அவர் செல்ஸ்? கொஞ்சம் ப்ளீஸ் யோசனை பண்ணி இதை நல்லபடியாக அட்டென்ட் பண்ணுங்க. தேங்க்யூ சார்.
தேங்க்யூ.
I am inviting Mr. Y. Arokya Das, Joint Secretary, SDTP, will now honor Dr. Erin Nalavan with a token of our appreciation.
Thank you, sir. Our next session is another panel discussion, this time on troubleshooting in hemodialysis. Moderating this discussion is Dr. M. Ram Prabhakar, Senior Consult and Head Department of Nephrology at SIMS. Please welcome Dr. Ram Prabhakar and our esteemed panelist, Dr. Satyan S., Consultant Nephrology at SIMS, Dr. Jay Nivas J., Consult Nephrology at SIMS. Let's give them a warm round of applause.
Good afternoon. At the outset, I thank on behalf of my co-chairs the opportunity given by Dialysis Technologist and Paramedical Association. I think last year also we did a panel discussion. This time it's a different topic, so we will try to make it interesting at the same time. At the interest of the time, we'll be going a little faster. So, yeah, as you all know, hemodialysis is not something new, like what Dr. Elilnavan has presented about hemoperfusion. This is the age-old topic that has been done for close to 70, 80 years. The first human hemodialysis was done in 1945. Since then, there is quite a bit of technological advancements. I still remember my age-old days, 20 years before. We used to run in the hemodialysis room with every patient vomiting, somebody is having low blood pressure, all sorts of complications. We have evolved from there, but still the numbers still quite high. If you look at the published data, the incidence is close to 10 to 30%. As dialysis professionals, it is very important to have eternal vigil. This is the way we keep telling our staff members to be very, very careful, because at times it may land up in losing a patient. The problem is the complication resulting morbidity, mortality, hospitalization, big hypotension, you can lose the access, and it can result in hospitalization, so the overall cost of care becomes very high. So that's why we more focus on forums like this to increase the awareness about complications and how to handle them. So the troubleshooting is basically divided to patient related and machine related. For want of time, we will be more focusing on patient related complications today. We'll be focusing on the common complications, what we see in day-to-day life, low and high blood pressure, chest pain and so on. For want of time, we are not able to cover the machine-related complications. If you provide one more opportunity, maybe in a year or two, we may handle the machine-related complications. With that overview, we will start with the first complication, which is commonly seen in our population, about intradialytic hypotension. So my first question to Dr. Satyan is, how to define intradialytic hypotension, how common is it, and what are the risk factors?
Yeah, thank you, sir. Intradialytic hypotension is, a patient is considered to have intradialytic hypotension if the systolic blood pressure falls by more than 20 millimeters of mercury, or if the mean blood pressure falls by more than 10 millimeters of mercury. The fall in blood pressure alone is not enough. It should be accompanied by symptoms for the patient, or it might be accompanied by an intervention required for controlling the fall in blood pressure. In another study, it has been found that the intradialytic systolic blood pressure less than 90 has been found to be associated with worse clinical outcomes. So that can also be considered as a definition for the presence of intradialytic hypotension. It is a commonest complication among patients undergoing dialysis. It has been found to be varying according to various definitions from about 5 to 30% of dialysis complications. Dialysis patients have the intradialytic hypotension during dialysis. The risk factors, it is seen more commonly in elderly people. In women, it is more common than men. In people who are undergoing a long duration of several years of dialysis, the long dialysis vintage, they have a higher incidence. Patients with diabetes, those who already have a low blood pressure at the start of dialysis itself, they are at higher risk of getting intradialytic hypotension. People with low albumin and low nutritional status, and those who have a high body mass index. So these are all some of the common predisposing factors or risk factors for the occurrence of intradialytic hypotension.
So it is important to understand that there is no universally accepted definition of intradialytic hypotension. Many times the professional societies have given you guidelines like when to define it. It is important to note that the most accepted definition is the K-Doki definition, which we still use when there is fall in systolic blood pressure more than 20 or MAP more than 10. So this fall is called the other one is studied in large scale clinical studies where they looked at systolic blood pressure fall less than 90. So these two are the most important definitions of intradialytic hypotension. So moving on from defining to managing the problem, the question to Dr. Nivas is how to manage an acute hypotension during dialysis.
Good afternoon. Thank you, sir. So like we just saw, this is one of the most common problem that you are going to encounter in your day-to-day dialysis. One of the first things that you have to do is to identify a patient with hypotension, because many times when we set the BP measurements and machine, we keep it at even 15 minutes once or 30 minutes once even in stable patients. So between the readings, there is a possibility that you will miss a patient developing hypotension. So it requires your shrewdness to identify that the patient is going in for hypotension, because they do not present with classical symptoms always. Most of the times they will just present with a vacant stare, sudden reduction in the responsiveness, or vague discomfort. So it may not be a classical symptom always. But then the moment you identify that the patient has hypotension, ensure that you go through all these steps immediately. So I would like to suggest you to do 2 steps simultaneously immediately. So the first thing is positioning the patient. You put him in something called as the Trendelenburg position, which is nothing but the head and low and the feet up, let's say by 15 to 30 degrees. The moment you put this simultaneously, you will have to switch off the ultrafiltration as well, because the most common cause for hypotension is excessive fluid removal. So the moment you put the patient in Trendelenburg position and you switch off the ultrafiltration, so what happens is the venous return to the heart increases, you are not removing further fluid, so that per se will start stabilizing the patient. Along with that, you move on to the second step, which is in giving the fluid. So you give a fluid bolus of, let's say, around 100 to 200 ml as you continue to observe the BP. If the first set of fluid replacement is not improving the BP, you can even go ahead with the second time. But however, there is no specific limits or how many times you have to give fluid or how much you have to do. There is no clear-cut guidelines. Let's say we usually give a maximum of even up to 500 ml of saline generally. But at that time also, if the patient's blood pressure is not improving, then we are dealing with something more sinister. It is at that time we have to seek help of the acute critical care personnel as well.
So it is important to understand that there are various fluids that are used in dialysis. I have seen in our own unit that over and over use of hypertonic glucose. We need to understand there is generally these 3 are the solutions that are used. We use isotonic saline or 0.9% saline, hypertonic glucose or albumin. There is no advantage of one over another, but generally we can stop with 0.9% saline. So the third question is about how to prevent hypotension, because it is very important to prevent rather than to treat, because by the time if they develop significant hypotension, you may lose the access or the patient may develop other complications. So how to prevent recurrent episodes is the question to Dr. Satyan.
Yes, we have a lot of patients who have repeated episodes of hypotension during dialysis, giving us the opportunity to do something to prevent this from happening in the first place. The first thing is a patient who is going into repeated hypotensions, probably we are going below the dry weight of the patient. So we must have to reassess the dry weight of the patient. This reassessment most often is done on a clinical basis, clinical assessment of the volume status. there are sometimes machines are also available to reassess the dry weight, like crash kit monitoring, blood volume monitoring, using the ultrasound of for the lung and the IVC diameter. The maximum ultrafiltration rate that we might be exceeding the ultrafiltration limit of the patient. So the maximum recommended is 15 ml per kg per hour. So if you are keeping a high ultrafiltration rate, reducing the ultrafiltration rate per hour might improve, decreasing the chance of hypotension. But this might, if the patient is coming with high weight gain, we may need to extend the dialysis time or increase the frequency if we are able to achieve this for a particular patient. Yeah, this another common thing that we see in our dialysis patients is most of them come, once they start dialysis, they start taking their food. So that can also be prevented in the patients who are, especially patients who are prone to develop hypotension. So it's because most of the blood is diverted to the splanchnic circulation, which will be a reason for hypotension. So preventing this in those who have hypotension is important. Yeah, for patients who develop hypotension, it is important to ask them not to take their antihypertensive drugs at before the start of dialysis. But for many other patients who might require to continue to take the antihypertensive drugs, it's not applying for everyone, but for patients who develop hypotension, we should ask them not to take antihypertensive drugs before dialysis. Yeah, asking the patient to limit the salt intake in between dialysis limits the weight gain of the patient, and so we require a lower ultrafiltration volume in dialysis. So a lower ultrafiltration volume might translate into the lesser chance of hypotension. Yeah, we must also be reviewing our dialysate composition. If you are using acetate, which is not done most often now, we must convert the acetate to bicarbonate based dialysis. If you are using a very low sodium, you might have to increase the dialysate sodium. A very low calcium as well as a very low magnesium also is also a risk factor for hypotension. So we must be going at a calcium level more than 2.2 milliequivalents and a magnesium of more than 1.2 milliequivalents to prevent hypotension. So the second line approach to prevent intradialytic hypotension. One is if the patient continues to have hypotension, the patient might be having a cardiac problem. It might be heart failure, obstructive cardiac disease or valvular heart disease or cardiac arrhythmias or pericardial effusion. So these things need to be assessed, and they may need to be corrected if the patient is developing repeated hypotensive episodes. The use of a cool dialysate. So we can go up to 35 degrees centigrades of the dialysis solution temperature. So that has been found to be translating into higher blood pressure for the patient. But the patient might have some discomfort in the form of chills or rigors. Or if the patient is able to tolerate, we can go up to 35 degrees centigrades of dialysate temperature. The third line approach, we might be using midodrine 2.5 to 5 milligrams at least about 15 to 30 minutes before the start of dialysis, and if required, the dose may need to be repeated in the middle of dialysis to prevent hypotension. But it might cause piloerection, urinary retention, and it might also lead to supine hypertension in some patients. It might also cause paresthesia and pruritus. The last thing is changing the mode of dialysis. Suppose if patient is doing thrice weekly dialysis, we might be doing daily nocturnal hemodialysis or changing the patient to hemodiafiltration, or if possible converting to peritoneal dialysis, which has a very low chance of developing hypotension. A correction of anemia is one very important factor that can be done in addition to all the other measures to prevent hypotension. A combination of sodium and ultrafiltration profiling can be tried. There have been several drugs that have been tried, but like something like sertraline can be given for a period of 6 to 12 weeks to prevent hypotension. Carnitine is also tried to prevent hypotension.
Okay, so it is the most important point from the dialysis technician's point of view is the limiting ultrafiltration. So people should understand that there is something called plasma refill rate. As you remove fluid from your body, the fluid comes from the interstitial compartment back into the blood volume. So that refill rate is the one, if you remove in excess, the patient will end up in low plasma volume and hypotension. So please ask your patient, whenever patients come and ask to remove more and more and more, you should educate them about value of limiting ultrafiltration to 15 ml per kg per hour. So don't do too much of removal in a single session and land up in a complication. And I also want to highlight on two important things in hypotension that has come recently. What antihypertensive drug use is associated with lesser hypotension. So people, whenever we go for rounds, they keep on asking, what is the antihypertensive drug that is preferred in dialysis patients? We continue to use calcium channel blockers more and more. This is because compared to the other group of drugs, calcium channel blockers have relatively less incidence of intradialytic hypotension. That is why we use this particular drugs more and more. So that is the message I am giving. The second important point which we need to understand is, we cannot give a blanket advice of stopping antihypertensive drugs for everyone. This is the reason for high incidence of intradialytic hypertension in our population. From seeing more intradialytic hypotension, nowadays we are seeing more intradialytic hypertension. So it is very important to understand, for people only with recurrent intradialytic hypotension, you recommend them to avoid antihypertensive drug. For people, for other people, there is no advantage whatsoever of stopping antihypertensive drug prior to the dialysis procedure. So please don't do it. That will be the single most important message I am giving. I hope somebody is at least listening here. So there is a data which is called take-hold study, which compared patients taking antihypertensive drug and undergoing dialysis versus stopping. They have clearly documented that there is no statistical difference in incidence of hypotension in people taking and stopping the drug. This doesn't apply to people who are known to have intradialytic hypotension. So routinely do not ask them to stop antihypertensive drug. Identify the patients who develop repeated intradialytic hypotension. Only for them you ask them to avoid antihypertensive drugs. So that is the most important message of the entire panel discussion. The next talk is about intradialytic hypertension, about its prevalence and mechanisms.
So to go on with this is just the exact opposite of what we have discussed so far. So there is one group of patients, let's say even 10 to 20% is the prevalence of this. This group of patients develop high blood pressure during the dialysis. It's the exact opposite of what we have discussed so much in detail. So that is called as interdialytic or intradialytic hypertension. Just like IDH, hypotension, here also there are no clear-cut guidelines or definition, but generally we go by the first one. A rise in a systolic blood pressure of more than 10 is considered to be, or it is used to define an interdialytic hypertension. Of course, there are other definitions as well. In terms of mean arterial pressure, if the pressure goes up by 15 mm, it is considered to be intradialytic hypertension. Or in general, for any practical purpose, if a patient's blood pressure goes up from the baseline, from the initiation of the dialysis, if the blood pressure goes above that, then we can call it as an intradialytic hypertension. Now, why are we worried about it is because of two reasons. Remember, any patient who has a hypotension is also a problem. On the other hand, hypertension also becomes a problem because these patients tend to develop some other kind of complications. They can develop some cardiac event, and more importantly, with heparin inflow, they can go on to develop a stroke, an intracerebral hemorrhage, or some seizure or something. So again, a very, very critical thing that we have to monitor and we have to adjust. So the thing is, why does this intradialytic hypertension occur? Again, there are so many reasons. Remember, the most common phenomenon is the volume status of the individuals and the drug usage that Sir just mentioned. So let me begin with the volume status. Whether the patient is overvolumic or hypervolumic, or the patient is hypovolemic, both the scenarios can cause a patient's blood pressure to go up during dialysis. Paradoxically, like if you look into the last one, when a patient is too volume depleted, too dry, and we keep on trying to remove the fluid, they tend to have sympathetic overactivity. So sympathetic overactivity triggers a rise in the blood pressure, and that can manifest during dialysis as interdialytic hypertension. On the other hand, a patient who is chronically volume overloaded, they always tend to have a high blood pressure even during dialysis because of the changes in the blood compartment volumes. The second most important cause is the one that Sir discussed. That is because of our regular practice, like advising all the patients to avoid the blood pressure medications before the start of dialysis. That is something that you have to note down today and you have to change. Here there is no one size fits all. Always advise the patient in general to go ahead and take the antihypertensive medications. Identify the patients who have tendency to develop low BP, and it is only those patients who should not take the BP medications. Apart from that, there are other reasons. Even administration of erythropoietin during dialysis can cause a high blood pressure as well. Of course, there are other theoretical reasons, activation of endothelial system, renin-angiotensin system, all of this. But remember, it is the sodium content of the patient that determines how high a blood pressure is. So always adjust the dialysate sodium, keep it appropriate for every individual patient, and also advise them to take the appropriate medications that would prevent the intradialytic hypertension.
So from recognizing and identifying the risk factors and mechanisms, we will move on to the treatment of intradialytic hypertension.
Treatment, the most important aspect would be to reassess the dry weight. Most often these patients might be at higher body weight, and so they may require a reduction in their dry weight. The administration of diuretics might also increase the urine output of the patient, and that might help in bringing down the dry weight of the patient. Most of these patients might, optimal treatment of hypertension, we may need to increase the dose of the antihypertensive drugs, and most of them might require more than a single antihypertensive drug to control their hypertension. So emphasizing them to take the antihypertensive drugs before dialysis would also be important, not to skip the antihypertensive medications. Usage of appropriate antihypertensives, like most often calcium channel blockers are not removed by dialysis, and there are some beta blockers also which are not removed by dialysis. So use of these drugs that are not removed by dialysis would be helping them to control the intradialytic hypertension. Extending the duration of dialysis treatment, this might facilitate more removal of volume, and so this might, because as volume overload is the most common cause for intradialytic hypertension, more removal of fluid will bring down the blood pressure. Considering use of a non-dialysable beta blocker like carvedilol, which is not removed by dialysis, compared to metoprolol or atenolol, carvedilol might be helpful in preventing intradialytic hypertension. If despite all these measures the patient continues to have intradialytic hypertension, we can give a short-acting antihypertensive agent just prior to the dialysis session like hydralazine, or sometimes in resistant or refractory patients, minoxidil is also tried to prevent intradialytic hypertension.
So two important drugs we need to remember in treating intradialytic hypertension. The largest data is from beta blockers. Though we use calcium channel blockers, the largest data is from beta blockers. That too, you have to choose non-dialysable beta blocker. Okay? Even as Sir said, atenolol is fully dialysable, metoprolol is partially dialysable, whereas carvedilol is not dialysed. And the additional data is there in the recent years that people who are prone to get hypertension during dialysis, if they get single shot of hydralazine 30 minutes before dialysis starts, this reduces the incidence of interdialytic hypertensive episodes. So we should use probably this drug more nowadays.
So we must be choosing an antihypertensive drug which is less dialysable, like carvedilol or calcium channel blockers. Lowering the dialysate sodium is an important aspect, so that removes the sodium from the patient into the dialysis fluid. So thereby removal of sodium will also bring down the blood pressure of the patient. High calcium in the dialysis fluid is also another cause for intradialytic hypertension. So if there is a feasibility of having a low calcium dialysate, we must use it. We have been using a low temperature to prevent hypotension. So in a patient who is having hypertension, we can consider a high temperature. So, but we must, a very high temperature can lead to hemolysis. So generally not beyond 37 or 37.5 degrees centigrade. Erythropoietin, if the patient is, if his hemoglobin is more than 13, we must stop, or considering a subcutaneous route of erythropoietin might also prevent hypertension.
So the next complication we routinely see is the chest pain during dialysis. What to do in case somebody suddenly develops chest pain in dialysis, and how to go about.
Okay, this is something very, very important, because it can be either a very trivial gastritis, just a peptic ulcer disease, and it could be nothing, or on the other end of the spectrum, it could be any of this life-threatening condition. Unfortunately, in our patients, most of them will have some vague discomfort. They tend to call epigastric pain as chest discomfort or burning sensations or anything. So we have to be shrewd enough to identify a cardiac-related chest pain from a non-cardiac chest pain. Remember, the typical cardiac chest pain is retrosternal, and it tends to radiate to the arm, but in dialysis patients it might not present like that, it can be atypical. So we should have a high index of suspicion. So we need to be understanding the history of our patients, whether previously he has had such episodes, previous his pain and everything, and the associated symptoms. Like if the patient is having breathlessness, if he's having any sweating, and all those things will help us to identify the real cause for the chest pain. The first among that is the most common one, or the most important one I would say, because it can be a life-threatening one. Patient can collapse immediately during dialysis as well, because already we are putting some stress on the heart by doing a dialysis as well. And also remember there are other causes like air embolism, dialysis reactions, which we'll be discussing subsequently. They can also present with chest pain. So we need to have all these things in mind whenever a patient complains of chest pain. We should not simply blame it on a mere gastritis and we just end up giving some injection pan or Rantac. We should always have a high index of suspicion that any of these can present with a chest pain in a patient. And let's say if a patient, you're attending to a patient and you feel the patient has a cardiac chest pain, if he's having some kind of coronary syndrome, so what should you do? So these are all the steps that you should do. Immediately observe the vitals of the patient. Ensure that the patient is comfortable, his vitals, his blood pressure, pulse and saturation is normal. And if you cut off the ultrafiltration, bring down the blood flow rate if the dialysis is still ongoing. If the patient, and you also examine the circuit for the other reasons that we mentioned. It could be a hemolysis, so you look for port vein appearance. It could be an air embolism, so you look for foam or any air collection in the venous chamber. So you have a broad mind. You see it could be anything. So ensure that you are covering all the aspects. And if you feel it is cardiac chest pain, most of the units have the capacity to do an ECG simultaneously. So put the patient and immediately go for an ECG on the table itself. And always compare the ECG with the previous ECG, because most of our patients come back, so you always compare it with the previous ECG. And if you feel there is any alternative changes or new changes, immediately seek medical help. And most often in the same settings, the other blood investigation should also be taken. If you are suspecting an acute coronary syndrome, ensure that an ABG or a top levels or even CBC and everything is done in the same setting. So basically what we are trying to say is the chest pain can be as trivial as a gastritis or it can be as severe as an acute coronary syndrome. So you need to have a broad vision. Just try to identify if it is a cardiac chest pain, and if you feel if it is cardiac chest pain, ensure that the patient has stable vitals and put the patient into taking an ECG.
So the next probably unrecognized complication in many sudden deaths in the units is the air embolism. What is this and how to recognize it?
Air can enter the systemic circulation through the dialysis axis and the machine related and the lines. It commonly enters from the connection of the arterial port to the patient's to the dialysis lines. It can be through a cracked dialysis catheter or an uncapped dialysis catheter left inadvertently, or it can happen at any of the venous connection points of the circuit. It is usually seen along the arterial lines of the circuit. Inadequate or incomplete priming of the circuit is another common cause for the occurrence of air embolism. But nowadays this complication has been decreased to a big extent because of the newer dialysis machines, greatly by means of air detector in the venous circuit or the venous chamber of the air. That prevents air embolism to a big circuit, but we must be making sure that it is kept in the machine and it is not kept outside. The prevention of air embolism can be done by these three measures. One is by keeping the arterial lever lock adequately tightened, adequately priming the hemodialysis circuit with appropriate saline volumes, and maintaining a high level of blood in the venous air catcher can prevent air embolism to a big extent. It is the four possible entry of air in the dialysis circuit. It is most often seen in the arterial side of the dialysis circuit. One, it can be connecting from the patient connection from the catheter to the dialysis line. That would be number one side. Number two, anywhere from the arterial connection to the blood pump. And number three, it can be happening from the heparin connection point. And then it can happen anywhere along the dialyzer also if it is not properly tightened. So it is most often seen in the arterial line.
How to treat a suspected air embolism?
Luckily, the advancements in the protective mechanisms in the machines have reduced this incidence of this very, very sinister complication. But in case if you end up developing one, remember it is a life-threatening one. The patient can collapse within minutes, just like a heart attack or an acute coronary syndrome. So if you are suspecting an air embolism, let's say there is some bubbles in the venous chamber and the patient is developing dyspnea and patient is collapsing in front of you and you're suspecting air embolism, the first thing that you should do is to discontinue dialysis. Because if you continue the dialysis, there is some leakage through which more air is entering into the circulation. The higher the volume of air that enters the circulation, more is going to be the complications for the patient. And as soon as you identify and discontinue the dialysis, as well as clamp the venous line, give 100% oxygen by face mask to increase the oxygenation of the patient. And you have to put the patient specifically in left lateral position with the leg, with the heads down and the leg up. So this is a very logical thing to do. Remember, air will get accumulated as per gravity, and we do not want the air to enter into the brain or to remain in the pulmonary circulation. So we are okay if the air enters into the body and if it's at the other end, at the leg end. So what we do, you put the patient on the left side and in the Trendelenburg position so that the air bubbles, whichever has entered the systemic circulation, gets traveled or moved away from the heart and from the brain. It reaches the extremities to the end of the legs. On the other hand, if in case the patient is in seated position or recumbent position, ensure that they are not in that position. So this will be the symptoms that the patient will develop. If the patient is in sitting position, the air will climb up by gravity and it will reach the cerebral circulation, so the patient can have seizures, blurry vision, altered sensorium, they can develop stroke and so on. On the other hand, if the patient is just in a recumbent, supine position, the air can enter into the pulmonary circulation. It's more like a pulmonary embolism now. So the patient can develop chest pain, he can develop worsening of the chest pain and tachypnea and hypotension. So ensure that the patient is not in this position. So you put the patient in left lateral position with the Trendelenburg one. So the head up, and so that the air is away from the heart and the brain.
Okay. So the next complication we commonly come across is the muscle cramp. We will discuss a bit about what causes it and how to manage it.
It is another common complication next to hypotension. It is a prolonged involuntary muscle contraction is called as a muscle cramp, as we all know. It is most often due to excessive or rapid ultrafiltration and plasma volume contraction. It could also be due to excessive or rapid removal of plasma uremic toxins and osmolytes. Tissue hypoxia is one important cause for muscle cramps, and hypomagnesemia, hypokalemia and other electrolyte shifts are also contributing to the incidence of hemodialysis associated cramps.
Coming to how to prevent and treat muscle cramps in dialysis.
So though it is relatively a benign complication, but what you would have seen is patient winching in pain whenever they develop cramps. It's like they have lost their life. That severe is a pain when a patient develops muscle cramps. So what do you do immediately? It's again because of rapid removal of fluid and reduction in the plasma osmolarity. So immediately you cut off the ultrafiltration and just help the patient with passive stretching, whichever muscle has gone into cramp. So they will not be able to move because of the extreme pain. So what we have to do is passive exercising. And if your patient is hypotensive, because remember it is not just the fluid which causes cramps, so it is a change in the osmolarity. So always fluid need not be given. But if the blood pressure is also on the lower side, if you feel the patient is hypotensive, yes, fluid administration is going to help. Otherwise, solutions which will increase the osmolarity are the ones that is going to help you. So that is why we immediately generally give dextrose, 25% dextrose along with saline or without saline. And of course, mannitol is also something that has been advised for this scenario, but in general we don't use. We feel it is nephrotoxic and it is not easily available to us. What is commonly available in our dialysis unit is dextrose and saline. And of course, carnitine, either parenterally or oral administration, also helps to treat the cramps. The other spectrum is to prevent the cramps from occurring. So what we have to do is we have to adjust the dry weight of the patient previously. We have to ensure that the patient is not made too dry or too hypovolemic. And we also have to ensure that the rate of fluid removal is not that high. So that way we can prevent the cramp as well. And there are other anecdotal use of giving gabapentin, amitriptyline, vitamin C supplements, all can prevent the development of cramps. But however, the proper method to reduce the advent of cramps is by using sodium modeling. We do know that we can change the level of sodium at different hours of dialysis. That is one way that has been shown to reduce the incidence of cramps. But unfortunately, we have to monitor it very, very closely, because if we do not monitor and keep the profiling proper, there is always a chance that the patient can develop net sodium balance, which can trigger other complications. So if we are able to do it properly, yes, sodium profiling will help in reducing the incidence of cramps. But for that, intradialytic exercises, drugs, carnitine supplementations can also prevent the incidence of cramps.
So there is a tendency among dialysis staff is overuse of carnitine. So the data on carnitine is very limited. The most important steps still reducing or stopping ultrafiltration, passive stretching and fluids. These three are the first three steps. If these doesn't help only, the role of carnitine comes. There are people who even start the dialysis by giving carnitine. So that should have been avoided. Coming to the last topic is about dialyzer reactions. What are dialyzer reactions and how to?
Dialyzer reactions, they refer to an abnormal sequel resulting from interaction between the blood of the patient and the hemodialysis membrane. There are two types of reaction, type A, which is a more sinister reaction, and type B, which is not so very problematic. They are grouped under, where they were previously grouped under the term first use syndrome because they primarily occurred with the new dialysis and they were not so common with the second or third time when they were used for dialysis process. The type A reaction is seen immediately. Sometimes it can be delayed for up to immediately when the blood is returned to the patient, or sometimes it can occur even up to 30 minutes after dialysis sessions. It is most often due to substances that are leached from the dialyzer into the patient. It could be involved, it could be ethylene oxide, which is used for sterilization process. It could be a bacterial endotoxin or bacteremia or some bacteria that are improperly cleaned before the dialysis, before cleaning the dialysis. From the dialysis it can enter the patient. Sometimes bleach you use for reprocessing, it removes all the proteinaceous substances that are bound in the dialysis membrane. So this can lead to increased incidence of dialyzer reactions. Or some patients who are using AC inhibitors, if they are exposed to AN69 membranes, which are most often seen with high flux or CRRT, for which are dialysis which are used for purpose of CRRT, this can also be a cause for a type A reaction. The next, the symptoms, it could be mild or it can be severe. Mild reactions could be in the form of itching, burning sensation, urticaria, flushing, cough, sneezing or wheezing. Severe reactions could be in the form of hypotension, dyspnea, shock, or sometimes patient might even develop a cardiac arrest. The type B reaction, which is more common and less severe type of reaction, which is seen in about 3 to 5% of patients. The incidence of type B reactions happens after 30 minutes of dialysis, and it gradually, despite continuing dialysis, it improves gradually. Whereas in type A reaction, we need to stop the dialysis and do not return the blood to the patient. Whereas type B reaction, if we suspect, we can continue doing dialysis. This is mediated by complement because the free hydroxyl group in the dialyzer membrane interacts with the complement, and this leads to activation of alternate complement pathway causing type B reaction.
Coming to how to treat the dialyzer reaction.
Yeah, so basically, for all practical purposes, remember, if a patient on dialysis develops some kind of reaction immediately after dialysis, it is type A. In general, if they develop after say or 30 minutes or an hour into dialysis, you can take it as type B. The most important reason why we have to differentiate this is the management differs for both. And type A is very severe, and if you continue to dialyze a patient, he is going to collapse. So if it is a type A reaction, what you need to do immediately is to stop the dialysis and not return the blood. Whatever blood is in the, even if it is going to be a waste, you should not return it, because the return of the blood is going to further aggravate the reaction. So that's a very important point. And along with that, depending upon the severity, it could be either mild or it could be severe, as just like sir mentioned. So minor ones will generally settle with just giving an avil, some antihistamine or something. But on the other hand, life-threatening, if the patient develops some angioedema or laryngeal edema, you might even have to give steroids, adrenaline, and he might even need inotropic supports in the form of adrenaline or noradrenaline. So the best one is to prevent. So always the dialysis should be properly rinsed, proper sterilization measures should be taken, and in general, reuse of dialyzer prevents these reactions. And antihistamines and steroids should always be kept in place. The history should be noted if a patient has previously developed a type A reaction. So that much needs to be noted definitely. On the other hand, type B reaction is a relatively benign one. It generally occurs, let's say, 30 minutes or 1 hour into the dialysis, and it can be conservatively managed, and even you can continue the dialysis. One of the ways to prevent the type B reaction is to reuse dialysis, because as sir mentioned, it is predominantly mediated by hydroxyl groups and complement. By reusing the dialyzer, we can avoid that. But of late, we are using more biocompatible membranes. With the use of biocompatible membranes, the incidence of both type B as well as type A reactions are significantly coming down.
So there are major problems that happens in dialysis unit is acute breathing difficulty. So the last two questions are about acute dyspnea at entry and during dialysis. First we will take up acute dyspnea at entry.
Yeah, the patient who is dyspneic before start of dialysis, so we must first look for danger signs. One, the patient might be having hypoxemia which does not improve despite giving supplemental oxygen. So that patient, we must be more careful. He might require additional form of respiratory support, or if the patient is having hypotension, or in some way the patient is hemodynamically unstable. So these are all the patients who may not be able to, who we may not be able to manage in the dialysis unit. These patients, we might have to shift them to the emergency unit or the ICU for appropriate management. The most common cause of dyspnea at the start of dialysis is, most often it is fluid overload. So adequate dialysis and adequate removal of ultrafiltration or adequate fluid removal improves the symptoms of these patients. So if you are able to, this patient is having mild hypoxia, improving with oxygen therapy, we can start and initiate dialysis. Adequate ultrafiltration will be able to alleviate dyspnea in most of these patients. If the patient is having high blood pressure, giving antihypertensive drugs might also improve the symptoms of this patient. We must also be aware of other possibilities apart from fluid overload. It could be coronary artery disease. So the patient might be having chest pain or hypotension, which implies the patient is having a probable coronary artery disease. Or if the patient is having high fever, or if there is evidence, if we have an ABG showing an acidosis, so it might be because of sepsis also. So especially in the patient who is having a temporary or a permanent dialysis catheter, sepsis is also a possibility for dyspnea before start of dialysis. If the patient is stable, we can continue doing good ultrafiltration, which will improve the dyspnea in most of these patients.
So this is another situation that comes in. Patient comes walking into the HD room comfortably. After starting dialysis, suddenly having breathing difficulty. This is where the attenders will come and alert you that I have come walking down and developed acute dyspnea. So what are the causes and how to manage it?
This is a head scratching problem. Anytime when patient comes normally and during procedure patient develops any complication, we always become answerable. But then the most of the causes are ones that we have already discussed. Remember, these are the reasons, and most important I would say is the intradialytic hypertension. So whenever a patient develops high blood pressure, there is always a chance that he can develop breathing difficulty. But also remember all the causes that we have discussed priorly, all the complications. Let's say a patient is developing a new onset coronary syndrome. So the moment you put the patient in dialysis, we are increasing the load on the heart. So the patient walks in normally, but once you start the dialysis, there is a stress in the heart that can precipitate an ACS and patient can develop dyspnea. So keep that in mind. And the rare complications that we discussed, the allergic reactions, the air embolism, intravascular hemolysis. Look for change in the color of the blood in the tubings. And all of these can cause or present as breathlessness as well. So if the patient, along with breathlessness, if he is developing hypoxia also, so you are connecting the patient to a saturation probe, and if you feel that the patient is becoming hypoxemic, then you are dealing with something life-threatening. So immediately seek critical care people's help and ensure that the patient's hemodynamics are maintained. Depending upon that, decide on whether to continue dialysis or the patient has to be shifted to a critical care unit.
So I think we have given whatever we can in the 45 minutes. I think we have stuck to the time. Now the final part is, if you have any particular questions, if you have time, we can take it. Otherwise, we can dive even during the lunch hours. With that, thank you so much for the opportunity on behalf of my co-chairs. Oh, you are asking questions. I think should be the last.
Mic testing. Sir, nowadays some centers starting dialysis at 4 a.m.
4 a.m.
early in the morning.
Yes.
So to accommodate more sessions probably, big corporate centers. Is it advisable? One more question, sir. And some patients are taking food during dialysis. When the dialysis started, in the middle of the dialysis, they are taking dialysis. Is it advisable?
So about the first, I think we are in an era where dialysis is now done not only in hospitals, even in the standalone centers. I don't think per se there is any particular time that is advantageous. Then you might say, like marriage, people will ask for auspicious hours.
Yeah.
We cannot look for auspicious hours and all. I don't think there is a problem. Only thing is, if you are starting early into the dialysis, the staff should be adequately trained and enough number should be there. The problem in a unit like ours is the problem. We have the night duty staff which are less in number, and you have the first shift patients who are working in huge number. There is the problem that comes in. So we always say, try to hold on at least till 5:30, so the morning staff comes in, or there can be an overlap of morning staff in the morning hours. Other than that, there is no problem with the timing. Regarding food in dialysis, there are two problems that can come in with food in dialysis, which we have seen. One is the people who are prone to develop hypotension can develop hypotension if they consume food during dialysis. May be beneficial for people who develop hypertension because food may reduce their hypertensive episode. The second part, most important part, is the infection control. Problem is how far we can provide them hygienic food, how they handle it during dialysis, and the leftovers left alone in the unit, who is going to clear it off? That is another problem. The third problem, which I am sorry to make here, is the bribing of the food to the technicians. That is another problem we are facing. Everybody, patients think they are doing a favor by handing over the food which they get to the staff, and think that this is like a compliment to them. That culture we should not encourage. That is what my personal opinion about food in dialysis. So I will always stick to something like a high tea or a small kind of short snack during dialysis than a full course meal.
Yes, sir. In Singapore, we have seen those who have worked in Singapore, we know that all the patients who are coming for dialysis come with the food only. When they come in inside the center.
Best option.
That's what, sir. But in India, after the dialysis only, they used to take food. That is happening. But early morning dialysis,
the corporate culture, it is considered as a hospitality. You are supposed to provide hospitality to patients.
Yes, sir. 4 a.m., is it possible, suppose patient coming for dialysis, if they have a full stomach, is it good? Or if they are coming in the empty stomach, how it affects the...
There is no way, I mean, food as such, whether they have it or have not, doesn't have any major impact on dialysis. It's all about patient preference only. Some people who develop hypoglycemia, we tell them to eat, that's all.
Okay, sir. Thank you very much, sir.
So I told, see, one solution doesn't fit everyone. If the person is a habitual hypertensive or a hypotensive is what you need to identify. If the person is a habitual hypotensive fellow, you have to tell them not to eat during dialysis, avoid antihypertensive drugs. If he is a habitual hypertensive individual, it is better to give all the antihypertensive drug, encourage them to eat. In fact, I have shown one among the papers which you showed, even advise them to take a short-acting antihypertensive drugs 30 minutes before start of dialysis session, so that the incidence of intradialytic hypertension goes down.
Sir, good noon, sir. Sir, regarding this sodium profiling, so we can use it for to prevent intradialytic hypotension and also intradialytic hypertension, I think so. Why it is still challengeable for our dialysis technology people to implement and also follow that kind of technological prescription?
So this you should ask your own colleagues, man. We don't say no to sodium profiling. You have to teach your staff more and make them more of comfortable using it.
But the outcomes are to be faced by our nephrologist only, no. So even though the implementation goes wrong or the patient had any other complication due to that kind of prescription, finally our nephrologist have to handle it, sir. So what kind of challenges or what kind of barriers we have to go through or we have to come across?
Theory-wise, literature says that it definitely helps. Practically, implementing for individual patient is the difficulty here because we are outnumbered. If we have enough number of technicians and patient volume is correct, we can definitely do an ultrafiltration profiling or sodium profiling for that matter, depending upon the individual patient. But here for the ease, most often it is for the ease that we generally do not change, even dialysate sodium prescriptions, we do not, even on the profiling, just the adjustment of overall dialysate sodium even, we don't do it for patients, every patient independently. It's again, it becomes a practical problem in implementing it because you have to check it, you have to keep changing it for every patient, you have to change the settings in the machine. I think it is because of the convenience for our purpose, we are not implementing it. If it is implementable, definitely it is advisable. Yes. No, but if we have identified a patient and if you feel that this patient profiling is working and we have the staff support, definitely we can implement it and go on.
Excuse me, sir. Good afternoon, sir. So my question is about post-dialysis dizziness and drowsiness experienced by patients. Post-dialysis session, patient experiencing giddiness problem for over a period of 30 minutes. Is there any special intervention required for that, or is it a common problem?
One is, most often you don't ask the patient to immediately get up and go out of the dialysis unit immediately after finishing dialysis. You advise them to be in the bed, in those patients especially who are developing post-dialysis giddiness or dizziness after standing position. So you ask them to lie down for 10 minutes at least before they start to get up and move around. Another thing is we might be going below the dry weight. There might be a reassessment of the dry weight should be done in these patients. They might require to revise the dry weight to a slightly higher dry weight might be required. You can also give, if they are feeling depleted and nutritionally washed out, we can give a supplement to improve their, they might be having other complications like hypotension, hypoglycemia might be present. It might be even orthostatic hypotension. When they stand up, they might be developing a low blood pressure. We must, in those patients, we must be checking the standing BP also in these patients. There are several other causes. The patient might also be having an underlying cardiac problem also, which is predisposing to, if all the simple measures does not lead to an improvement or does not change the outcome, we must be looking at cardiac status also. Autonomic neuropathy is very common among these patients. So that might also be one very common reason for post-dialysis hypotension or giddiness or fatigue.
Does ultrafiltration profiling helps with this post-dialysis?
Yes, it might help. Sodium profiling is, we start with high dialysate sodium and we end with a lower sodium. So, it is the average sodium over that period that is more important. So if you are going at the high sodium, if the average is still high, then we are giving more sodium load and more fluid for the patient. Even sodium profiling at the end, we go with the low dialysate sodium. So it may, the problem might still persist also. It is different for each and every patient.
Thank you, sir. Now I am inviting Dr. D. Dagjeeshwaran, Principal and Professor at Savita College of Allied Health Science and Advisor SDTP, to honor our moderator and panelist. It's now time for lunch. Enjoy your meals. Welcome back. Next, we have a panel discussion on assessment of nutrition status in HD patients. Moderating this session, Dr. Manish Lalwani, along with his panelists, Dr. Ankit Jain, Dr. B. Divakar, Dr. T. Jayaprakash, Assistant Professors at Christian Medical College, Vellore. Please join me in welcoming them to the stage.
Good afternoon, everybody. We'll be starting the post-lunch session. The session will be on nutrition assessment in kidney diseases. So as we know that undernutrition or overnutrition affects every step. It affects the patient going into CKD, a patient who has already gone into CKD. Undernutrition and overnutrition affects the progression of CKD, as well as it increases the complications of kidney dialysis and the patient, kidney disease and the patients on hemodialysis. The first step to solve a problem is identifying it. So the problem is identified by nutritional assessment, and that is the today's topic. We will be starting with Dr. Ankit telling us about the dietary and anthropometry, and Dr. Jayaprakash about the body composition and laboratory absorption. So these two faculties will be talking about the ABCD of the nutritional assessment: anthropometry, biochemical assessment, composite body indices, and dietary assessment. So this ABCD will be discussed by Dr. Ankit and Jayaprakash, and Dr. Divakar will throw light on the special situations encountered. Off to you, Dr. Ankit.
Good afternoon, everyone. How I can see? Okay. Good afternoon, everyone. First of all, thank you SDTPCON for giving us the opportunity to speak on this platform. I know this is a post-lunch session, little bit difficult, but we promise that we will be fast and we will be very precise. Starting why nutrition is important. So initially we have to understand what is protein energy wasting. Protein energy wasting is defined as a pathological state where there is a continuous disease, decrease or wasting of both protein deposit and energy reserves, including a loss of fat and muscles. So there are, before that there were so many terms like malnutrition, undernourishment, cachexia. These all terms have been included, and we have given a new term, protein energy wasting, which means there is a decrease in muscle mass as well as fat loss also is there. So it is a single pathological condition in which purely nutritional disease converges with catabolic conditions. That means there is deficiency in the nutrition in intake of the patient, and there is something going on in the body of the patient so that there is breakdown of the muscles and other things are happening. Second thing, why it is important to know. As a dialysis therapist, you must have a question ki why we are discussing this thing in this conference. So we come to what are the significance of protein energy fasting. It has been seen that patients who are undernourished or having protein energy malnutrition, they were found to have high mortality. There are so many studies, and it is more of cardiovascular mortality have been found in the patient. It is also been seen that the patient who are undernourished, they develop more risk of infection, and it has been also seen that there is recurrent hospitalization because of the protein energy malnutrition, as well as it causes the decreased quality of life. So it is important to know for our patients that who are in the range of having malnutrition or protein energy fasting. Now we come to the little bit epidemiology. There is no, actually traditionally it has been the widespread prevalence is there. It is somewhat from 18% to 75%. It's because there are multiple studies and multiple races, multiple results and multiple criteria are obtained. But in any single point of time, in any center, you can find this percentage up to 50% in our setup, in our country. So it is different, prevalence is very different in different countries, and it is a reflection of the economic situation, the degree of development and the prevalence of malnutrition in the general population. So it just doesn't depend on the thing that patient is having CKD, but it also depends what is the economic situation of the patient and whether he was malnourished before the advent of the disease. Now we come to what are the causes of protein energy malnutrition in CKD. So first thing, we all know there is decrease in intake and increase in loss of nutrients. What are the causes? One is anorexia. We know all that our patients are anorexic. They have very less appetite. Second thing which increases this thing is the restrictive diet patterns. So much the patients are restricted that this should not be eaten, this should be eaten. So that restrictive diet also increases the chances of protein energy nutrition. And with the dialysis, there is loss of amino acids, and we all know that the blood loss also happens in dialysis, which exacerbate this protein energy fasting in the patient of the CKD. Other than this, there are other things which is increased catabolism. That means there are increased breakdown of muscles in the body. It may be due to, first thing is metabolic acidosis, which we know that which increases the catabolism. There are so many endocrine disorders in the patients of CKD. Hormones which are essential to maintain a proper balance in the body, proper growth, that we see in the CKD. There is insulin resistant, thyroid hormone is less, the decreased testosterone level, all that accumulate to the cause protein energy fasting in the CKD. Third, which is one of the most important reasons, is inflammation and oxidative states. CKD is an inflammatory state, and because of this, there is increase in catabolism. Fourth is the activation of proteolytic system, such as ubiquitin proteasome and caspase system. This is also responsible for the catabolism in the CKD patient. And then accumulation of uremic toxins, and there are so many pro-inflammatory cytokines in the CKD patients which causes increased catabolism and lead to the protein energy fasting like IL-6, TNF-alpha, IL-1 and TGF. Now we come to our topic. Before that, we have discussed what is protein energy malnutrition, why it is important, and what are the causes of this. So how we can know that person is having protein energy malnutrition? I will be taking the nutritional assessment actually. So this is a very simple process. Nutritional assessment consists of dietary assessment, anthropometry, body composition analysis, muscle strength assessment, biochemical parameter, and there are then composite nutritional assessment like subjective global assessment and malnutrition inflammation scores. So I will be discussing dietary assessment and anthropometry. First thing, start with in any patient, we should assess the appetite. So in CKD patient, there is large alteration in the appetite. It is because of the taste is altered, smell is altered, and one more thing which is important, there is so much of pill burden in the patient, which also can cause decrease in appetite. So whenever you are assessing the nutritional assessment, dietary assessment, we should rate the patient appetite accordingly, like it's very good, fair, poor, or very poor. In the children, we can use the picture-based assessment and test if the CKD patient is a child. What we do in this is a 3-day food record or 24-hour food recall. In this, we should include the weekdays and weekends, and on dialysis and non-dialysis days should be included. Before considering the dietary assessment, it's important about what patients know about the diet, what are his beliefs about the diet, whether, I mean, like, so many people have so different beliefs about the food, like this food can cause this problem, this food can cause this problem. They should be known before we make this dietary assessment. His attitude, his behavior, dietary habits, access to the food is another important point we should take in the consideration. And last is the depression. So many CKD patients are clinically found to be depressed, and depression can cause loss of appetite. That should be assessed and should be corrected actually. So nowadays it's very difficult to, I mean, like, if you see what you have eaten in last 3 days, it's very difficult for a patient to tell. So we can use, there are so many various apps are available in the internet. You can use the apps and can tell the patient to feed the apps. So whenever he is taking the meal, he can directly enter whatever diet he has taken in that point of time, and we can have 3 days data. The good thing in these apps is like that these apps provide what is the amount of protein you have taken and what amount of the calories you have taken. So we can have an exact data, an exact approximate data actually for the patient dietary assessment. There are some apps are also there which have the pictures actually. So whatever you are eating, you just take a picture, and then app will give the approximate calorie, approximate protein, and approximate fat and carbohydrate percentage in that food. Some apps can help us in the micronutritional assessment also, so that they can tell what was the amount of zinc, magnesium in this patient. For the requirement purpose, I will tell that in CKD patient requires some 30 to 35 calorie per kilogram. Protein is 1.2 gram per kg requirement. Carbohydrate should be 50 to 60% of the diet, and fat should be 25 to 35% of the diet. So according to these are the criteria for protein, energy, malnutrition. These are International Society of Renal Function and Malnutrition criteria. So according to that, if you find in the diet that protein intake was less than 0.8 kilogram per day, so it can be, patient can develop malnourishment, at risk of malnourishment, or this energy intake is 25 kilocalorie per day for at least 2 months, then they can fall into the category of PEW or PEM. Now we come to the anthropometry. Anthropometry basically means the body measurement we can take in the simply terms. So what are the advantages? It is simple and inexpensive actually. So first we'll talk about the weight actually. Weight, we know actually it is very simple thing to measure, and by that we can assess a patient. What is the disadvantage in that? That weight loss may be masked in patient with edema. So it is more important the body weight change need to be interpreted rather than the absolute weight actually. And what is the frequency? We should check the body weight to monitor at least monthly in dialysis patient. And again, if there is non-intentional weight loss of more than 5% of weight in 3 months or more than 10% in 6 months, then again this is the criteria for protein, energy, malnutrition. Next we come to the BMI. BMI is, as we know, it is a body mass index. It is calculated as a weight upon height of square, which is height in the meters. It assesses both undernutrition and obesity. The problem with the BMI is that it does not differentiate between the muscle mass and fat tissue. According to ISRNM, again, if BMI is less than 23 kilogram per meter square, it may be a criteria for PW, but old criteria for WHO is less than 18 kilogram per meter square. Third thing is we are coming is the skin fold thickness. This is the problem with this is it is operator dependent. So whosoever is taking the skin fold, that value might be different if another person is taking. What are the sites of taking the skin fold thickness are tricep, bicep, subscapular and suprailiac. After taking the skin fold thickness, we can calculate the body fat percentage. So there are so many equations available. One is equation is Dury and Salmon, by which we can calculate the body fat percentage. So what is the use? If body fat percent is less than 10% of body mass, then again it may be a criteria for protein energy wasting in patient with CKD. It has been seen in the studies that this skin fold thickness is correlated with the DEXA and bioimpedance, which are again the method of examining the patient of protein energy malnutrition. So this is the picture which I am showing, that how you can take the skin fold thickness. This patient is, this triceps skin fold thickness is getting calculated in this picture. Second is mid-arm muscle, this mid-arm muscle circumference. This is actually this is a tool used in the children, and in pediatrics it is routinely used. In CKD patient, this is again can be used in the children, but it is not useful in the adults because it doesn't represent the muscle mass in adult, and we know the base. We need to know the baseline measurement is also needed in this. So this is waist hip ratio and chronicity index. This is also our patient, most of our patients are actually undernourished, but obesity is also a kind of malnutrition. So if patient is obese, by this thing we can find out, in which we calculate the waist upon hip ratio. It should be 1, it should not be more than 1. So more than 1 indicates the patient is obese, and chronicity index is again calculated from the waist circumference. There is one formula. Accordingly, we calculate the chronicity index and define the obesity, because obesity also, if like I said, malnutrition, there is increased risk of mortality, and in obesity also, if a patient is having BMI more than 30 kilogram per meter square, again the risk of having morbidity and mortality increases in CKD patient. Now this is the hand grip strength. This is also a method where we can find out the functional status of the patient, and this can correlate with the nutritional state of the patient. This is also very simple and inexpensive. There is one device which is called dynamometer, which is used, and this I will show you this. So this is the dynamometer we use to find out hand grip strength, and again there should be gradual, I mean like progressive checking for the patient, for the same patient, of the hand grip strength, and then we should conclude whether patient is getting malnourishment or his strength is coming down or not. Next we'll come to the composite nutritional indices, which is very important. First is a subjective global assessment. I think my colleague will talk about this, and important is that this tool has been validated in the various study, and one important study, Kenusa study, which is Canada, USA in PD patients. So I will hand over to Jayaprakash.
So for the, Dr. Ankit has spoken on the anthropometry physical examination for the, which is useful in a nutritional assessment. So I'll summarize this, that whenever a patient enters a dialysis, for a dialysis, and he has to undergo nutritional assessment, the basic nutritional assessment can be done by a dialysis technician, which is height, weight, BMI. Other than that, we can go up to hand grip strength and dietary assessment in special situation. In our institute, the dietary assessment is done by the nutritionists. For the tracking of the food recall, apps which he mentions can be used. Our patients usually used pre-food, sometimes they use pre-cooked food measurements. Raw food can also be measured, which is more accurate but more cumbersome for the patient. And a point which is to be remembered, it has to be done on dialysis as well as non-dialysis days. Now, speaking for the laboratory assessment and composite body indices, Dr. Jayaprakash will be taking over.
So good afternoon all. This is a continuation of the previous topic regarding this nutritional assessment. There are 5 components of nutritional assessment. One is that the dietary assessment, then physical examination, which was already covered by Dr. Ankit. So I'm going to cover the remaining 3 parts. Like first thing is a laboratory assessment, then like a composite body mass evaluation, then composite indices actually. So So regarding laboratory assessment, there are many indices are available to assess the nutrition status of the patient, but which is the ideal tool for assessing the nutrition. So what is the characteristics of this tool? The first thing is the ideal tool should predict the outcome, and it should be inexpensive, and it should be easily performed and it should be reproducible. And there should not be any interference with the other factors actually. So these tools should not be interfered by other factors like inflammation or gender or sex or presence of any other comorbid conditions. So ideally there is no ideal tool available at present for like accurately assessing the nutrition of the patient. So coming to the first tool, which is most commonly used in our practice, is the serum albumin. Serum albumin is one of the major component of total proteins in the body, which is produced by the liver. The normal level is above 4 to 6 grams actually per deciliter actually. But any patient with a low serum albumin, we should evaluate them for the presence of any malnutrition or other issues like presence of any inflammation or presence of any other renal issues like causing this protein losing conditions or protein losing GA reasons should be evaluated actually. So in our dialysis patients, this albumin level should be measured at the beginning of at the initiation of dialysis, then it should be measured every monthly to assess the progress of the condition actually. So any patient with serum albumin that is below the normal level should be evaluated for the presence of any underlying malnutrition. So normal cutoff is 4 grams. So if it is below 4 grams during the screening time, so we should do some more, we should evaluate the patient to look for any presence of any other issues. So according to this protein energy wasting criteria, so serum albumin less than 3.8 is considered one of the criteria for diagnosing the protein energy wasting. The limitation of using this serum albumin is that levels can not only decrease in malnutrition, but levels can be altered by presence of other comorbid conditions. It is one of the negative acute phase reactant actually. So in the presence of any inflammation, the levels may be low. So we should consider this when evaluating the patient with malnutrition. And presence of any underlying that primary native kidney disease, whether the patient is having any proteinuric renal disease, they may have low albumin due to the renal problem, not due to the malnutrition. So when evaluating any patient with this suspecting malnutrition with a serum albumin, you have to consider all these factors before making diagnosing them as a protein energy wasting problem. So next tool is serum pre-albumin, also known as transthyretin. It is also a protein produced by the liver, which is one of the indirect measure of a visceral protein pool. So the normal function of transthyretin, it is a thyroid binding protein actually. So the function is to transport thyroid hormones in the body. Though usually this pre-albumin is produced in the liver, but which is normally excreted in the kidneys, and it is extensively metabolized by the kidneys. So whenever the patient is having any renal dysfunction, the excreted proteins will not be, the protein excretion will be affected. So the levels will be increased in the circulation. So it depends on the levels can vary, that accumulated levels can vary, depends on the stage of the renal dysfunction. If the patient is having milder renal dysfunction, the level may not be increased that much, but the patient is reached ESRD, the levels will be very high. So according to this international nutrition guidelines, that lower pre-albumin levels less than 30 milligram per deciliter is considered as one of the criteria to diagnose the protein energy wasting. So the problem with this pre-albumin is it is similar to albumin, the levels can be altered in the presence of inflammation. So it is also levels will be decreased in the presence of inflammation. But compared to serum albumin, this is more sensitive because compared to serum albumin, the half-life is more with the half-life is less actually with this pre-albumin. So next method is the serum cholesterol. Although low serum cholesterol is beneficial in normal population, it is opposite in dialysis patients. Very low serum cholesterol levels is considered as a criteria to diagnose a protein energy wasting. So based on these different studies, it showed that low serum cholesterol is associated with higher mortality in dialysis patients. So any patient with very low serum cholesterol, normal level should be like below 200 actually, but in dialysis patients, if the level is very low, like below 150 and all, we have to evaluate the patient to look for any underlying malnutrition. Next is serum transferrin. It is also a protein produced by the liver. It is iron transferring, and the function is to transfer the iron in the circulation. The low levels of transferrin is also associated with increased risk of mortality in dialysis patients. So next is that creatine, like based on the renal parameters, based on the urea creatine, which we routinely measure all the patients, the serum creatine levels, and serum creatine and creatine index. Normally this creatine is produced by different, like the metabolism, protein metabolism by the muscles, as well as the urea also produced by the metabolism of these proteins actually. So whenever there is a very low level of serum creatine in the presence of like normal dialysis, we have to suspect the patient to look for any underlying malnutrition. That is muscle wasting, we have to suspect actually. Next is that serum urea nitrogen. It is also a product of protein catabolism in the body, but the lower serum urea nitrogen levels are associated with inadequate protein intake or presence of any muscle wasting actually. So the problem with this measuring this serum urea as a marker for this protein energy malnutrition is that the levels can be affected by many factors like presence of dialysis efficiency, or if the patient is already having some residual renal function, the level can be low because of this increased urinary excretion. Next is the protein equivalent of the total nitrogen appearance. It is calculated by adding the, like, it is a difference between the daily nitrogen intake and excretion. That is, intake means by means of like through the dietary proteins actually. So excretion means by means of either urinary nitrogen loss or non-renal nitrogen loss or dialysate protein loss or urinary protein loss. So we have to divide the total protein minus the total protein in the diet minus what all the ways it can be eliminated through the body. So if there is a zero balance means the intake should be equal to that of output. So that means usually in a normal, like normal patients, it should be zero or it should be slightly positive. Whereas if the patient is having malnutrition, there will be a negative nitrogen balance. So other measurements are like a routine measurement of these electrolytes and micronutrient deficiencies. Like any patient with lower phosphorus or lower potassium or presence of any other vitamin deficiencies, B12 deficiency or vitamin D deficiency or presence of any other electrolytes like magnesium deficiency or zinc deficiency can also be associated with, correlates with the patient's malnutrition status. And acid-base status also, and in dialysis patients we should maintain the acid-base status within a particular cutoff. If patient is having severe acidosis and all, that will further worsen the protein catabolism, then leads to this malnutrition. So our target is should keep the bicarbonate level more than 22. So what are the newer markers in the malnutrition? So these are, we do not use routinely in our clinical practice, but these markers are all mainly used to look for the presence of any inflammation. Mainly this like C-reactive protein, interleukin 6 levels, or presence of tumor necrosis factor alpha, or presence like lower levels of fibrinogen, all are associated with increased risk of inflammation. Or elevated interleukin 6, elevated TNF alpha indicates the patient is having like underlying chronic inflammation or acute or chronic inflammation. So another thing is that markers of this protein muscle wasting. One is that lower levels of myostatin reflects patient is having underlying muscle wasting. So other newer markers include like leptin and adiponectin. Elevated levels are associated with increased risk of malnutrition. Next is body composition assessment. Body composition assessment, there are two different methods available, direct methods and indirect methods. Indirect methods, what we are using as anthropometry. So using these anthropometers these are practical, inexpensive, and these can be used in a routine clinical practice and all. And so what are these anthropometric methods? These include this height, weight, BMI, skin fold, and mid-arm circumferences, and use of these technologies like bioelectrical impedance analysis and near infrared methods. So So what is this bioelectrical impedance analysis? This is a non-invasive method to assess the nutritional status, like body composition status of the patient. Like it assesses different components of the body, like presence of how much patient is having this fat mass or fat-free lean body mass, or presence of how much water we can assess through this bioimpedance assay. It can able to differentiate the patient is having malnutrition or presence of any fluid overload. The problem with this bioimpedance assay is that the levels can be altered by presence of the patient's hydration status, and electrolyte imbalances can also alter the result of these bioimpedance assays. So next method is that DEXA. There is a dual energy X-ray or absorptiometry. It is a direct method to assess the nutrition status of the patient. It is considered as a gold standard in assessing the nutrition in CKD patients. But the problem with this method is that it is costly because of it's not available in all places, and it is reduced. The results can be influenced by other factors like hydration also. So final part is that composite nutritional indices. So far we discussed individual parameters actually, what all the tools can be used to assess the nutrition status of the patient. But the problem with these individual parameters is that each parameters can have their own limitations. To overcome those limitations, we combine different parameters to formulate indices, so which can be used to accurately identify the patient with protein energy malnutrition. So these indices can be subjective or objective. So the subjective like indices include subjective global assessment, malnutrition inflammation score, mini nutritional assessment forms, and nutritional risk score. And then objective measurements include GNRIs, PNAs, and CONUT score. So in this is the evaluation of that nutritional indices. The first thing was introduced was that SGA, the subjective global assessment in 1980s. So which later evaluated. Then like malnutrition inflammation score was introduced in 2001 and 2. Then currently this GLIM, it's currently under evaluation. There is currently that what SGA and MIS are recommended by this KDOK for clinical use. Others and all still it's still not validated actually. So subjective global assessment, this was initially developed in 1980s actually, which later it undergoes multiple modifications, then later validated in 1996 as a 7-point scale, which is what currently we are using. So this includes patient's medical history as well as physical examination section. You can see in this chart, this first part is that patient's history. Depends on how much weight change and what diet he took actually, what all the patients, depends on patient's symptoms and patient's functional status and patient's comorbidity status and all. So then last part is the physical examination, which includes patient's loss of the subcutaneous fat or muscle wasting or presence of edema. So total this includes 7 points actually. So if the score is 6 to 7, that is patient is not having any like malnutrition or it is a very mild. If score is like 3 to 5, it is a mild to moderate protein energy wasting. If the score is very low, it is severely malnourished. This is the most widely used method for assessing the subjective nutrition status, and it has a good reproducibility and it correlates strongly with the clinical outcome of the patients. Next is the malnutrition inflammation score. It is almost it is a addition to that this 7-point subjective global assessment. They included that 3 objective parameters also: body mass index, serum albumin, and iron binding capacity. To look for this is to consider the presence of inflammation also, not only like dietary thing, also inflammation also included in this malnutrition inflammation score. So the higher in this total score is like 30. If the score is very high, that indicates patient is having severe malnutrition or severe inflammation. This is a chart like malnutrition inflammation score. This first, till this level, it is the same as the 7-point subjective global assessment. The last 3 points are new in this malnutrition inflammation score. They included this body mass index and serum albumin and serum total binding capacity. So higher the score, more severe the malnutrition. So based on different studies evaluated and showed that like higher the score, they are more associated with increased risk of cardiovascular morbidity and mortality. Next is that GNRI, Geriatric Nutritional Risk Index. Actually, originally it was developed to assess the risk status in elderly patients, but later this was like generalized to other diseases also, including lung diseases and heart failure, respiratory failure, etc. But currently it is also useful in patients in CKD also to assess their prognosis. So these are all the other, this is just a summary of the other scores like prognostic nutritional index, prognostic inflammatory nutritional index, many nutritional assessment, and I'm not going too deep into this. So what are the suggested strategies in CKD patients on dialysis? So what are the methods to use the screening of the patient with malnutrition? So first thing is we have to assess the body weight. These are all the parameters used for screening. One is the body weight. If the patient is having like progressive loss in body weight, like if it is more than 15% over 6 months, then we have to put the patient for like extensive evaluation for malnutrition. The second thing is dietary nutrition intake. If the daily energy intake is less than 25 kilocalorie per kg per day, or daily protein intake is less than 0.8 gram per kg per day, or presence of serum albumin like below 4 gram per deciliter, or serum creatinine which is a very low, or presence of, if the MST score is more than 2, then you have to do extensive evaluation to look for any underlying malnutrition or not. So what are all the extensive assessments? One is the serum pre-albumin. If it is less than 28 milligram per deciliter, it is one of the criteria for protein energy wasting. So like elevated CRP levels or anthropometrics are very much deranged from the cutoff values, or presence of this very low subjective global assessment score or very high MIS score, we have to label them as protein energy wasting. So what is the criteria to diagnose the protein energy wasting? It contains 4 components. One is the serum chemistry, body mass index, and presence of muscle mass, then dietary intake. If the serum albumin is less than 3.8 gram per deciliter, or serum pre-albumin less than 30 milligram per deciliter, or patients with very low cholesterol levels. And regarding body mass index, if the BMI is very low, then we have to consider it label it as a protein energy wasting, or total fat percentage is less than 10%, or presence of muscle mass, if the reduced muscle mass over like more than 5% over 3 months, or over 10% over 6 months, then you have to consider it as protein energy wasting. And regarding the dietary intake, if it is a low daily protein intake less than 0.8 gram per day, or for at least 2 months for dialysis patients, or if it is a very less than 0.6 gram per kg per day in non-dialysis patients for at least 2 months. So in this, at least 3 out of 4 should be positive, and each category should have 1 positive score. So to consider it as to diagnose it as a protein energy wasting. So next, I am going to summarize about the KEDOKI 2020 guidelines regarding the nutritional assessment. First thing is regarding routine nutrition screening. Any patient with a CKD stage above 3 with stage 5 on dialysis or renal transplantation, it is reasonable to consider routine nutrition screening. This is screening. Routine nutrition screening should be done at least biannually with the intent of identifying those at risk of protein energy wasting. Regarding nutrition screening tools, there is a limited evidence to suggest the use of one tool over the others for identifying those at risk of protein energy wasting. That means there is no strict tool that can be used to diagnose them as a protein energy wasting. So if your screening test is showing some abnormalities, next thing is we have to put the patient on this comprehensive nutritional assessment, which includes patient's history of dietary intake and patient's anthropometric measurements and biochemical data and nutrition focused physical findings. So how frequently we have to do this comprehensive nutritional assessment? at least within first 90 days of starting the dialysis, it should be done. Or if the patient, if the patient is not having any other things, so we have to do it annually or whenever the patient is indicated by nutritional screening or provider's referral. Next thing is anthropometric measurements to assess the body composition. In this, first thing is regarding body weight. There are different methods are used for assessing the body weight, like actual body weight, desirable body weight. It all depends on the patient's clinical characteristics. Like adjusted body weights can be used only in obese patients, or water-free body weight can be used in post-dialysis patients. So it all depends on which method you are choosing. It depends on the patient doctor's clinical assessment. And before assessing this body weight and all, you have to assess the nutrition status, that hydration status also. Regarding BMI is not considered as a gold standard method for assessing the body weight, because even the patient is having good BMI, which can be due to fat also, without muscle. So it is very difficult to use BMI as an ideal marker for assessing the nutrition of the patient. Next is the skin fold thickness. This Kedoki recommends assessing the body fat, using the skin fold thickness to assess the body fat in the patients who does not have any other edema. So the problem with this skin fold thickness is that it cannot be used in obese patients. So regarding waist circumference, the KDIGO suggested to assess the abdominal obesity in dialysis patients, but the problem is it has a low reliability over time, and there is no cutoff so far. Regarding the technical devices to assess the body composition, the hand grip strength. The Kedoki suggested this hand grip strength as an indicator for protein energy status and functional status related to muscle mass when the baseline data are available for comparison. If we don't have the baseline data, it is of no use. The limitation of this using this hand grip strength is that it should be used for a longitudinal measurements only. We don't know the accurate cutoff which is considered as significant, or when to measure, whether it's a pre-dialysis or post-dialysis, which is not defined. And this hand grip strength should be used in patients with diabetic nephropathy. Next is the bioelectrical impedance. In any patient on dialysis, this Kedoki suggested multi-frequency bioelectrical impedance to assess the body composition. Ideally, it should be performed at least 30 minutes after the dialysis, because during the dialysis time water will be removed, but that cannot be we have to wait at least 30 minutes post dialysis for the redistribution of the fluids between the compartments. Then only it will give the accurate assessment of body composition. And next is DEXA. Kedoki suggested to use DEXA whenever possible if it is available, because it is a gold standard for assessing the body composition, although it is influenced by some fluid status. So how frequently this BMI and body weight should be assessed actually? If the patient is having the CKD stage 1 to 3, at least annually we have to measure this body weight or BMI. If the patient is stage 4 to 5 or post-transplant patients, at least every 3 months we have to measure. Patients on maintenance hemodialysis, every month we have to measure. Regarding the composite nutritional indices, Kedoki recommends the 7-point subjective global assessment scale as a valid tool to assess the nutritional status. It is also suggested to use MAS score also to assess the nutrition status. The limitation of these scores are, they cannot pick up even if there is a mild change in the nutrition status. If there is a gross changes, then only these scores can pick up. And early stages of CKD cannot be useful. And regarding this MAS scales, cutoff are not validated. Regarding the single biomarker measurements, Kedoki recommends we can use this single biomarker as a tool to assess the nutrition status, but it should not be used alone for assessing the nutrition status. Serum albumin, Kedoki recommends if the levels are very low, it can be used as a criteria to diagnose this malnutrition. Regarding the dietary intake, so before, while analyzing the diet history, we have to consider the following points: what medication he used, patient's knowledge about the diet and behavior, access to food, whether the patient is having any depression, patient's cognitive function, and 3-day food records to be conducted during both dialysis and non-dialysis treatment days as a preferred method to assess the dietary intake. And alternative methods can be used, like 24-hour food recall or food frequency questionnaires or NPCR can be used. But it recommends 3-day food records. So, summary of the topic, it's like nutritional assessment in CKD is very challenging. There is no ideal method available to accurately detect the protein energy malnutrition, and there are limitations and errors should be considered when using the tools. And it's always better to use a combination of indices to predict the malnutrition, and longitudinal measures are recommended to assess the nutrition status of the patient. Thank you.
So, Dr. Jayaprakash has comprehensively covered the laboratory assessment and the body composition indices. I will like to point out two things, that there are the fluid assessment of the patient also is usually is a part of dry weight, but that also is a part of nutritional assessment, and the various modalities like body composition analysis, focus for the nephrologist are also a part of fluid assessment, which won't be covered today. And the recent advances, gut microbiota analysis is also be used in the nutritional assessment of CKD patients, which also is only currently in the research purposes. Off to Dr. Devakar.
Good afternoon, everyone. Already my colleagues have taken most of the time, so I will be little quick in the presentation. Basically, it will be the repetition of the previous discussion. My topic is on acute kidney injury. Previously, now they discussed about CKD. My topic will be on AKI. So the assessment will be the same for both, but why nutrition assessment is important in AKI patients? Because it correlates directly with the mortality, in-hospital both hospital mortality and the morbidity. If the patient is severely malnourished, they have more chances of getting further infections and more chance of getting moribund. So how common is the incidence? So incidence is out of 100 patients, 25 to 60% of all hospital patients with AKI will have malnourishment. Compared to the critical care settings, the incidence is much more. It will be more than 75%. So patients who survive and get discharged also will have poor outcomes. So this will be the repetition why malnourishment is happening, because of the inflammatory state, because of uremic toxins, because of metabolic rearrangement, they will have protein energy wasting. So coming to the classification of AKI, AKI is classified based on the catabolism of the patient into three groups. Group 1 is less severe, group 2 is moderate, and group 3 is severe. It is classified based on the urea nitrogen appearance. That is the difference in urea appearance in the urine and the urea production by the kidney. If it is less gram or less, the patient is in very less catabolic state. It comes in group 1. The causes are mostly it could be nephrotoxins like contrast, and the severity will be mild, and patient will recover with, without any hemodialysis usually. And nutrition for this patient usually can be given as oral. In group 2, the urea nitrogen appearance is 6 to 12 grams. It is little moderate compared to group 1, and causes will be infection. They might need dialysis, but they won't usually need CRRT. They will need only intermittent HD. That is enough. And nutrition wise, they will need both oral and parenteral. Group 3 is most severe. Usually these kind of patient will be in ICU with hypotension requiring mechanical ventilation, inotropes. Usually they will require CRRT, and urea nitrogen appearance for this patient will be more than 12 grams. And group 1 we can again divide into AKI in non-catabolic state and AKI in catabolic state. Non-catabolic state is group 1 and catabolic state is group 2 and 3. Nutritional markers will be same for both AK and CKD, so I will skip this. Actually, in anthropometry, we have to measure in 4 points. Out of the 4, triceps is preferred because it is least affected by edema. Subjective global assessment, it is validated only in CKD patients. You can see the wasting in temporal region and loss of orbital fat in severe malnourishment. Biochemical markers, only difference is albumin level is same, less than 3.8 in both in CKD and AK will have a poor outcome. Prealbumin less than 30 in CKD, in AK it is less than 11. That is only difference. Bioimpedance analysis also already been discussed. So this is a case scenario. This is a 62-year-old lady who is a CKD patient on regular follow-up with a GFR of 14. Her usual weight is 95. Current weight is 95. Her usual weight is 92 to 94. So she is having breathlessness and bilateral pilial edema. His appetite is also very poor. Her appetite is also very poor. So which of the following is the gold standard for body composition assessment in this patient? The answer is DEXA. So why anthropometry is not useful in this patient is her weight is stable because of the edema, not because of adequate nutrition status. So anthropometry will not be useful, and bioimpedance analysis is, will vary based on the hydration status of the patient. So DEXA scan is the gold standard for assessment of in these kind of CKD patients. So these are the goals of nutritional support in AK. Main thing is to prevent the mortality. So ultimately the main thing is to prevent the mortality, to prevent protein energy wasting, to prevent lean body mass, and to support the immunity. The major thing is to prevent the mortality. This is the guidelines. As per guidelines, in AK patient, they will need a daily calorie requirement of 20 to 30 kilocalorie per kg per day. So protein requirement will depend based on the RRT modality they will be undergoing. So in RRT modality hemodialysis, there will be loss of approximately 10 to 13 grams of protein per dialysis session. If you use a high flux dialyzer, it will be 8 gram, and CRT there will be much more. So those patients on CRT will require a protein requirement of 1.7 gram compared to IST patient 1.2 gram per kg per day. This is how we will calculate protein requirement for a patient on RRT. If the patient is not on RRT, we can, for a 70 kg patient, we can give a protein of 42 to 70 gram, that is 0.6 to 1 gram per kg. If the patient is on intermittent hemodialysis, we can give 1.2 to 1.5. If the patient is on CRRT, the protein requirement is 1.7 gram. This has been already discussed. So what is the limitation? Limitation of urine nitrogen appearances, it needs the actual body weight of the patient. The main limitation is we don't have beds which accurately measure the weight of the patient on a daily basis. So this cannot be applied for our patients. Coming to carbohydrate requirement, main thing is to maintain a glucose level of 130 to 180, and we should have to avoid both hypo and hyperglycemia in these patients. And apart from vitamin C and vitamin A, all nutrients will be lost in dialysis. So we have to be careful in supplementing vitamin C and vitamin A. Other than that, all vitamins and micronutrients we have to supplement for dialysis patient. Still, previously, KDK guidelines is for CKD patient. This ESPN guidelines is for AKA and acute and CKD patients. Mostly will be the same for both the group. I will just highlight the important differences. Medical nutrition may be considered in a patient with hospitalization, but it should be provided for any patient who is admitted for more than 48 hours in ICU. So, in malnourished patient, if they are not able to take adequate nutrition, we have to supplement with oral nutritional supplements. So this oral nutritional supplement is not a replacement for a feeding. It is like they have to take their oral feed, and 1 hour after their routine meals, they have to take it, because it can provide up to 10 to 12 kilocalories only. It cannot provide the complete calories for a requirement for a patient. So it is only an additional thing, not a it is the replacement for the nutritional. So these are the commonly available supplements, HP and REN-HP and Nephro-HP. This is high protein for dialysis patient, and similarly we have LP, low protein, that is for non-dialysis patient. And other supplement is intradialytic fluid supplements, that is for those patients who is not tolerating the oral nutrition supplements. We can give a intradialysis nutritional supplements that is very costly. So usually it is not practiced in our centers. To assessment of hand grip, the main difference is hand grip assessment using the dynamometer. The hand grip strength is less than 10 kg at the time of discharge, or it is less than 15 kg 1 month after the discharge. They have more chance of directly correlates with the mortality. Other recommendation is enteral feeding is the best. Even though if the patient is been on parental nutrition, the best feeding is central, followed by parental and enteral. The last one is the total parental nutrition. So parental should be initiated if the patient is taking only less than 70% of the required nutrition. So other things are to avoid hypo and hyperglycemia, and caution to be taken to avoid overfeeding, and reassess periodically and start the oral as early as possible. A few points about pediatric CKD and its nutrition assessment. Only difference is in pediatric it is not a straightforward like height, weight and BMI. It is we have to take in consideration about height for age, and it should be documented as percentile, and height velocity for age should be documented, and weight for age should be documented, and head circumference should be documented, and normalized protein catabolic rate also should be documented. And the frequency of monitoring is much more, that is at least it should be twice as frequently for a pediatric patient as compared to the adults. And child with evidence of polyuria or any evidence of growth delay, the monitoring should be much more. This growth chart shows why the frequency of monitoring should be very frequent in a pediatric patient. As you can see, even if we are documenting the growth and height and weight of the patient monthly, there is a sudden drop in weight of the patient even when we monitor frequently. So if you skip 1 or 2 sessions, the child will have severe malnourishment very quickly. So, and other thing is nutritional deficiency should be treated more aggressively in a pediatric patient, and serum bicarbonate should be at least 22. Not for adults, we can keep at least 20, but for a pediatric patient should be minimum 22, because the bone will be utilized as a buffer, and it will affect the growth of the child if we do not correct the acidosis in this patient. And one more point is we should consider recombinant growth hormone therapy when the patient's child's height is less than 3rd centile for 3 consecutive months, even after correcting the nutritional deficiency. And one more important thing is the calorie recommend for a kid is much more compared to adult. For adult it is 25 to 30 kilocalorie, but for a pediatric it is much more, that is 70 to 120 kilocalorie. Protein requirement will be similar, but only the calorie requirement will be more, and it will decrease once the kid's age is more.
Thank you to all our panelists for your valuable insights. Before we proceed, பின்னாடி உட்காந்துக்கிறவர சத்தம் ரொம்ப ஜாஸ்தியாக இருக்குது. பின்னாடியிலேருந்து சத்தம் ரொம்ப வருது. இங்கே முன்னாடி உட்காந்துருக்கிறவங்களுக்கு ரொம்ப தொந்தரவாக இருக்குது. பேசுகிறவங்களுக்கும் கொஞ்சம் கஷ்டமாக இருக்குதுன்னு நினைக்கிறேன். ஸோ உங்களுக்கு பேசணும் அப்படின்னா வெளியில் போய் பேசுங்க, இல்லாட்டி ஃப்ரண்ட்டில் வந்து உட்காந்துக்கோங்க, கொஞ்சம் கேட்குறதுக்கும் ஈஸியாக இருக்கும். ரொம்ப சத்தமாக இருந்தால் டிஸ்டர்பன்ஸாக இருக்குது முன்னாடி உட்காந்துக்கிறவங்களுக்கு. தேங்க்யூ. So are we ready to take questions from the audience? Yeah. So please raise your hands if you have any questions. I'm inviting Mr. T. Jayasivan, President SDTP, will now honor our moderator and panelists with a token of our appreciation.
We will now have another panel discussion on dry weight, moderated by Professor Dr. V. Balraman from the Institute of Child Health Hospital, Egmore. Joining him on the panel are Dr. D. Shivakumar, Assistant Professor at Rajiv Gandhi Government General Hospital, Madras Medical College, Dr. A. Shanmugasundaram, Assistant Professor at Royapet Kilpak Medical College, and Dr. Sheikh Sultan Alauddin, Assistant Professor at Rajiv Gandhi Government General Hospital, Madras Medical College. Please welcome them with applause.
Hey, the slideshow. Slideshow அங்க போச்சு. Slideshow காணோம். எடுத்துட்டு வச்சு போட்டு பார்ப்போம். Slideshow நான் ஒன்று வரும். Slideshow. இருந்ததை காணோம். இது பண்ணிடுவோமா? அதில் இருக்கா இல்லைண்ணா? அதில்
ஸ்லைட் ஷோ வரதா பாருங்க. இதில் வரல, அந்த ஆப்ஷன் வரல. 5 நிமிஷம் ட்ரை வெயிட். இல்லை இது நடுவில் இருக்குது. இந்த இது எடுக்க முடியும், அம்பர்லா. Good afternoon. Good afternoon. Like ஒரு 10 நிமிஷம் செல்ஃபி எடுக்கிறத நிறுத்தினீங்கன்னா we'll finish and then so just 10 minutes. So first SDTPCON SDTPCON 24க்கு ரொம்ப தேங்க்ஸ். They have invited us. So Dr. Sivakumar is held up. அதனால் அவரோட ஸ்லைடை சேர்த்து நான் தான் ப்ரெசென்ட் பண்ணுறேன். ஸோ ஒரு பேஷண்ட் நார்மலி நமக்கு எதனால டெத் ஆகுறாங்கன்றதை யோசிச்சு பார்த்தீங்கன்னா fluid overload and hyperkalemia. ஸோ இதில் ஒன்று வந்து ஹைப்பர்கலிமியா பற்றி நான் இப்போதைக்கு பேச போகிறதில்ல. fluid overload அப்படிங்கிறது இந்த ட்ரை வெயிட்டை பேஸ் பண்ணி தான் வரும். ஸோ அதனால் ட்ரை வெயிட்னா என்னங்கிறது உங்களுக்கு எல்லாருக்கும் தெரியும். இட்ஸ் கோயிங் டு பி a revision only. புதுசாக நான் எதுவும் சொல்ல போகிறதில்ல. இட் வில் பி a revision of concepts and it may be useful for many of you. So it is the lowest tolerated post dialysis weight where there are no symptoms of hypo இருக்கக்கூடாது, ஹைப்பரோ இருக்கக்கூடாது. It will be an ideal body weight. So இதுதான் வந்து நம்ம ட்ரை வெயிட்னு சொல்கிறோம். ஸோ ட்ரை வெயிட் வந்து என்ன, ஒரு 60 கிலோ ஆள் 42 லிட்டர். இப்போ உங்களுடைய வெயிட் 60 கிலோனா உங்களுடைய வெயிட், உங்களுடைய வாட்டர் வந்து 42 கிலோ இருக்கும். ஸோ வேர் இஸ் திஸ் வாட்டர் டிஸ்ட்ரிபியூட்டட்? ஸோ இதில் வந்து ஒரு 40% வந்து சாலிட், ஒரு 60% வந்து ஃப்ளூயிட். இதில் வந்து 2/3 வந்து இன்ட்ரா செல்லுலர், 1/3 வந்து எக்ஸ்ட்ரா செல்லுலர். இந்த எக்ஸ்ட்ரா செல்லுலர் வந்து பிளாஸ்மாலேயே இருக்கு. இதில் சிம்பிளாக புரிஞ்சுக்கணும்னா உங்கள் கையை தூக்கி பாருங்க. ஸோ ஒரு வெயின் இருக்கா, ஸோ அந்த வெயின் உள்ள இருக்கிறது இன்ட்ரா செல்லுலர், இன்ட்ரா வாஸ்குலர். இடிமா பார்ப்பீங்க நீங்கள், பீடல் எடிமா, கையில் எடிமா பார்த்துருப்பீங்க, அது இன்டர்ஸ்டிஷியல். இது ரெண்டும் சேர்ந்தது தான் எக்ஸ்ட்ரா செல்லுலர். மசில்குள்ள இருக்கிறது இன்ட்ரா செல்லுலர். ஸோ நம்ம எதை மேனிப்புலேட் பண்ணுறோம்? இன்ட்ரா வாஸ்குலர் மட்டும்தான் மேனிப்புலேட் பண்ண முடியும். ஸோ மீனிங் தட் இப்போ லங்ஸை விட்டுருவோம், கேஸ்ட்ரோஇன்டெஸ்டைனல் ட்ராக்டை விட்டுருவோம். கிட்னி ஆகப்பட்டது வேஸ்ட் ப்ராடக்ட் அனுப்புறது மட்டுமல்ல, வாட்டரையும் வெளியில் அனுப்புது. இந்த வாட்டர் எங்கேருந்து வருது? இன்ட்ரா செல்லுலர், உங்கள் மசில் செல்லேருந்து வெளியில் வருது. இன்டர்ஸ்டிஷியல், அந்த பீடல் எடிமா இருக்கு இல்லையா, அங்கே வருது. அங்கிருந்து உங்கள் வெயினுக்குள்ளே போகுது. So we are manipulating only your intravascular compartment. So the water has to move. So இந்த வாட்டரோட மூவ்மெண்ட்ல டெபிசிட் இருக்கு அப்படின்னும் போது ஹைப்போடென்ஷன் வரும். 45 லிட்டர் 50 லிட்டர் அவன் இருந்தா கூட இன்ட்ராசெல்லுலர்ல இருந்து இன்டர்ஸ்டிஷியத்துல இருந்து பிளட் வெசல்குள்ள வரலன்னா அவங்களால அந்த வாட்டர் எடுக்க முடியாது. as simple as that. ஓகே, ஸோ இது வந்து கிட்னின்னு எடுத்துக்கோங்க. இன்னொரு வகையில் சொல்கிறோம், இன்ட்ரா செல்லுலரில் இந்த வாட்டர் எக்ஸ்ட்ரா செல்லுலரில் வருது. எக்ஸ்ட்ரா செல்லுலரில் தான் நம்ம கிட்னி வெளில எடுக்குது. கிட்னியோட வேலையை தான் நம்ம செய்கிறோம். ஸோ இந்த கான்செப்ட் வந்து ட்ரை வெயிட்டுக்கு உங்களுக்கு யூஸ்ஃபுல்லாக இருக்கும். ஸோ என்ன ஆகிடும், யூஓலிமியா இல்லை அப்படின்னா இது ஹைப்போலிமியா இன்க்ரீஸ்டு ரிஸ்க் ஆஃப் டெத், ஹைப்பரோலிமியா இன்க்ரீஸ்டு ரிஸ்க் ஆஃப் டெத். ஹைப்போலிமியா வாட்டர் பத்தலை, ஸோ தே பிரசன்ட் வித் ஹைப்போடென்ஷன். நம்ம தப்பாக கேல்குலேட் பண்ணிட்டோம், அதுக்காக ஃபிஸ்ட்லா போயிடுது. ஆக்சஸ் த்ராம்போசிஸ், கிராஃப்ட் போகுது. கிராஃப்ட் போச்சுன்னா 1.5 லட்ச ரூபாய் அவுட்டு. ஸோ யூனோ அதில் இருக்கக்கூடிய காம்ப்ளிகேஷன்ஸ். கிராம்ப்ஸ் நாளைக்கு வரணுமான்னு யோசிப்போம், வரும்போது சிரிச்சிட்டு வர திட்டிட்டு போவான் நம்மளை. ஸோ அந்த வீட்டுக்கு போய் ஃபட்டிக், ஒரு வேலை செய்கிறவன் வீட்டுக்கு போய் வீட்டில் வேலையே செய்ய முடியல. ஓகே, ஸோ ஹைப்போலிமியா சைடு போனோம்னா இதெல்லாம் பிரச்சனை. ஹைப்பரோலிமியா சைட் போனோம்னா ஹைப்பர் டென்ஷன். சி மைண்ட் யூ திஸ் அபவுட் ஹைப்பர் டென்ஷன். ஹைப்பர் டென்ஷன் நீங்க பார்க்குற ஹைப்பர் டென்ஷன் மட்டும் அல்ல. பிபி 140/90 150/90 அனுப்புறீங்க, அவன் மறுநாள் காலையில் இன்ட்ராசெரிபிரல் எடிமா ஆர் சே இன்ட்ராசெரிபிரல் ஹெமரேஜ் வந்து இறந்து போறான். எதுக்கு? அன்கண்ட்ரோல் ஹைப்பர் டென்ஷன் அட் ஹோம். ஸோ வாட்டர் வந்து வெளியில் நீங்கள் எடுத்தீங்கன்னாலும் இந்த பிபி இஸ் நாட், பிபி வந்து காமிச்சு கொடுக்கல.
பிபி வந்து அதிகமாக இருந்ததுன்னா இன்னும் கொஞ்சம் எடுத்து அனுப்பியிருப்பீங்க நீங்கள், பிபி காமிச்சு கொடுக்கல. ஸோ தி ஹைப்பர் ஆம்புலேட்டரி பிபி, வீட்டில் எவ்வளோ இருக்கு பிபி, தட் பிகம்ஸ் இம்பார்ட்டன்ட். edema always will tell us that it is hyperolemia, dyspnea and fatigue hyperolemia வரும். இன்னொன்று எண்டார்கன் டேமேஜ். சரி, இப்போ நீங்கள் அவருக்கு வந்து 42 லிட்டர் தான் இருக்கணும், 40 லிட்டர் போயிட்டீங்கன்னா என்ன ஆகும்? பிரெயினில் வந்து ஒரு இன்ஃபாக்ட் வரும், அவருக்கு ஒரு ஹெமிபெரசிஸ் வரும். ஒரு சிலருக்கு வந்து வாரத்துக்கு 2 இருப்பாங்க, வாரத்துக்கு 1 இருப்பாங்க. ஃபர்தர் கிட்னி டேமேஜ் ஆனதும் வாரத்துக்கு 2 வாரத்துக்கு 3 போக வேண்டிய கட்டாயத்துக்கு தள்ளப்படுவார். ஸோ நீங்கள் கிரானிக், இது வந்து கிரானிக் ப்ராப்ளம், இதெல்லாம் வந்து அக்யூட் ப்ராப்ளம். ஸோ கிரானிக் ப்ராப்ளத்தில் வந்து ஹார்ட் பார்த்தீங்கன்னா எல்விஹெச் வந்து 4 பட இருந்ததுன்னா அன்கரெக்டபிள், ஹார்ட் டைலேட் ஆகிடுது, ஹார்ட் ஃபெயிலியர் ஆகிடுது. அதோட ரீமாடலிங்னு ஒரு இது இருக்கு, அது விட்டுருவோம் இப்போதைக்கு. ஸோ தெர் இஸ் அ ப்ராப்ளம் வித் ஹார்ட். கான்ஸ்டன்டாக ஹைப்பரோலிமியால இருந்தாருன்னா தெர் வில் பி a ப்ராப்ளம் டு ஹார்ட். ஸோ அதனால நாங்கள் என்ன நம்ம கேட்கணும் டிரைவேட் சம்பந்தமா அப்படின்னா நம்ம என்ன கேட்குறோம், ஸோ நம்ம என்ன பார்க்குறோம், நம்ம என்ன டெஸ்ட் பண்ணுறோம் அப்படிங்கிறத சிம்பிளா ஐ வில் ட்ரை டு சே. ஸோ இதில் வந்து இப்போ பிரீத்திங் டிஃபிகல்ட்டி இருக்கு, காஃப் இருக்கு, எஸ்பெஷலி while lying down. சார் ராத்திரியில் மட்டும் சளி பிடிக்குது சார், இட்ஸ் நாட் சளி, இட் இஸ் பல்மர் எடிமா. ஓகே, the water from the pedal edema, லைக் ஒரு பாட்டில் நீங்க திருப்புறீங்க தலைக்கு வந்துடுது வாட்டர், அந்த மாதிரி அவர் படுக்கும் போது காலில் இருக்க வாட்டர் லங்ஸுக்கு போகுது. ஸோ காஃப் while lying down, பிஎன்டினா என்ன அர்த்தம்னா படுத்துன்னு ஒரு திடீர்னு எழுந்துக்கிறதுக்கு பேர் paroxysmal long term dyspnea. தெரியலன்னா விட்டுருங்க, மூச்சு வாங்குறது அவ்வளவுதான். ஆர்த்தாப்னியானா ஈவன் அட் ரெஸ்ட் உட்காந்து கூட மூச்சு வாங்குது. ஸோ இதுல வந்து உங்களுக்கு எந்த டவுட்டும் இல்லை, இவர் வந்து ஹைப்பரோலிமிக் மூச்சு வாங்கிட்டு இருக்கு, லங்ஸ் ஃபுல்லா ஆயிடுச்சு. ஓகே, ஸோ இது வந்து இன்னொரு ஒரு சட்டில் பாயிண்ட். ஸோ அசைட்டிஸ் வந்து இருக்கு அப்படின்னா there can be 2 reasons. ஒன்று வால்யூம் ஓவர்லோடா இருக்கலாம், இல்லைன்னா அண்டர் டயாலிசிஸ் சீரோசைட்டிஸ், யூரிமிக் சீரோசைட்டிஸ் சொல்றோம் இல்லையா. ஸோ அதனால அசைட்டிஸ் இருந்ததுன்னா ட்ரீட்மெண்ட் ஒன்று வால்யூம் ஓவர்லோடா இருக்கும், அப்படி இல்லைன்னா மோர் டயாலிசிஸ். சம்டைம்ஸ் we say டிரான்ஸ்பிளான்ட் தான் உனக்கு வேற வழி கிடையாது அப்படின்ட்டு. ஸோ இந்த பீடல் எடிமா, லெக் ஸ்வெல்லிங் வந்து எப்படி பார்க்கறது? ஓகே, ஸோ அவங்க இங்க பாருங்க, அந்த ஒரு முட்டி இருக்கு, நீ ஜாயிண்ட் மேலியலஸ் பேரு, முட்டி சுருக்கமா ஒரு போன் பாயிண்ட் ஒன்று இருக்கு, அதுக்கு 5 சென்டிமீட்டர் மேல போட்டு ஓங்கி அழுத்தணும்னு கிடையாது. the idea is to displace the fluid அந்த இடத்துல இருந்து வெளியில அனுப்புக. ஸோ அதுக்கு 30 செகண்ட்ஸுக்கு மாடரேட் பிரஷர் கொடுத்தீங்கன்னா ஒரு சொட்டை விழும். நீங்க நிறைய பேர் பாருங்க இடிமா இல்லம்பாங்க, நல்லா தானே இருக்கு என் காலு அப்படின்ட்டு படுக்க வச்சு காமிச்சீங்கன்னா then they know. So this is how you look for pedal edema. ஸோ ஹைப்போலிமியால வந்து என்ன ஆகும், வீட்டுக்கு போனதும் அவங்களுக்கு வந்து கிராம்ஸ் இஸ் a form of hypovolemia, fatigue at home at work point is a form of hypovolemia. But what is most important, எப்படி வந்து மூச்சு வாங்குதா, வால்யூம் ஓவர்லோடு தான். அந்த மாதிரி ஹைப்போலிமியாக்கு ஏதாவது ஒன்று சொல்லுங்க சார் அப்படின்னா பாஸ்டரல் கிடினஸ் தான். சார் எழுந்து படுத்துன்னு இருக்கும்போது நல்லா இருக்கேன், எழுந்து நடக்கும்போது தலை சுத்துது. ஸோ திஸ் இஸ் பாஸ்டரல் கிடினஸ் மீன்ஸ், அதாவது ஒரு டெஃபினட் சயின்ஸ்னு இருக்கும். இப்போ சே ஃபார் எக்ஸாம்பிள் ஒரு ராக்கெட் கிளம்புறதுக்கு ஒரு டைமிங் கொடுக்குறீங்க 4:17 அப்படின்னு கொடுத்தீங்கன்னா 4:17 கிளம்பிடும் அது. வேறஸ் ஒரு ட்ரெயின் வந்து 4:30 வரும் அப்படின்னீங்கன்னா 4:35 வரும். ஸோ தெர் ஆர் சர்டன் டெஃபினட் ஷுவர் சயின்ஸ், தெர் ஆர் சம் மேபி சயின்ஸ். ஸோ ஷுவர் சயின்ஸை வந்து ஆல்வேஸ் நம்ம வந்து விட்டுறக்கூடாது. வால்யூம் ஓவர்லோடு மூச்சு வாங்குறது ஆர்த்தாப்னியா வந்து ஷுவர் சைன். அந்த மாதிரி பார்ஷியல் கிடினஸ் வந்து ஹைப்போலிமியாக்கு வந்து ஷுவர் சைன். மோர் தேன் 20 millimeters ஆஃப் மெர்க்குரி எழுந்துக்கும் போது தலை சுத்துது, எழுந்து நின்று பிபி பாக்குறீங்க, படுக்க வச்சு பிபி பாக்குறீங்க, 20 சென்டிமீட்டருக்கு மேல ஃபால் இருக்கு அப்படின்னோம்னா ஷுவர் சைன். ஸோ நீங்க தைரியமா வந்து நீங்க ஃப்ளூயிட் எடுக்காம ஒரு அனுப்பலாம். ஸோ ஷுவர் சைனை வந்து விட்டுறாதீங்க. ஸோ இன்னொன்று வந்து நம்ம ஜேவிபி அப்படிங்கிறது டாக்டர் இந்த சட்டில் பாயிண்ட், இங்கே வந்து கட்டிட்டர் போட்டிருப்பாங்க, அதனால பழைய ஸ்கார்ஸ் இருக்கும், அப்போ தெரியாது. ஒருவேளை ஸ்கார்ஸ் இல்லை கிளியரா இருக்கு நெக் அப்படின்னோம்னா இதை பாருங்க. ஓகே, ஸோ ஜேவிபிங்கிறது நார்மலாக தெரியாது, ஒரு 45 டிகிரியில் வச்சா லேசா தெரியும். ஓகே, இதுதான் வந்து இந்த வெயின் இங்கே இருக்கு. ஸோ இங்கே இருக்கு பாருங்க எப்படி. See, it is tortuous distorted vein. இது எக்ஸ்டர்னல் ஜுகுலர் வெயின், பட் பொதுவாக வந்து இப்படி இருக்கும் இருக்கு அப்படின்னா அந்த வெயின்ஸ் வந்து ப்ராமினெண்டா இருக்கு அப்படின்னா வால்யூம் ஓவர்லோட் இருக்கு அப்படின்னு அர்த்தம். அவருக்கு வந்து ஃப்ளூயிட் நீங்க எடுத்து தான் ஆகணும். இன்னொன்று சார் வயிற்று வலிக்குது என்ன பண்றோம், ரான்டடின்
ஜெலிசில் சாப்பிடு, ரேண்டனிம் போடு, ஓமிப்ரசோல், பேண்டப்ரசோல் சாப்பிடு அப்படிங்கிறோம். பட் மோஸ்ட்லி நம்ம பேஷண்ட்ஸுக்கு எல்லாருக்கும் இருக்கிறது லிவர் என்காஜ்மெண்ட். லிவர் பெருசா இருக்கிறதுனால என்ன ஃப்ளூயிட் ஓவர்லோட் இருக்கிறதுனால வரக்கூடிய என்காஜ்மெண்ட். இன்னொன்று வந்து ஹெப்படோஜுகுலர் ரிஃப்ளெக்ஷன் பேர். உங்களுக்கு வந்து அந்த வெயின் வந்து ப்ராமினெண்டா இல்லை. ஸோ இந்த மாதிரி அவர் படுக்க வச்சு 30 செகண்ட்ஸ் அழுத்துங்க. 1 சென்டிமீட்டருக்கு மேலே இந்த வெயின் வந்து ப்ராமினென்ட் ஆகுது, மேலே இங்கே இருக்கிற வெயின் வந்து இங்கே வருது அப்படின்னா இஸ் வால்யூம் ஓவர்லோட். ஓகே, ஸோ இதெல்லாம் வந்து சட்டில் நம்மளே பார்க்கக்கூடியது. இது வந்து உங்க எல்லாருக்கும் தெரிஞ்சது SiO2. SiO2 வந்து 95 to 100% இருக்கணும், 90% வரைக்கும் டாலரபிள். பட் தெர் மே பி அதர் ரீசன்ஸ். யூஸ்வலாக மூச்சு வாங்கிட்டு இருக்காரு, கால் வீங்கி இருக்கு, பிபி அதிகமாக இருக்கு, SiO2 கம்மியாக இருக்கு, தென் இட்ஸ் ஃபைன். பட் சப்போஸ் ஒரு ஃபீவர் இருக்கு அப்படின்னா இட் மே பி பிகாஸ் ஆஃப் நிமோனியா. ஸோ தட் வி நோ. கிரெபிடேஷன்ஸ் வந்து டாக்டர் பார்க்கறது. பட் உங்களுக்கு சிம்பிளாக சொல்லணும் அப்படின்னா கொரகொரன் டெத் ரேட்டல்ன்றோம் இல்லையா, கொரகொரன் சவுண்ட் வருது. ஸோ தட் இஸ் கிரெபிடேஷன்ஸ். இது வந்து எனக்கு தெரியல சார், அவர் வந்து என்ன வால்யூம் ஓவர்லோட ஹைப்பர் வால்யூமிக்கா தெரியல அப்படின்னா திஸ் ஹெல்ப்ஸ். ஒரே ஒரு வார்த்தை NT-proBNP. பிரச்சனை வந்து இது ஏட்ரியல் ஸ்ட்ரெச் இருந்தால் வரும். பட் NT-proBNP வந்து ஒரு ரிலையபிள் இன்வெஸ்டிகேஷன். இந்த ப்ராப்ளம் இஸ் 1500 ரூபாய். ஒரு முறையும் அதை நம்ம பண்ண முடியாது, பட் டவுட் இருக்கும் போது பண்ணலாம். செஸ்ட் எக்ஸ்ரேல என்ன வாஸ்குலர் பெடிக்கல்னு ஒன்று இருக்கு. பல்மனரி எடிமா இருந்தா அப்பர் லோப் எல்லாமே அந்த இடத்துல நீங்க 2 பல்மனரி எடிமா பாத்தீங்கன்னா கண்டுபிடிச்சிருவீங்க நீங்களே. சிடி ஸ்கேன்ல தெரியும். ஐவிசி வந்து டாக்டர் ரேடியாலஜிஸ்ட் தான் பார்ப்பாங்க. பட் இதெல்லாம் பார்க்கலாம். பார்த்து சொல்லுங்க சார் தெரியல, கொஞ்சம் நீங்க உங்களுக்கு ஃப்ரெண்ட்லி டாக்டர் வந்தா நீங்க கேட்கலாம், சார் இல்ல சார் இது ஐப்போவா ஐப்பரான்னு தெரியல சார், ஒரு ஐவிசி டயமீட்டர் பார்க்கலாம். அண்ட் இப்போ வந்து லங் அல்ட்ராசவுண்ட் பிகம்ஸ் ஈஸி. ஸோ லங் அல்ட்ராசவுண்ட் கேன் டூ. அண்ட் பயோ இம்பிடன்ஸ்னு ஒன்று வந்து எல்லாரும் வாங்கிட்டு இருக்கோம் இப்போதைக்கு. ஸோ அது வந்து இட் இஸ் ஆல்சோ வெரி யூஸ்ஃபுல் ஃபார் அசஸிங் தி வெயிட். வெயிட் வாட்டர் அதிகம் இருக்கா, ஃபேட் அதிகமாக இருக்கா அப்படின்னு பார்க்கறது. இன்னொன்று ஸ்ட்ரோக் வால்யூம் வேரியேஷன். இது வந்து இன்டுபேட்டட் பேஷண்ட்டுக்கு அவங்க வந்து இன்ட்ராஆர்டரியல் பிபி போட்டிருப்பாங்க. அதில் ஸ்ட்ரோக் வால்யூம் எவ்வளோ வருதுன்னு பார்ப்போம். ஸோ அதில் வந்து ரெஸ்பிரேட்டரி வேரியேஷனை வச்சு வி ஃபைண்ட் அவுட் வெதர். ஸோ இது வந்து எதுக்காக உங்களுக்கு சொல்லப்பட்டது அப்படின்னா தெரியாத பட்சத்தில் இன்வெஸ்டிகேஷன்ஸ் அவைலபிலிட்டி இருக்கு. ஸோ டிரைவேட் செட்டிங் வந்து இப்போதைக்கு நமக்கு ட்ரையல் அண்ட் எரர் தான். எப்போ லோ பிபி ஆகுது, இடிமா இல்லாமல் இருக்காரா, அப்படிதான் இருக்கு. அவர் எவ்வளோ கெயின் வந்திருக்காரோ அதுக்கு மேலே வந்து ஒரு 1/2 கிலோன்னு வச்சு ஸ்லோலி when we remove. சார் எடுக்க முடியல சார், ஸ்லோலி we can do. ஆல்பமெண்ட் சம்டைம்ஸ் லிவர் டிசீஸ் இருந்ததுன்னா ஆல்பமெண்ட் போட்டு பண்ணுவோம். கார்டியாக் டிசீஸ் இருந்ததுன்னா இன்னும் கொஞ்சம் ஸ்லோவாக பண்ணுவோம். ஓகே, ஸோ பிபி ட்ரக்ஸ் சாப்பிடாம வரணும். பிகாஸ் பிபி ட்ரக்ஸ் வந்து அனல்ஸ் தி உங்களுடைய வாட்டர் எடுக்கக்கூடிய கெப்பாசிட்டியை வந்து குறைச்சிரும். ஸோ வெட்டிங் அப்படின்னா ரொம்ப க்ளோஸாக பாருங்கன்னு அர்த்தம். அண்ட் இட் இஸ் அ டைனமிக் பேராமீட்டர்னு என்ன அர்த்தம், நேற்றுக்கு ஒன்று இருக்கும் இன்னைக்கு ஒன்று இருக்கும். வரும்போது அவர் வந்து 1 வருஷமா டயாலிசிஸ் பண்ணாமல் வருவார் நம்ம கிட்ட. ஃபர்ஸ்ட் டயாலிசிஸ் பண்ண ஆரம்பிச்சதும் சாப்பிட ஆரம்பிப்பார். ஸோ ட்ரை வெயிட் வந்து மாறும். ஓகே, நடுவில் ஒரு முறை அட்மிட் ஆவார், திடீர்னு விட்டுருவார் திருப்பி. ஸோ ட்ரை வெயிட் வந்து குறையும். ஸோ இன்டர்கரண்ட் இல்னஸ் வரும்போது ட்ரை வெயிட் குறையும். மசில் லாஸ் போனதுனால ட்ரை வெயிட் வந்து குறையும். நம்ம வந்து அதே பழைய ட்ரை வெயிட் வச்சிருந்தோம்னா அவருக்கு மூச்சு வாங்க ஆரம்பிச்சிடும். வேறஸ் அவர் நல்லா சாப்பிட்றாரு இப்போ, பட் ஸ்டில் எக்ஸாஷன் அப்படி இருக்கு அப்படின்னா ட்ரை வெயிட் ஹஸ் சேஞ்ச்டு, இன்க்ரீஸ் த ட்ரை வெயிட். So health is a state of physical and mental social well-being. நம்ம டயாலிசிஸ் என்னன்னா be as normal as possible. ஃபில்ட்ரேஷன் ஃபங்க்ஷன் மட்டும்தான் டயாலிசிஸ் பண்ணுது. ஸோ மீதி எரித்ரோபாய்டின், மீதி வந்து போன், ஸோ எல்லாத்தையுமே நம்ம ஃபோக்கஸ் பண்ணுறோம். அதில் ஒன் இம்பார்ட்டன்ட் பாயிண்ட் இஸ் ட்ரை வெயிட். there's no point in living. உயிரோடு இருக்கிறேன் ஆனால் டயர்டாக இருக்கிறேன், அண்ட் என்னைக்கு மூச்சு வாங்கன்னு தெரியாது, என்னைக்கு சாவ போகிறேன்னு தெரியாது. ஸோ we have to give them that comfort, restore the health in all our CKD patients by adequate dialysis. So finally, so we ask for breathing difficulty, dyspnea, abdomen distension, edema, cramps, fatigue and possible giddiness. இதையே பார்க்குறோம். SiO2 பார்க்குறோம், லிவர் பெருசாக இருக்கான்னு பார்க்குறோம், பாசிபிள் பிபி இருக்கான்னு பார்க்குறோம். இன்வெஸ்டிகேஷன்ஸ் வந்து நமக்கு ஹெல்ப்ஃபுல்லாக இருக்குது. ஸோ திஸ் இஸ் a summary of clinical assessment of dry weight. Thank you. கரெக்டாக முடிச்சிட்டேன். அலாமடி ட்ரை வெயிட் வந்து இல்லை இது உங்களது வந்து இது ஃபைனல் இது உங்கள் இது சரி ஏதோ பண்ணார் வந்தது.
Good afternoon to all. ஆல்ரெடி போஸ்ட் லஞ்சில் எல்லாம் டயர்டாக இருப்பீங்கன்னு நினைக்கிறேன். அதனால தான் ஒரு இன்ட்ராக்டிவாக இருக்கட்டும்னு ப்ரெசன்டேஷனை கொஞ்சம் மாற்றுறோம். இது பேனல் டிஸ்கஷன் இஸ் மோர் ஆர்லெஸ் ஒரு சும்மா ஒரு பட்டிமன்ற மாதிரி தான். மொதல் பேசினவங்க வந்து மோர் ஆன் கிளினிக்கல் எஸ்டிமேஷன் ஆஃப் ட்ரை வெயிட், கிளினிக்கலாக அசஸ் பண்ணுறதுனுடைய யூஸ்ஃபுல்னஸ் எவ்வளோன்றதை சொன்னாங்க. அதை நான் வந்து அப்ஜெக்ட் பண்ணணும், அதான் எனக்கு கொடுக்கப்பட்டிருக்கிறது. ஏன்னா எவ்வளவு தூரம் கிளினிக்கல் அசஸ்மெண்ட் ஹெல்ப்ஃபுல்லாக இருக்கும் அப்படிங்கிறது. ஸோ மொதல் பேசுனது படி நம்ம பிபி மானிட்டரிங் அண்ட் ஜேவிபி எஸ்டிமேஷன் அண்ட் த மெத்தட் டு கரெக்ட்லி எலிசிட் பீரியட் எடிமா இதெல்லாம் நம்ம பார்த்தோம். பட் இதெல்லாமே வந்து 100% சக்ஸஸ்ஃபுல்லாக பேஷண்ட்டுடைய வால்யூம் ஓவரோட அட்ரஸ் பண்ணுமா? கண்டிப்பாக பண்ணாது. ஏன்? ஆனால் இதெல்லாம் இம்பார்ட்டன்ட். தீஸ் ஆர் த ஃபர்ஸ்ட் ஸ்டெப்ஸ். ஆப்வியஸ்லி இது எல்லாமே இருந்துச்சுன்னா பேஷண்ட் இஸ் ஆப்வியஸ்லி வால்யூம் ஓவர்லோடட் கண்டிப்பாக இருக்கும். ஆனால் இது மட்டுமே பத்தாது நமக்கு. ஸோ அதை தான் நம்ம இப்போ பார்க்க போகிறோம். ஸோ ஏன் பத்தாது? ஸோ நிறைய நேரம் வந்து நம்ம பார்க்குற ஹைப்போடென்ஷனோ ஹைப்பர் டென்ஷனோ இதுக்கெல்லாம் மேலே ஒரு சில டேர்ம்ஸ், ஃபார் எக்ஸாம்பிள் நம்ம வேகமாக ஃப்ளூயிட் ரிமூவ் பண்ணும்போது பேஷண்ட் மே டெவலப் ஆர்த்தோஸ்டேட்டிக் ஹைப்போடென்ஷன். ஸோ நல்லா இறங்கிருச்சுட்டு பேஷண்ட் ஹஸ் அச்சீவ்டு ட்ரை வெயிட் அப்படின்னு எடுத்துக்கிட்டோம்னா we may land up in trouble. ஏன்னா it indicates more fluid has been removed அந்த மாதிரி இருக்கு. ஸோ அதனால தான் முதல் சொன்னது மாதிரி ambulatory BP monitoring is very important. பேஷண்ட்டுடைய பேஸ்லைன் பிபி ஓவர் several hours of a day எப்படி இருக்கு அப்படிங்கிறதுக்கு ambulatory BP monitoring நம்ம நீங்க எல்லாம் பார்த்துருக்கீங்களா தெரியல, ஒரு 24 hours நம்ம வந்து கண்டினியூஸா எஸ்டிமேட் பண்ணுவாங்க. ஏன்னா நம்ம டயாலிசிஸ்க்குன்னு வரும்போது மார்னிங் டைம்ல வரும்போது அவங்களுக்கு காட்டுற பிபி மே நாட் பி தியர் ஒரிஜினல் ரெப்ரசன்டேட்டிங் பிபியா இருக்குமான்னு சொல்ல முடியாது. ஸோ நமக்கு சொன்னது என்ன? பிபி raised. எஸ் ஆப்வியஸ்லி இட்ஸ் கரெக்ட் ஒன்லி. பிபி இன்க்ரீஸ்ட் ஹைப்பர் டென்ஷன் ஆப்வியஸ்லி மீன்ஸ் ஒரு 3 தடவை வால்யூம் ஓவர்லோடு தான் நம்ம எடுத்துக்குவோம். அதனால we may tend to decrease the dry weight, கம்மியாக வச்சு தான் எடுக்கணும். ஸோ அதில் வர இஷ்யூஸ் என்ன? So hypertension may not always be due to volume overload நால மட்டும் இருக்கிறது கிடையாது. There are so many reasons. இதுல சொல்லியிருக்க நம்ம வால்யூம் ஓவர்லோடுக்கு dry weight reduction அதுதான் பார்க்குறோம். But there are some other reasons. CKD-ல வந்து obviously nerves எல்லாமே வந்து abnormal-ஆ இருக்கும். So they elicit more sympathetic overactivity. எரித்ரோபாய்ட் நம்ம கொடுக்கறதுக்கே ஹைப்பர்டென்ஷன் வரலாம். அதே மாதிரி ரெனின் ஆஞ்சியோடென்ஷன் சிஸ்டம் ஓவர் ஆக்ட் ஆகும். இந்த மாதிரி நிறைய மெக்கானிசம்ஸ் மூலமா வரலாம். ஸோ வால்யூம் ஓவர்லோட் தோ predominantly it is the cause for hypertension. There are some other reasons which may not be under our control or should நம்ம அதுக்கு வேற மெஷர்ஸ் நம்ம எடுத்தாகணும். ஸோ another thing, வெயிட் கெயின் இதுக்கு வந்து வெறும் வால்யூம் மட்டும்தான் ரீசனா கிடையாது. நம்மளே இருக்கோம், நம்ம வந்து இப்போ ஒரு ஓவர் பீரியட் ஆஃப் 1 monthல நம்ம இதே வெயிட்டாக இருப்போம். கண்டிப்பாக ஆப்வியஸ்லி நம்ம சாப்பிட்ற ஃபுட்டு நம்மளுடைய என்விரான்மெண்ட்டை பொறுத்து வெயிட் ஏறலாம் இறங்கலாம். ஸோ இம்பேக்ட் ஆஃப் லீன் அண்ட் மசில் மாஸ். ஸோ அப்பிடைட் நல்லா டயாலிசிஸ் நல்லா பண்ண அதுவும் ஹீமோ டயஃபில்ட்ரேஷன் இது மாதிரிலாம் பண்ண பேஷண்ட்ஸ் அப்பிடைட் வில் இம்ப்ரூவ். ஸோ நல்ல மசில் மாஸ் கெயின் பண்ணுவாங்க. அப்படி இருக்கும்போது அவங்க வெயிட் ஏறும்போது அந்த நேரத்தில் கரெக்டாக ட்ரை வெயிட்டை ஏற்றலைன்னா we may land up in trouble. ஸோ பழைய ட்ரை வெயிட்டே வச்சோம்னா they may land up with hypotension, cramps இந்த மாதிரி இஷ்யூஸ் வரும். ஆன் த கான்ட்ரடிக்டரி பேஷண்ட் ஒரு இல்னஸ் போகிறாங்க, நம்ம டயாலிசிஸ் பேஷண்ட்ஸ்க்கு நிறைய பேருக்கு எம்ஐ வரும், ஏதோ ஒரு சர்ஜரி வரும், அந்த மாதிரி விஷயங்கள்லாம் வரும்போது they may have less nutrition, so they may lose their weight. அப்போ கரெக்டாக எஸ்டிமேட் பண்ணி ட்ரை வெயிட்டை குறைக்கலைன்னா they may be overloaded and they develop pulmonary edema. So correct issues are there with the same dry weight fixation. நிறைய நேரம் எல்லா யூனிட்லயும் பார்த்தா ட்ரை வெயிட்ங்கிறது தனியா ஒன்று போட்டுக்கிட்டே வருவாங்க, போஸ்ட் டயாலிசிஸ் வெயிட்னு ஒன்று பார்த்துக்கிட்டு அசஸ் பண்ணிக்கிட்டே வருவாங்க. அப்படி பண்ணக்கூடாது. ட்ரை வெயிட் ஹேஸ் டு பி கான்ஸ்டன்ட்லி ரிவைஸ்ட். ஸோ இதில் பார்த்தோம்னா இதில் என்ன இன்சிஸ்ட் பண்ணுறோன்னா யூஎஃப் ரேட். நிறைய பேர் இப்போ ஒரு பேஷண்ட்டுக்கு 10 லிட்டர் ரிமூவ் பண்ணணும் முடியுமா நம்மளால் அப்படின்னா முடியும், கண்டிப்பாக முடியும். ஆப்வியஸ்லி த டியூரேஷன் ஹேஸ் டு பி எக்ஸ்டெண்டட். நம்ம வந்து எவ்வளவு ரிமூவ் பண்றோம் யூஎஃப்க்கு இம்பார்ட்டன்ஸ் கொடுக்கறத விட யூஎஃப் ரேட் இஸ் மோர் இம்பார்ட்டன்ட். 1 மணி நேரத்துக்கு இவ்வளவுங்கிறது நம்ம வந்து ஒரு யூனிட்டுக்குன்னு ஒரு புரோட்டோகால் வச்சா கூட அதுவும் இண்டிவிஜுவல் வேரியேஷன்ஸ் இருக்கு. ஸோ யூஎஃப் ரேட்டுக்கு இம்பார்ட்டன்ஸ் கொடுத்தா 10 லிட்டர் கூட நம்ம ஓவர் த பீரியட் ஆஃப் டைம் நம்ம ரிமூவ் பண்ண முடியும். ஸோ கிளினிக்கல் சயின்ஸ் ஆர் ஆல்வேஸ் அன்ஸ்பெசிபிக் அண்ட் சம்டைம்ஸ் டிஸ்கார்டன்ட். ஸோ இந்த பிக்சர் நம்ம ஏற்கனவே சொன்னாங்க, ஏன்னா திஸ் பிக்சர் இண்டிகேட்ஸ் ரீடிஸ்ட்ரிபியூஷன். ஸோ நம்ம ரிமூவ் பண்ற எல்லாமே இன்ட்ராவாஸ்குலர் கம்பார்ட்மெண்ட் பிளட் வெசல்குள்ள இருந்து தான் எடுக்கிறோம். ஆனால் நிறைய ஃப்ளூயிட் அதுக்கு வெளியே தான் இருக்கு. ஸோ அதெல்லாம் வெளியே வரணும். அப்போ வெளியே வர்றதுக்கு அதுக்கு ஒரு டைம் கொடுக்கணும். அதான் ரீடிஸ்ட்ரிபியூஷன். தட் வேரிஸ் ஃப்ரம் இண்டிவிஜுவல் டு இண்டிவிஜுவல். சில பேருக்கு எவ்வளவு எடுத்தாலும் ஹைப்போடென்ஷனே வராது, ஏன்னா தே ஹேவ் ஃபாஸ்டர் ரீடிஸ்ட்ரிபியூஷன் ரேட். சில பேருக்கு என்ன பண்ணாலும் ரீடிஸ்ட்ரிபியூஷன் ஆகவே ஆகாது. இட் மே ஈவன் டேக் வீக்ஸ். You will be surprised, it may even take weeks. So நம்ம எக்ஸ்ட்ரா கார்போரேட் செல்லுலர் வால்யூம் ரெடியூஸ் பண்ணா கூட கொரலேட்டிங் எக்ஸ்ட்ரா செல்லுலர் வால்யூம் வித் பிபி மேபி டிஸ்கார்டன்ட்ங்கிறதுக்கு என்ன எதுன்னா ஒரு வாரம் கூட ஆகலாம் அப்படின்றாங்க. ஸோ இதெல்லாம் வந்து கிளினிக்கல் அசஸ்மெண்ட்டுக்கு நமக்கு வந்து ஹிண்டரிங் பாயிண்ட்ஸ். ஸோ அனதர் திங், மெனி பேஷண்ட்ஸ் நிறைய ஆன்டி ஹைப்பர்டென்சிவ் மெடிகேஷன்ஸ் நம்ம வந்து எடுத்துக்கிட்டு இருப்பாங்க இல்லையா. ஆன்டி ஹைப்பர்டென்சிவ் ட்ரீட்மெண்ட் இஸ் மேஜர் சோர்ட் ஆஃப் ட்ரீட்மெண்ட். நிறைய நேரம் டயாலிசிஸ்க்கு வரும்போது பிபி ட்ரக்ஸ் எல்லாம் ஸ்டாப் பண்ணிட்டு வர சொல்லுவோம் நிறையா. அதை வந்து 100% ரூலாக வச்சுக்கவும் கூடாது. ஏன்னா இட் சுட் பி வேரிட் வித் பேஷண்ட் டு பேஷண்ட் கண்டிப்பாக. ஸோ ஆன்டி ஹைப்பர்டென்சிவ் ட்ரக் எடுக்கும்போது ஸோ வி மே நாட் ரிலே அப்பான் த பிபி ஃபார் அசஸிங் வால்யூம் ஓவர்லோட். கண்டிப்பாக எடுத்துக்க முடியாது. ஆன் த கான்ட்ரடிக்டரி மெனி ஆஃப் த மெடிகேஷன்ஸ் நிறைய ட்ரக் எடுக்கிறாங்கல்ல, அதுவும் டயாலிசிஸில் ரிமூவ் ஆயிரும். ஸோ ஃபோர் த பீரியட் ஆஃப் டைம் முடிக்கும்போது பேஷண்ட்ஸ்க்கு பிபி அதிகமாகும். ஆனால் தோ ட்ரை வெயிட் ரீச் பண்ணியிருந்தா கூட ட்ரக் லெவல் கம்மியாக இருக்கிறதுனால தே மே ஹவ் ஹைப்பர் டென்ஷன். ஸோ இந்த மாதிரி பாயிண்ட்ஸும் நம்ம மைண்டில் வச்சுக்கணும். ஸோ இது ஒரு முக்கியமானது. சோடியம் ப்ரொஃபைலிங். இப்போ ஒரு பேஷண்ட் ரொம்ப வால்யூம் லாக்டாக இருக்காங்க, அவங்களுக்கு நம்ம ஃப்ளூயிட் ஹேஸ் டு பி ரிமூவ்ட். ஸோ என்ன இஷ்யூஸ் வருது, சடன்லி பேஷண்ட் ரீடிஸ்ட்ரிபியூஷனால தே மே டெவலப் ஹைப்போடென்ஷன். ஸோ நமக்கு எல்லாத்துக்கும் தெரியும், நம்ம சோடியம் ப்ரொஃபைலிங் வி டென் டு கீப். முதல்ல சோடியம் ஒரு 154 அதுக்கு மேலே கரெக்டாக வைப்போம் முதல்ல. இதில் நிறைய நேரம் என்ன ப்ராப்ளம் வரும்னா, பேஷண்ட் வந்து ஒரு குறிப்பிட்ட இதில் அதே மே டெவலப் ஏதோ வாமிட்டிங் இருக்குன்னு ஏர்லியராக செஷன் க்ளோஸ் பண்ண சொல்லிடுவாங்க. ஆர் வி மே டென் டு க்ளோஸ் த செஷன் ஏர்லியர். அப்படி இருக்கும்போது தட் அக்கர்ஸ் த பாயிண்ட். நிறைய நேரம் ஹையர் சோடியம் லெவல்ஸோட டிஸ்கனெக்ட் பண்ணும்போது problem is there. So patient becomes more thirsty. நிறைய தண்ணி குடிப்பாங்க, they may become symptomatic. So we may not be able to achieve the dry weight. So இதுக்கு இம்பார்ட்டன்ஸ் கொடுக்கணும். சோடியம் ப்ரொஃபைலிங் நீங்கள் பிளான் பண்ணுறீங்கன்னா that session should be completely completed. ரொம்ப இம்பார்ட்டன்ட். ஸோ இந்த இதெல்லாம் வச்சு பார்க்கும்போது கிளினிக்கல் அசஸ்மெண்ட் மட்டும் பத்தாது. there should be something else நம்ம தேவைப்படுது. அதுதான் வந்து முதல் காலங்காலமாக சொல்றது சிடி ரேஷியோ, கார்டியோ தொராசிக் ரேஷியோ. ஹார்ட்டுக்கும் அந்த டோட்டலாக இருக்கிற அந்த தொராசிக் ரேஷியோ எவ்வளோ இருக்கணும் அப்படிங்கிறது 0.5 to 0.55 to 0.6 இருக்கணும். நாங்கள் அதுக்கு மேலே போகுது அப்படின்னாவே இண்டிகேட்ஸ் தட் ஹார்ட் இஸ் பம்பிங் மோர் ஃப்ளூயிட். அப்போ வால்யூம் ஓவர்லோடுன்னு எடுத்துக்கலாங்கிறது ஒரு ரஃப் கான்செப்ட். நான் இது இப்பெல்லாம் சேஞ்சுடு, ஏன்னா இதில் நிறைய ஃபேலசிஸ் இருக்குது. ஏன்னா ஆஸ் ஆஃப் கார்டியா கண்டிஷன்ஸ் இருக்குது, எல்விஹெச் இருக்குது, ஒரு டிசிஎம் பேஷண்ட்டு, ஒரு பெரிகார்டியல் எஃபிஷியன்ட் இருக்குன்னா அவங்களுக்கு ஹார்ட் பெருசாக தானே இருக்கும். அப்போ சிடி ரேஷியோ மே நாட் பி ரிலையபிள். ஸோ நெக்ஸ்ட் கம்ஸ் த ஐவிசி டயாமீட்டர். ஐவிசி டயாமீட்டர் இந்த மாதிரி தான் பார்ப்போம் நம்ம எபிகாஸ்டிக் ரீஜன் இதெல்லாம் பார்க்கும்போது. இதில் பார்த்தீங்கன்னா நம்ம வந்து கரெக்டாக அந்த ஹார்ட் ஏட்ரியம் வென்ட்ரிக்கு கீழே கரெக்டாக பிகினிங்கில் ஐவிசி நம்ம பார்க்கணும். இட் நீட்ஸ் ட்ரைனிங். ஸோ இதில் பார்க்குற இந்த ஐவிசி இதில் பாருங்கள் ஒரு 2.2 சென்டிமீட்டர்ஸ்னு கொடுத்துருக்கு. அதே மாதிரி இந்த மாதிரி தான் அசஸ் பண்ணுவோம். ஸோ இட் இஸ் அ வெரி யூஸ்ஃபுல் மெத்தட் ஃபார் அசஸிங். இது வந்து என்ன வருதுன்னா இப்போ மோர் தேன் 1.5 சென்டிமீட்டர்ஸ். அதில் பாயிண்ட் டு நோட்டீஸ் த வேரியேஷன் வித் ரெஸ்பிரேஷன். ஸோ ரெஸ்பிரேட்டரி வேரியேஷன் நம்ம நல்ல இன்ஹேலேஷன் நம்ம பண்ணும்போது இட் ஷுட் கொலாப்ஸ். இட் ஷுட் நாட் கொலாப்ஸ். மோர் தேன் 50% கொலாப்சபிலிட்டி இருக்கு அப்படின்னா தேர் நாட் வால்யூம் பிளாக்னு அர்த்தம். இப்போ பாருங்க 1.5 மேலே இருக்கு, பட் லெஸ் தேன் 50% கொலாப்சபிலிட்டி இருக்கு. நார்மலி நம்ம இன்ஸ்பயர் பண்ணும்போது இட் ஷுட் கொலாப்ஸ். லெஸ் தேன் 50% தான் கொலாப்ஸ் ஆகுதுன்னா கண்டிப்பாக வால்யூம் ஓவர்லோடாக இருக்காங்கன்னு அர்த்தம். ஸோ இப்போ ஐவிஸ் நல்ல மெத்தட் தானே, அதில் என்ன ப்ராப்ளம் இருக்கு அப்படின்னு பார்த்தோம்னா இட் இண்டிகேட்ஸ் தேர் இஸ் வால்யூம் ஓவர்லோட். ஹவு மச் வால்யூம் ஓவர்லோடட் எவ்வளோ இருக்காங்கன்னு நம்மளால டெஃபினட்டாக சொல்ல முடியாது. அது ஒரு முக்கியமான இது. நமக்கு போஸ்ட் டயாலிசிஸாக பார்க்கும்போது ஐவிசியில் இந்த மாதிரிலாம் மோர் தென் 1.5 இருக்கு, கொலாப்சபிலிட்டி இல்லை அப்படின்னா வால்யூம் ஓவர்லோடுன்னு தெரியும், ஆனால் எவ்வளோங்கிறத சொல்ல முடியாது. அதே மாதிரி பிரைமரிலி ஒரு ரைட் ஹார்ட் ஃபெயிலியர் இருக்கு, அது டிமோதொராக்ஸ், அதுலேயே ரைட் ஹார்ட் ஃபெயிலியர் வரும், அது இருக்கு. கார்டியக் டாம்பனெல்லாம் இருக்குன்னா ஐவிசி மேபி பெர்மனன்ட்லி இட் வில் பி டைலேட்டட், இட் வில் நாட் கொலாப்ஸ். அதை வச்சு ஸோ இதை வச்சு நம்ம அசஸ் பண்ணக்கூடிய தகுதி இழந்துடுறோம். இந்த கண்டிஷன்ஸ்ல எல்லாம் நம்ம அசஸ் பண்ண முடியாது. So here comes our lung ultrasound, the usefulness of lung ultrasound. So என்னது இது? So என்ன சொல்றாங்க, lung ultrasound should be immediately performed before and within 15 minutes after completion of dialysis. So இதில் என்ன பார்க்கலாம்? So பார்க்குறீங்கன்னா this is the normal A lines. இப்படி இந்த மாதிரி தெரியுது, இப்படி தெரியுது பாருங்க, ஒரு ஃபிளாட்டா ஏ மாதிரி இருக்கு பாருங்க, இந்த மாதிரி தெரியுது அப்படின்னா this is the normal reflection of the lung over the pleura நமக்கு வச்சு பார்க்கறதுல. ஸோ இது நார்மல். இதுவே ஆன் த கான்ட்ராரி வால்யூம் ஓவர்லோடா இருக்கு அப்படின்னா we will have this curly B line. இந்த மாதிரி இருக்கு அப்படின்னா this means the volume has not been fully removed. இருக்கு, இன்னும் வால்யூம் இருக்குன்னு அர்த்தம், வால்யூம் ஓவர்லோட். ஸோ எப்பயுமே இதுவும் நம்ம வந்து போஸ்ட் டயாலிசிஸாக பார்க்குறோம் அல்லது இன்ட்ராடயல் பார்க்குறோம்னா இது இருக்கிற வரைக்கும் we may tend to give continuous dialysis so that the dry weight may be reached. இதில் எவ்வளவு இருக்குங்கிறத கரெக்டாக அசஸ் பண்ண முடியாது. till the point of disappearance of B lines நம்ம கண்டினியூ பண்ணணும் அப்படிங்கிறது தான் பாயிண்ட். ஸோ இதனுடைய லிமிடேஷன்ஸ் ஆஸ் ஆஃப் லங்ஸை பற்றி கண்டுபிடிக்கணும்னா ஃபர்ஸ்ட் லங் ஷுட் பி நார்மல். லங் ப்ராப்ளம்ஸ், இன்டர்ஸ்டிஷியல் லங் டிசீஸ், கன்சால்டேஷன், எம்ஐ, டீகாம்பன்சேட்டட் ஹார்ட் ஃபெயிலியர் இந்த மாதிரிலாம் இருக்குது அப்படின்னா லங்ஸில் ஏற்கனவே அக்குமுலேஷன் இருந்துகிட்டே இருக்கும். ரீசன்ட் எம்ஐனா ஆல்ரெடி நீங்கள் என்னதான் இது பண்ணாலும் ஃப்ளூயிட் மேபி அக்குமுலேட்டிங் வித் இந்த லங்ஸ். ஸோ இட் மே நாட் பி யூஸ்ஃபுல் டு அசஸ் பி லைன்ஸ். அந்த ஸ்டேஜில் நம்ம யூஸ் பண்ண முடியாது. ஸோ ஹியர் கம்ஸ் த இம்பார்ட்டன்ஸ் ஆஃப் பயோ இம்பீடன்ஸ் ஸ்பெக்ட்ரோஸ்கோபி. வாட் இஸ் பயோ இம்பீடன்ஸ் ஸ்பெக்ட்ரோஸ்கோபி? இதுதான் இது யூசிங் these 4 electrodes. கீழே காலில் 2 எலக்ட்ரோட், மேலே கையில் 2 எலக்ட்ரோட் கட்டியிருப்பாங்க. இந்த மாதிரி பொசிஷன் பண்ணியிருப்போம். சிம்பிள், கீழே 2 எலக்ட்ரோட், மேலே 2. இது என்ன மெஷர் பண்ணுது? நம்ம உடம்புல இருக்க டிஷ்யூஸில் ஒரு சின்ன எலக்ட்ரிக்கல் சிக்னலை அதை நம்ம அனுப்புகிறோம். ஒவ்வொரு டிஷ்யூவும் அதுக்குன்னு ஒரு ரெசிஸ்டன்ஸ் கொடுக்கும். அந்த ரெசிஸ்டன்ஸ் பேட்டர்ன் நார்மலாக இருக்கிறத நம்ம டாக்குமெண்ட் பண்ணிக்குவாங்க. அப்நார்மலாக ரெசிஸ்டன்ஸ் கொடுக்குதா அப்படிங்கிறத அசஸ் பண்ணுவோம். அப்நார்மல் ரெசிஸ்டன்ஸ் வில் பி given by whom? நம்ம நிறைய வால்யூம் அதிகமாக இருக்கிறவங்க, வால்யூம் ஓவர்லோட் பேஷண்ட்ஸ்க்கு அப்நார்மல் ரெசிஸ்டன்ஸ் இருக்கும். ஸோ அதை தான் நம்ம அசஸ் பண்ணுறோம். ரெசிஸ்டன்ஸ் பேட்டர்ன் இது சிம்பிள். இந்த மாதிரி தான் ஒரு சிம்பிள் apparatus, ஈவன் லெஸ் தேன் ஒரு இசிஜி மிஷின் கூட சின்ன சைஸில் தான் இருக்கும். இட் காஸ்ட் அரவுண்ட் ஒரு 7 to 9 lakhs வரும். இது ஈவன் இன் கவர்மெண்ட் ஹாஸ்பிட்டல்ஸ் we are planning to buy this. ஏன் அப்படிங்கிற இம்பார்ட்டன்ஸ் சொல்லுவோம். ஏன்னா பெனிஃபிட்ஸ். So not only volume, it indicates the clear volume. எவ்வளவு வால்யூம் ஓவர்லோடுங்கிறத ஓரளவுக்கு எக்ஸாக்டாக ப்ரெடிக்ட் பண்ணக்கூடியது. ஏன்னா மற்ற எல்லாத்துலேயும் வால்யூம் ஓவர்லோடுன்னு மட்டும்தான் சொல்ல முடியும். இதில் எவ்வளோங்கிறத அசஸ் பண்ணலாம். அண்ட் இட் ஆல்சோ இண்டிகேட்ஸ் த செல்லுலர் ஹெல்த். எவ்வளவு நியூட்ரிஷனலுக்கும் நம்ம யூஸ் பண்ணிக்கலாம். எவ்வளோ மசில் மாஸ் ரெடியூஸ் ஆயிருக்கு, நியூட்ரிஷனலி பேஷண்ட் எவ்வளோ இல் பில்ட்டாக இருக்காங்கிற அந்த இன்ஃபர்மேஷனும் கிடைக்கும். ஹோல் பாடி காம்போசிஷன் நமக்கு கிடைச்சிரும். ஸோ இது வந்து இந்த பேட்டர்ன்ஸ் அந்த கருவில் அந்த இதில் என்னென்ன வருங்கிறது. திஸ் இஸ் த நார்மல் ரெசிஸ்டன்ஸ் பேட்டர்ன். ஒரு ரெசிஸ்டன்ஸ் உள்ளே போய் வெளியே வரணும். இந்த மாதிரி ஒரு பேரபோலிக் கர்வ் இப்படி நார்மலாக இருக்கணும். எங்கேயுமே ஒரு டிஸ்கண்டினியூஷன் இல்லாமல் வரணும். ஸோ ஃபர்ஸ்ட் எடுத்தா பார்த்தா இந்த OHYன்னு போட்டோன்னா ஓவர் ஹைட்ரேஷன். ஒரு பேஷண்ட் நார்மலாக இருக்கிறத விட அவங்க உடம்புக்கு எவ்வளோ ஓவர் ஹைட்ரேட்டடாக இருக்காங்கன்னு தெரியும். ஃபர்ஸ்ட் இதில் பார்த்தீங்கன்னா அந்த -0.4 கொடுத்துருக்கு. ஆல்ரெடி வால்யூம் கம்மியாக இருக்குன்னு அர்த்தம். இதில் பார்த்தீங்கன்னா இந்த மாதிரி வந்துடும் 1.6 liters ஓவர் அப்படின்னு எக்ஸாக்டாக அட்லீஸ்ட் டு த ப்ரெசைஸ் நமக்கு எவ்வளோ ஓவர்லோடுங்கிறது நமக்கு தெரிய வரும். ஸோ ஃபேஸ் ஆங்கிள்னு ஒரு மெஷர் அதில் யூஸ் பண்ணுவாங்க. லோ, அதாவது ஹை ஃபேஸ் ஆங்கிள் இருக்குன்னா வால்யூம் ஓவர்லோடுன்னு அர்த்தம். அதுவே லோ ஃபேஸ் ஆங்கிள் இந்த மாதிரி இருக்குன்னா நியூட்ரிஷனல், மால் நியூட்ரிஷனில் இருக்காங்கன்னு அர்த்தம். இப்போ என்னென்ன பேராமீட்டர்ஸ் அதில் வருங்கிறத உங்களுக்கு இது பண்ணுறதுக்காக சொல்கிறேன். இது பிவா வெக்டார் அனலைசிஸ். பிவாங்கிறது என்னன்னா பயோ இம்பிடன்ஸ் வெக்டார் அனலைசிஸ். இதுதான். இப்போ ஒரு எக்ஸ் ஆக்சிஸ்ன்னு எடுத்துக்கிட்டிங்கன்னா அது மசில் மாஸை குறிக்கும். ஒய் ஆக்சிஸ்ன்னு எடுத்துக்கிட்டிங்கன்னா வால்யூம் ஓவர்லோட குறிக்கும். அதுக்கு தகுந்த மாதிரி இந்த பிளாட் கரெக்டாக நார்மலாக இப்போ நம்ம வந்து செக் பண்ணாங்க. இப்போ நாங்கள் ஒரு எப்படி இருக்கும்னு பார்த்துக்க டாக்டர்ஸ்லாம் கூட அனலைஸ் பண்ணோம். அப்போ கரெக்டாக அந்த வெக்டார் நியர் நார்மல் அந்த சென்டர் பாயிண்ட்டை நோக்கி போகும். இதுவே சிகேடி டயாலிசிஸ் பேஷண்ட்ல இருக்கும்போது வால்யூம் கண்ட்ரோலாக இருக்கவங்களுக்கு பார்த்தீங்கன்னா நிறைய பேர் கெக்கெக்ஷியால இருக்கிறத ஐடென்டிஃபை பண்ணோம். இந்த இடத்துல வருது, அவங்க வால்யூம் இதில் இருக்கவங்க இப்படி வருது. நார்மலாக இருக்கவங்களுக்கு 10 இந்த மாதிரி நடுவில் போகிற அளவுக்கு போகுது. ஸோ இட் வில் பி யூஸ்ஃபுல். நம்ம எங்கே போகிறாங்க இது அப்படியே ஓவர் த பீரியட் நம்ம அசஸ் பண்ணிக்கிட்டே வந்தால் பேஷண்ட்டுடைய இம்ப்ரூவ்மெண்ட் அசஸ் பண்ணுறதுக்கும் ப்ரொக்னோசிஸ்க்கும் இது உதவும். ஸோ இது வந்து செல் மெம்பரேன் கெப்பாசிட்டன்ஸ் எக்ஸ்ட்ரீம்லி ஹெல்த்தினா அந்த இதில் வரணும், க்ரீன் சைடில் இருக்கணும் ஃபுல்லாக. ஏன்னா செல் மெம்பரேன் கண்டக்டன்ஸ் வந்து செல்ஸ் would freely pass எனர்ஜி அந்த மாதிரி இருக்கணும். அந்த கண்டக்டன்ஸை வச்சு இதை அசஸ் பண்ணுறாங்க. ஸோ இந்த பேராமீட்டர்ஸ்லாம் அதில் வரும் உங்களுக்கு. ஸோ ஃபேட் எவ்வளோ இருக்குது, ஃபேட் லீன் பாடி வெயிட் எவ்வளவு, டோட்டல் பாடி வெயிட் எவ்வளவு, பார்டர் வாட்டர் எவ்வளவு, இது எல்லாமே வந்துடும். அதில் ஸ்கெலட்டல் மசில் மாஸ் எவ்வளவுங்கிற டீட்டெயில் இது வரைக்கும் வந்துடும் எல்லாமே. ஸோ இந்த ரிப்போர்ட்ஸ் வந்து கிளாசிக்கலாக பார்த்தா இந்த பிரிண்டட் ஃபார்மில் இந்த மாதிரி தான் வரும் ஃபுல்லாக. இந்த மாதிரி ஒரு 3 or 4 pages வரும். ஸோ இதுக்கும் லிமிட்டேஷன் இருக்கும்ல. எஸ், ஜஸ்ட் பிஃபோர் டயாலிசிஸ் நிறைய தண்ணி குடிச்சாங்களா இட் மே அஃபெக்ட். ஏன்னா ஓவரால் நம்ம எவ்வளோ இது பண்ணுறாங்கன்னு தெரியும். ஹைட்ரேஷன் ஸ்டேட்டஸ், இமீடியட்டாக ஃபுட் இன்டேக்கு, அப்புறம் எக்ஸ்டர்னல் என்விரான்மெண்ட்டுக்கு ஏர் டெம்பரேச்சர், ரீசன்ட் ஃபிசிக்கல் ஆக்டிவிட்டி இதெல்லாம் பொறுத்து மாறுபடலாம். பட் இதெல்லாம் நெக்லிஜிபிள் ஃபேக்டர்ஸ் தான். ஸோ இந்த மிஷின் அடிக்கடி ஸ்டாண்டர்டைசேஷன் பண்ணணும், அது ஒரு பாயிண்ட்டு. ஸோ இது லாஸ்ட் இதில் பார்த்தோம், ஜஸ்ட் அண்ட் எக்ஸாம்பிள் என்னென்ன வரும் அந்த இதில். இது இம்பீடன்ஸ் எவ்வளோ வருது, இந்த மாதிரி ஸ்மூத் கர்வாக வருதா அப்படிங்கிறத அசஸ் பண்ணுறது. இது ஃபேஸ் ஆங்கிள். இது இந்த மாதிரி கிரீன் கிட்ட வந்துச்சுன்னா ஓகேன்னு அர்த்தம். கீழேயோ மேலேயோ வருதுன்னா இட் இண்டிகேட்ஸ் எதர் வால்யூம் ஓவர்லோட இல்லை மால் நியூட்ரிஷனான்னு அர்த்தம். இந்த மாதிரி தான் வரும். இது வந்து கிரீனா, இது வந்து வால்யூம், இது வந்து வாட்டர் ஃப்ளூயிட் ஓவர்லோட், இது மசில் மாஸ். இந்த பக்கம் இருக்கிற ரெண்டுமே ஃபேட், குளூட்டியல் ஃபேட் அஸ் வெல் அஸ் ஜென்ரல் ஃபேட். இது எவ்வளோ இருக்குன்னு பர்சன்டேஜ் கர்வ் மாதிரி கொடுத்துருவாங்க. இது வந்து நம்ம எவ்வளோங்கிற எக்ஸாக்ட் டீட்டெயில்ஸும் வரும், பர்சன்டேஜ்லையும் கொடுத்துருவாங்க. எக்ஸ்ட்ரா செல்லர் ஃப்ளூயிட் வால்யூம் எவ்வளவு, இன்ட்ரா செல்லர் ஃப்ளூயிட் வால்யூம் எவ்வளோன்னு பர்சன்டேஜ்லையும் வந்துடும். இந்த மாதிரி தான் வரும். ஸோ இங்கே இது திஸ் இஸ் த நார்மல் ஒன், இந்த இடத்துல இருக்கிறது தான் நார்மல். பேஷண்ட்டுக்கு எவ்வளோ தூரம் இதாக இருக்குது, எய்தர் தேர் நியூட்ரிஷனலி டெப்ரைவ்ட் ஆர் வால்யூம் ஓவர்லோடுங்கிற இன்ஃபர்மேஷன் நமக்கு கிடைக்கும். ஸோ இதெல்லாம் வச்சு பார்க்கும்போது எக்ஸாக்டாக துல்லியமாக ஒருத்தருக்கு எவ்வளோ வால்யூம் ஓவர்லோட் இருக்குன்னு ஓரளவுக்கு சொல்லக்கூடியது கரெக்டாக இருக்கும். நம்ம கிளினிக்கில் என்ன தான் இது பண்ணாலும் we may tend to err அந்த சைடு. அதனால இது எம்ப்ளாய் பண்ணோம்னா ஓரளவுக்கு வருங்கிறது நெக்ஸ்ட் தாட். அடுத்தது இது வந்து வேஸ்ட் ஹிப் ரேஷியோ, நார்மலி இட் should be 1. ஸோ இது எவ்வளோ இருக்குங்கிறதும் நமக்கு மெஷர்மெண்ட்ஸ் வந்துடும். தேங்க்யூ.
Good afternoon to all. So after going through this dry weight பத்தி எல்லாம் புரிஞ்சிருப்பீங்க. So it is just a question and answer session தான். I will go through 2 case scenario and then we will finish this session. ஒரு question கேட்கலாமா? So dry weight is fixed or it is dynamic? Dynamic, it will keep change. Very good, dynamic. So we'll go through first case. This is case about a 55-year-old gentleman. He is on regular dialysis for 3 years. He is doing dialysis and standalone unit. அவர் ஒரு நாள் ஒரு 1 week 10 days ஹாஸ்பிட்டலுக்கு வரல, யூனிட்க்கு வரல. He came one day with மூச்சு டிஸ்னிக்காக இருக்கிறாரு. So his BP is higher, 190/100 and saturation is low. But his weight gain is only 2 kg. So our smart boy started dialysis, so with regular heparin and UF he kept as a 2 liter. So blood flow 300, dialysis flow 500. Is it right or not wrong? So dialysis technician kept the UF volume as 2 kg as the weight gain is just 2 kg. Is it right or wrong? But patient is dyspneic and BP was higher. So we'll see. So 2 hours, after 2 hours of dialysis, patient is dyspneic but better, but breathlessness is still persisting and saturation is getting better. So he continued the same prescription. At the end of dialysis, இன்னும் அவர் மூச்சு வாங்கிட்டு இருக்குது, இன்னும் எடிமா இருக்குது. So what is the problem with him? So though his weight gain is 2 kg, after removal of 2 kg, he still continued to be dyspneic. So he gave the history of recent admission for LRI a week ago, and he lost weight about 3 kg. So the problem here is the dry weight is not reassessed and adjusted. So the dry weight, as you rightly said, it is dynamic and it should be reassessed every 2 to 4 weeks. So regularly every 2 to 4 weeks dry weight reassess பண்ணனும். Or any following any illnesses or admissions, patient with ஒரு muscle cramp வருது, hypertension episodes வருதுன்னா dry weight reassess பண்ணனும். Difficult to control hypertension இருந்தது or edema இருக்கு அப்படினாலும் we have to reassess the dry weight. So என்ன பண்ணலாம் இதற்கு? So we have to extend the dialysis duration. So for example 4 hours பதிலா ஒரு 6 hours எடுத்துட்டு symptomatic-ஆ relieve பண்ணலாம். Or we can give extra dialysis, more frequent dialysis till he achieves the new dry weight. So new dry weight enna already explained. No hypertension during dialysis or pre-dialysis BP control, no edema and no signs of pulmonary congestion. Other patient dyspneic இல்லாம இருப்பாரு. So what to do? So in the explain பண்ண more frequent dialysis பண்ணலாம் or increment dialysis பண்ணி we can achieve the target weight. So the maximum EF rate is 13 ml per kg per hour மேல போகக்கூடாது. So if we exceed that நிறைய வால்யூம் எடுத்தோம் அப்படின்னா it become hypertension and become cardiovascular mortality அதிகம் இருக்கு அவருக்கு. So second case, so this is a case about 60-year-old gentleman non-diabetic CKD on dialysis with severe LV dysfunction. So he is a cardiac patient, he is on regular dialysis, his weight gain is 1.5 to 2 kg, he is on regular dialysis. So he is edematous and the BP is on the lower side, 100/60, pulse rate is higher and saturation is 93 at room air. What are the issues with the dialysis, during dialysis in these patients? So we will not be able to remove the fluid despite edema because of his low BP and severe cardiac dysfunction. So because of the recurrent hypotension, we tend to reduce the EF. So BP high கம்மியா இருக்கனால EF கம்மியா ஆகும். So the edema will persist. So blood flow கம்மியா ஆகும். So become under dialysis. அது again poor nutrition பண்ணுவோம். Anemia persistent இருக்கும். So this causes again worsening heart failure. So heart function இன்னும் மோசமாகும். So heart failure மோசமானாலே இன்னும் hypertension worsen ஆகும். Similar scenario will get in advanced liver disease and diabetes, autoimmune neuropathy and myeloma related disease லையும் இந்த மாதிரி BP கம்மியா இருக்கும், edema இருக்கும், but we cannot remove the excess fluid. So இந்த மாதிரி கேஸுக்கு என்ன பண்ணலாம்? So BP கம்மியா இருக்கு ஆனா edema இருக்கு, டயாலிசிஸ் பண்ண முடியல. So இந்த மாதிரி கேஸுக்கு என்னென்ன பண்ணலாம், என்னென்ன மெத்தட்ஸ் பண்ணலாம் அப்படின்னு பார்க்கலாம். ஸோ இது வந்து ஹார்ட் வீட் கூட ஸ்பெசிஃபிக் மேனேஜ்மெண்ட் skip. So dialysis treatment. So dialysisல ஒரு சில மோட்ஸை சேஞ்ச் பண்ணலாம். இந்த மாதிரி ஹைப்போடென்ஷன் வித் எடிமா இருக்க பேஷண்ட்ஸ்க்கு ஆர் பெரிட்டோனியல் டயாலிசிஸ் அட்வைஸ் பண்ணலாம். வாட் இஸ் தி அட்வான்டேஜ் ஆஃப் பெரிட்டோனியல் டயாலிசிஸ்? பிடி பார்த்துருக்கீங்களா? சிஏபிடி. ஸோ என்னென்ன அட்வான்டேஜ் சிஏபிடியில் இருக்குது அப்படின்னாக்க, ஸோ சிஏபிடியில் கண்டினியூஸாக டயாலிசிஸ் நடக்கும். த ஸ்லோலி வாட்டர் அண்ட் சோடியம் வில் பி ரிமூவ். ஸோ த ஹீமோடைனமிக் இன்ஸ்டெபிலிட்டி வராது. ஸோ டயாலிசிஸ் இருக்கிற மாதிரி பிபி டக்கு லோ ஆகாது, ஸோ அரித்மியா போகாது. ஸோ அதனால ஸ்லோ சஸ்டெயின்டாக இருக்கிறதுனால இட் இஸ் பெட்டர் வித் கார்டியக் டிஸ்ஃபங்க்ஷன். பேஷண்ட்ஸ் வித் பெட்டர் வித் கார்டியக் டிஸ்ஃபங்க்ஷன். ஸோ என்னென்ன டயாலிசிஸில் என்னென்ன பண்ணலாம் அப்படின்னு பார்த்தோம் அப்படின்னா, டயாலிசிஸ் இருக்குல்ல, நம்ம யூஸ் பண்ணுற டயாலிசிஸில் கோல்டு டயாலிசிஸ் யூஸ் பண்ணலாம். டயாலிசிஸில் டெம்பரேச்சர் குறைக்கலாம், 34 to 35.5 டிகிரி குறைக்கலாம். ஆர் டயாலிசிஸ் ரீமாடலிங், அதாவது சோடியத்தை வந்து குறைக்கலாம். 138 கீழே குறைச்சோம் அப்படின்னா பிபி ஸ்டெபிலிட்டி இருக்கும். டெக்ஸ்ட்ரோஸ் பேஸ்ட் டயாலிசிஸ் இஸ் ஆல்வேஸ் ப்ரிஃபர்ட் இன் எஸ்பெஷலி டயபெட்டிக் அண்ட் கார்டியக் டிஸ்ஃபங்க்ஷன் பேஷண்ட்ஸ். ஏன் அப்படின்னா hypoglycemia போச்சு அப்படின்னா again hypotension, arrhythmias very common and sudden cardiac death is very common during dialysis. So dextrose base யூஸ் பண்ணையில hypoglycemia, arrhythmiaலாம் we can prevent. செகண்ட் வந்து கன்வென்ஷனல் ஹீமோடயாலிசிஸ் பண்ணுறது ரொம்ப டிஃபிகல்ட். ஏன்னா நம்ம ஆல்ரெடி சொன்ன மாதிரி ஹைப்போடென்ஷன் வெரி காமன் வித் கன்வென்ஷனல் ஹீமோடயாலிசிஸ். ஸோ என்ன பண்ணலாம் அப்படின்னா மோர் ஃப்ரீக்வெண்ட் டயாலிசிஸ். ஸோ ஷார்ட் டியூரேஷன் மோர் ஃப்ரீக்வெண்ட் டயாலிசிஸ், நாக்டார்னல் ஹீமோடயாலிசிஸ் சொல்லுவாங்க அதுக்கு பேர். ஸோ டெய்லி டயாலிசிஸ் ஃபார் 5 days, 3 hours டயாலிசிஸ். இந்த மாதிரி இருக்கிற ஹீமோடயாலிட்டிக் ஸ்டெபிலிட்டி இருக்கும். அடுத்தது ஸ்லோ டயாலிசிஸ் பண்ணலாம். ஸ்லோ டயாலிசிஸ் ஃபார் லாங்கர் டியூரேஷன் டயாலிசிஸ் பண்ணலாம். ஸோ பெட்டர் ஹீமோடயாலிட்டிக் ஸ்டெபிலிட்டி இருக்கும். மூணாவது ஹை ஃப்ளெக்ஸ் ஹீமோடயாலிசிஸ் வித் அல்ட்ரா பியூர் வாட்டர். ஸோ மிடில் மாலிக்யூல் நல்லா உருவாகும். ஸோ ஹீமோடயாலிட்டிக் ஸ்டெபிலிட்டி இருக்கும். கன்வெக்டிவ் தெரப்பி, டெல் பிட்வீன் ஹிஸ்டியல் ஆன்லைன் ஹீமோடயல் ஃபில்ட்ரேஷன், அதில் கோல்டு ரீப்ளேஸ்மெண்ட் ஃப்ளூயிட் யூஸ் பண்ணுவாங்க, அதனால ஹீமோடயாலிட்டிக் ஸ்டெபிலிட்டி இருக்கும். ஸோ இந்த மாதிரி கேஸ்க்கு we can remove more fluid with the hemodynamic stability. So coming to PD treatment, PD என்னென்ன சேஞ்சஸ்லாம் பண்ணலாம் அப்படின்னு பார்த்தோம். PD டயாலிசிஸில் குளுக்கோஸ் கான்சன்ட்ரேஷனை இன்க்ரீஸ் பண்ணலாம். ஸோ குளுக்கோஸ் கான்சன்ட்ரேஷன் இன்க்ரீஸ் பண்ணோம் அப்படின்னா நம்மளுக்கு ஆஸ்மாலிட்டி அதிகமாகும். ஸோ மோர் வாட்டர் we can remove more water. செகண்ட் டயாலிசிஸ் டோசேஜ் இன்க்ரீஸ் பண்ணலாம். மூணாவது ஐகோடெக்ஸ்ட்ரோஸ் யூஸ் பண்ணலாம். ஸோ ஐகோடெக்ஸ்ட்ரோஸ் இஸ் நான் டெக்ஸ்ட்ரோஸ், அதனால் குளுக்கோஸ் மீடியேட்டட் டாக்ஸிட்டி அதில் வராது. அதனால் ஐகோடெக்ஸ்ட்ரோஸ் வந்து it has a good hemodynamic stability and good we can remove more water in the icodextrin based peritoneal dialysis. Frequency of dialysis increase பண்ணலாம். Usually 3 sessions per day எடுப்போம். அது 4 sessions increase பண்ணலாம். Reducing the dwell time. So instead of 4 hours வைக்கிறதுக்கு பதிலாக dwell time 3 hours 4-5 sessions நம்ம எடுத்தோம் அப்படின்னா we can achieve the dry weight and we can remove the more water as possible. So APD சொல்லுவாங்க automated peritoneal dialysis. இது வந்து conventional peritoneal dialysis விட பெட்டரா இருக்கும். ஏன் அப்படின்னா it is the peritoneal dialysis rate வந்து APD ல ரொம்ப கம்மி. machine dialysis அப்படிங்கிறதுனால. ஸோ பெரிட்டோனைட்டிஸ் வந்தது அப்படின்னா பேஷண்ட்டோட ஒரு மார்ட்டாலிட்டி ஹையாக இருக்கும், அதனால ஏபிடிஎஸ் ஃபார் பெட்டர். ஸோ இந்த மாதிரி ரொம்ப ஃப்ளூயிட் ஓவர்லோட் இருக்கிறவங்களுக்கு வீக்லி 1 ஹீமோடயாலிசேஷன் ப்ளஸ் பிடி சிஏபிடி அப்படி கண்டக்ட் பண்ணோம் அப்படின்னா we can achieve more stable ஃப்ளூயிட் ஓவர்லோட் அச்சீவ் பண்ணலாம். தேங்க்யூ.
ஸோ So we are here for questions. Summary என்னன்னா dry weight வந்து important factor, dynamic phenomenon மாறிக்கிட்டே இருக்கும், மாற்றமே மனித வாழ்க்கை மாதிரி மாற்றமே dry weight. So அது வந்து dry weight அது help பண்றதுக்கு there are gadgets available. So we are here for questions. அண்ட் இன்னொன்று கோமார்பிடிட்டிஸ் இருந்தால் ட்ரை வெயிட் தெரிஞ்சாலும் அச்சீவ் பண்ணுறது கஷ்டம். ஸோ அது 3வது பாயிண்ட். ஸோ இஃப் தேர் ஆர் நோ கொஸ்டின்ஸ், தேங்க்யூ ஒன் அண்ட் ஆல்.
Thank you, sir. I am inviting Mr. B. Ruben, Vice President, SDTP, will now honor our moderator and panelists with token of our appreciation.
Our next and final session is a panel discussion on dialysis access management and complication. Moderating this session is Dr. R. Radhakrishnan, HOD of Vascular Surgery at Srihar. Please welcome him and our panelists. Dr. Sarita Vinod, nephrologist at Vinita Hospital, Chennai. Dr. B. Balaji Krishnan, consultant nephrologist at Kaveri Hospitals, Alvarpet, Chennai. Dr. Ilanjeralathan, professor and HOD of vascular surgery at Government Stanley Medical College, Chennai. Let's give them a round of applause.
Good afternoon, everybody. So this is the last session, so just please hang around. Most of the questions actually we have spoken to Sindhil, so whatever questions you have sent through mail or WhatsApp messages, we have collected most of the questions and we'll try to answer them in the best possible way. So first, Dr. Sarita will be here. She'll be presenting few of the questions and their answers now. Then we'll continue with few more questions about AV access and other related queries. Please.
Thank you, sir. Good evening, everyone. First of all, thank you organizers for inviting us to be here as speakers. Second of all, I see it's the end of the day, everybody is really tired. So we will keep it short and also something that you can relate to. Instead of going through some topics, we just thought, what is the need of the hour? So we have asked for questions from the technologist, and as these are the answers that we are giving for your questions, so hopefully we'll have it as in a purpose. Thank you. Yes. So first question, I'm taking mostly on the vascular access. See, vascular access is basically the lifeline for dialysis patients. Agree? Yes? Okay, at least. So vascular access is very, very important. Without that, there is no dialysis can be done. So to keep the vascular access going, as we are using the membranes that can encourage the clotting, we use certain blood thinners, and the most common ones are the heparin, low molecular weight heparin, and citrate. Heparin and low molecular weight heparin have been studied for a very long time and have been proven to be beneficial in regular and conventional hemodialysis. However, in CRRT, we prefer to use a citrate as an anticoagulant because it is mostly regional. Although it has its own benefits and side effects, other than the citrate, we use the regular heparin. The other ways of avoiding clotting and keeping the circuit alive is some studies have been done with heparin bonded dialyzers, also wherein they initially started out with heparin flushes before the dialysis is started. However, they don't seem to be showing of any benefit. Higher the blood flow prevents. For example, if the blood flow is just about 150 or 200 and we try to extract more ultrafiltration, naturally the life of the membrane and the dialyzer goes down, clotting happens and the bleeding or the blood loss happens. So to prevent it, best is to ensure that we have a higher blood flow rates and check for the access inflow and outflow to allow this to happen. At least 250 through 300, 350 is better. Ultrafiltration. Ultrafiltration rate, I think already it was discussed in the dry weight chapter, that keeping the ultrafiltration rate not more than 10 ml per kilogram per hour is important for the long-term benefit of the patient. The next, during the hemodiafiltration, which is coming up now and seems to be more beneficial, here we can use a pre-filter dilution. Okay, and the last one in the CRRT, again, we should be keeping an eye on the filtration fraction. It should not be more than 25 to protect to prevent the clotting. Next, we talk about clotting, so we should also be aware of bleeding because we are giving them medicines that are increasing or making them prone for bleeding. So we should be aware, check periodically platelet count. If it is less than 20K, the patient is more at risk for bleeding. And this can happen in two ways. Initially, anytime a patient is initiated on dialysis, we are giving them heparin. First, 48 hours later, check for the platelet count, which will give us an idea if there is any chance of this patient having a heparin induced. It may not be immune, it can be a non-immune type of low platelets also. So it is good to note. Something immune meaning there's a hit, heparin-induced thrombocytopenia. So these are the two things we need to keep an eye on and watch for the platelet count. Any person having an acute GI bleed or a surgical wound bleeding, we don't want to give them heparin or any blood thinners. Patients who has undergone especially major operations like intraocular or spinal surgeries, within the first 72 hours, we don't want to give the blood thinners. Intracranial bleed, extradural bleed, patients should not receive anticoagulants. Uremic pericarditis, that is usually when we are starting the patient on dialysis, we don't give anticoagulants. Systemic anticoagulants, like if a patient is on a warfarin, but the INR is less than 3.5, we can still continue to give anticoagulants, but if it's more than 3.5, you don't want to give it. Coagulation factors 7 and 8 deficiencies are the only conditions wherein we don't want to give anticoagulants. Antiplatelet agents that maybe most of our patients, cardiac patients, are on either an aspirin or a clopidogrel. They do not demand any change in the anticoagulation doses. Heparin maximal, if at all the patient is clotting, despite the standard doses of a 2K bolus and then 500 per hour, if they are starting to clot, we want to increase heparin gradually. Maybe the bolus, if it is in the first half, and if it is in the later half, the maintenance doses can be increased by 100 units. Which anticoagulant is better is the next question that we received. So as you know, it is a heparin and low molecular weight heparin. We have many studies. None of them seem to be superior or inferior. So whatever you're comfortable with, you can use it. If a patient is on a low molecular weight heparin for a DVT for some other reason, then that patient coming in for a dialysis, and if the patient is receiving about 20 milligrams of enoxaparin or so, we don't need to give heparin on dialysis. Regional citrate for the regional is the comparison on a CRRT seem to be better when compared to a low molecular weight heparin. However, both can be utilized. The next question we received is a bleeding. How do we treat AV fistula bleeding? Well, this is a life-threatening emergency and it requires an urgent care. So first and foremost, every patient who is started on dialysis with a fistula should be educated by the caregivers on this emergency that can happen. So how do you educate them? If at all, first of all, end of the dialysis, the bleeding should be stopped by applying pressure, and only then they should be given a band or they should be receiving the ligation thing, and then they should be sent home. But after going home, in case they bleed, then they should be educated to apply pressure with 2 fingers at the local site. Why 2 fingers? Because again, we have 2 exit sites. That is a skin exit site and the vascular area exit site. If the applying pressure just with 1 finger, there will still be some amount of oozing around the vascular compartment, which leads to hematoma. Therefore, 2 finger pressure at the site of the needling has to be applied, and in spite of that, if there is more, ask them to take help with somebody who can apply pressure at the surgical site, which will reduce the blood flow towards the fistula. And they can also lie down and place their hand above the head so the flow again comes down, so the bleeding tendency comes down. If they're having high blood pressure, they should be taking an antihypertensive also. Despite that, if it's not coming down in the next 10 minutes, they should be coming to the hospital to seek help. And if the causes, if they have just finished their dialysis and the heparin dose they might have received, what do? We can give protamine to reverse the bleeding tendency. The heparin effect can be reduced by giving protamine. And still, if they continue, fresh frozen plasma comes in handy while watching that they don't clot. The next question we received is, what is the blocked vein called? It is nothing but a thrombosed vein, okay, thrombosed fistula. What are the causes? It is only most of the time it is because the inflow to the fistula is affected. It could be affected because the blood vessels are not very good, that is the arterial side is not very good, either because of their conditions like diabetes or atherosclerosis, or it could be because of the stenosis after the surgery, wherein there is a narrowing, allowing a less amount of blood flow into the fistula side. or post fistula, it could be the thrombosis wherein there is a stasis that is happening. Hypotension, or even after any surgery, a dialysis patient undergoing any surgery is bound to have a hypotension and hypercoagulability, and we should be watching for a thrombosed veins in them. Infection, because of the hematoma formation, infiltration, which can get infected, can lead on to it can cause thrombosis of the veins. High hemoglobin, erythropoietin, the doses that we use, our aim is only to keep it between 10.5 and 11.5. Anything more than that can increase the hypercoagulability. Technical errors is basically infiltration, double puncturing, all of that because of that hematoma formation, infection and thrombosis. So how do we prevent it? There is some studies which say why don't we do the surveillance periodically, but however they don't seem to be improving any the consequences except for AV fistula, that too it may be. So clopidogrel is being given. Early patency of the AV fistula is better maintained with clopidogrel, but not for the graft. Warfarin has no role. Any clotting or thrombosis of the fistula should be intervened within the first 48 hours. What are the best dressings for the central venous catheters is the next question. So there are 3 types of dressing. The most common one that we are using is a sterile dressing, sterile and gauze dressing. It has it's the most cheapest, most available. This is what we use in India most of the time. However, while removing it, sutures sometimes come off for the catheters, and then it can also cause a little bit of a trauma, some hematoma. So the others, if it is affordable, we can go ahead for the best one is a chlorhexidine impregnated dressings. This is recommended by the CDC in this year recommendations. But the other one that we normally see is the Tegaderm, which is a polyurethane dressing. It's transparent, it is sterile, it is semi-permeable, and it causes a good waterproof, and it is self-adhesive. Easy to use, but costs a little. Next question, interesting. This is actually, I got to learn about this also because I never knew what they were talking about, a blue and a red thumb. So what is a blue thumb is basically, blue stands for venous. So anything that is, it is for the direction of the loop graft. Towards the thumb, if the flow of the vein is upwards towards the thumb, then that is a blue thumb. If it is towards the, if the arterial direction is towards the thumb, then it is the red thumb. So the second question they asked was, which one is better? So basically, you need to place, it is important to know the direction. And when you know the direction, arterial vein should be from the arterial side and the venous needle should be on the venous side. That is the best way of cannulating. So next is the buttonhole technique. What is a buttonhole technique? It is a way to cannulate, but it is used only for AV fistulas. Inserting needles at the exact same site, at the same angle, and at the same depth is important for making the perfect buttonhole. So in our units, when every technicians keep changing, it's probably not going to be the best majority of the time, but in Western countries, individuals who are doing a self-cannulation or a home hemodialysis do practice this very often. And some of our centers are also doing it anyway. So here, after 10 to 12 cannulations, when the same path is created, a scar tissue is created, scar tunnel is created, through which even a blunt needles can be introduced. And the main advantage of this is no pain. It's just like the earlobe thing, because there is already a path created. When the needle is going in, it doesn't have any pain, and therefore the patients are not anxious and they're willing to do it themselves. It also, the patient feels empowered because they themselves can do it. So advantage is a less pain and fewer complications like hematoma and infiltrations, and decreased anxiety, patient empowerment. Disadvantages are cannulating from the same site every time can lead to aneurysms, and skills have to be developed. Infection is the biggest concern with this tech because there's a pathway that is created wherein the bacteria can settle down. So cleaning it before and cleaning it again after removing the scab, so maintaining the hygiene is absolutely a must to use this technique. The next technique is a rope ladder technique. This is what we use it most often because this helps us in using the entire length of the fistula and prevents complications like aneurysms and the hematomas. However, pain is always a problem with this. Disadvantage is pain, and anytime the new site is being used, all the patients say, please, I don't want to go to the new site because they're terrified of the pain. However, using it long, the entire length will give a longer life for the fistula. So one should look for it. Finally, coming to antibiotic lock for the permanent catheter. Permanent catheters have now become a lot more, and therefore we are seeing a lot more infections, and so we need to address this issue as well. What is this antibiotic lock? It is installation of the concentrated antibiotics into the lumen and allowing it to dwell in the catheter. Okay, mainly to kill the bacteria that is there in the biofilm. So this antibiotic lock is not to be used alone. It is to be used only when we are using the systemic antibiotics. This is in addition to that, only to allow us to continue with the catheter till we have an answer on what is the type of a bacteria, or should the catheter be removed, or can we salvage it. Okay, the common antibiotics that we use are usually vancomycin, cefazolin, ceftazidime and gentamicin. So again, the fallacy here is that whenever we're using it, it should be prepared immediately, not like preparing an hour before and then bringing it onto the dialysis unit and installing it into the catheter. So it should be used along with the heparin to maintain the patency of the catheter. There is no prospective study so far to support a gram-negative, staph epi, coag negative or enterococcus. So not a must, but if possible, if trained, if we have the facility, it can be used along with the systemic antibiotics. Thank you so much. If you have any questions, you're welcome to ask.
So, next presentation will be more based on the AV access and the related questions we got. And there will be few repetitions because we prepared the slide separately, so there are few repetitions. So first these are some general questions which we got. Why are the veins blue? Why do veins collapse? And why do we always use cephalic vein for the AV access? Next slide. So veins appear blue because whenever light reflects from the skin, the blue light is not penetrate the skin. So the blue light is reflected more. So that's why, especially in fair skinned individuals, when we see the veins, they appear greenish or blue. That is due to the reflection of the light. And veins tend to collapse because basically they are in a lower pressure system, except when we create a AV fistula where the arterial pressure comes into the vein. So otherwise, and during respiration, as sir was mentioning during the dry weight measurement, the veins tend to collapse because of the negative pressure in the chest cavity. So that is the main reason for collapse of the veins. And cephalic veins are preferred because they are long veins, they are quite straight, they have a very definite anatomy and they are very easy to cannulate. So that is the first choice for creating an AV fistula. So next, the other question we got was the challenges of vascular access in pediatric group. So Dr. Cheran will describe about that.
Okay, these fistulas are created by vascular surgeon, but the life for fistula is given by dialysis technician. So the longevity of any fistula, it is your technical brilliance gives a longevity to the AV fistula, whatever we create. So challenges of vascular access, specifically in children. குழந்தைங்களுக்கு ஏவி ஃபிஸ்டுலா பண்ணுறதுல என்னென்னலாம் ப்ராப்ளம் வரும், குழந்தைங்களுக்கு ஃபஸ்ட்டு ஃபிஸ்டுலா பண்ணுறாங்களா அப்படின்னே நிறைய எங்கள் டாக்டர்ஸ்க்கே நிறைய டவுட் இருக்கும். பீடியாட்ரிக் ஏஜ் குரூப்பில் ரீனல் ஃபெயிலியர் வருதா, அதுக்கு ஃபிஸ்ட்லா கிரியேட் பண்ணுறாங்கன்னா டெஃபினட்டாக ஃபிஸ்ட்லா கிரியேட் பண்ணுறோம். அதுக்கான ரீசன்ஸ் ஏன் வந்து ஃபிஸ்ட்லா வந்து வெரி டிஃபிகல்ட் இன் பீடியாட்ரிக் பாப்புலேஷன். பீடியாட்ரிக் பாப்புலேஷனில் பிளட் வெசல்ஸ் ஆர் வெரி ஸ்மால். நம்ம ரொட்டீனாக வந்து சின்ன வயசில் இந்த தொட்டா சினிங்கின்னு சொல்லி பார்ப்போம், டச் மீ நாட், அந்த மாதிரி தான் குழந்தைங்களுக்கு பிளட் வெசல் இருக்கும். நாங்கள் ஓப்பன் பண்ணி அதை டச் பண்ணோன்னே இட் வில் கோ ஃபார் சிவியர் ஸ்பாசம். ஸோ இட்ஸ் எ ரியல் சேலஞ்ச் ஃபார் அஸ். ஸோ டெக்னிக்கல் டிஃபிகல்ட்டி, லிமிட்டட் அக்சஸ் சைட்ஸ், டெலிகேட் ஸ்கின் டிஷ்யூ, நீட் ஃபார் செடேஷன் அண்ட் அனஸ்தீசியா. லோக்கலில் பண்ண முடியாது, குழந்தைங்க அழுதுகிட்டே இருக்கும். ஸோ அவங்கள்ட்ட we have to develop a good relationship. We have to gain confidence for the pediatric age group. Establishing pediatric vascular access poses a challenge because of smaller vessel diameter, as I have already explained. So vascular hyperactivity, அதான் தொட்டா உடனே அது வந்து ஸ்பாசம் போயிடும். So we have to do a no touch technique. And patient specific physiology, இவ்வளோ சேலஞ்சஸோட ஏவி ஃபிஸ்ட்லா பீடியாட்ரிக்கில் கிரியேட் பண்ண பிறகு இட் வில் ஃபங்க்ஷன் நைஸ்லி. தட் இஸ் தி பெஸ்ட் பார்ட். அண்ட் ஃபார் டயாலிசிஸ் டெக்னீஷியன் இட் வில் பி வெரி வெரி டிஃபிகல்ட் டு பஞ்சர் ஆல் திஸ். யூ ஹாவ் டு ஹேண்டில் ஜென்ட்லி. Or AV fistulas, the gold standard for elderly dialysis patient. Always AV fistula is the best for all renal failure patient. There are specific conditions that we cannot create AV fistula. So in elderly patient, patient specific இருக்கணும். சில patient வந்து more than 75 years, 80 years, prolonged ICU careல இருந்திருப்பாங்க, multiple vein punctured இருக்கும். அந்த மாதிரி phlebitic veinல எங்களால் கிரியேட் பண்ண முடியாது. இல்லைனா பேஷண்ட்டோட லைஃப் எக்ஸ்பெக்டன்சியே கம்மியாக இருக்கும். அந்த மாதிரி சில எக்ஸப்ஷனல் கண்டிஷன்ஸில் we can go for a dialysis catheter, a perm cath or a graft. So life expectancy and comorbidity, elderly patients may still be at high risk of complications due to Steele syndrome, reduces the effectiveness of the fistula. In such of those patients, we can go for other modality like perm cath. Otherwise, AV fistula creation, vein and artery is the best conduit we have. AV fistula in elderly, it's gold standard. Previous சொன்னது இதே இதுதான் ஆன்சர் தான். So central vein catheterization, what are the
these are all done by madam. So go to the next one.
Madam just answered all this. Why AV fistula is recommended for dialysis? AV fistula is the cheapest and best thing naturally occurring the vein and artery in our own body. So foreign body reaction irukadu. Longevity, prolonged years together, if it is properly maintained, it will be prolonging the life of the patient. அவ்வளோ சீக்கிரத்தில் அதில் பிளட் கிளாட் ஆகாது, அவ்வளோ சீக்கிரத்தில் அதில் வந்து இன்ஃபெக்ஷன் வராது. It is not like a dialysis catheter, it is not like a perm cath, it is not like a synthetic graft. So always our own human beings, vein and artery are the best access. What is the rule of 6? The KDOQ guidelines, the vein diameter should be 6 millimeter. So it is the rule of 6, and fistula should be 6 millimeter diameter, fistula present less than 6 millimeter below the skin. ஒரு obese patientக்கு vein ஓட depth of skin is very deep. It will be very difficult for a dialysis technician to puncture. So within 6 millimeter it will be always easy. Certain cases நீங்கள் டயாலிசிஸ் பண்ணுறப்ப எனக்கு கஷ்டமாக இருக்குது சார், பஞ்சர் பண்ணுறது ரொம்ப கஷ்டமாக இருக்குது, ஃபேட்டி இண்டிவிஜுவல், what you are going to do, we will superficialize the vein. யூஸ்வலாக பெஸ்லிக் வெயின் பண்ணுறதை மட்டும்தான் நாங்கள் சூப்பர்ஃபிஷியலைஸ் பண்ணுவோம். அதர் வெயின், கெஃபாலிக் வெயினில் அதை கொஞ்சம் டயாலிசிஸ் பண்ண இனிஷியல் ஸ்டேஜஸில் டிஃபிகல்ட்டி இருக்கும். தென் இட் வில் பி எக்ஸ்பேண்ட் and it can be after proper exercise it can be used. Even in such of those patients, if you have difficulty, you can request your vascular surgeon to superficialize the vein. And straight segment of the cannulation, that should be at least 6 centimeters in length. Maturation period is 6 weeks, that is 1.5 months, as you all know. This question madam had already answered. And what are the causes for poor vein access?
So poor vein access like when we get a referral for AV fistula patients, we don't see sometimes veins, mainly because sometimes the hands are chubby or fat, where the veins are not visible. When the veins are very thin, especially in malnourished patients or in patients who have been on chronic kidney disease, not treated properly, and again low blood pressure. This happens especially when the patient is undergoing dialysis and they ask a reference for IV access creation. Most of the time the veins will be collapsed. So we may not be able to see the good veins. So in these situations it is ideal to see the patient maybe the day after dialysis so that they are better filled and we are able to see the veins in a better way. And as mentioned previous, vein puncture, multiple IV medications. So many of our patients undergo various treatments at various hospitals before they come to us for access creation. So like as we mentioned, everybody always preserve one hand and don't use our cephalic vein for anything else rather than AV fistula. It's a request to all technicians and all paramedics. And as I mentioned, dehydration is one of the important causes when we are not able to assess the vein or poor vein access.
So how do you examine vascular access? Routinely we select the patient. Careful clinical examination is very, very important. As sir had already mentioned, as vein is prominent, don't puncture for other purpose. Usually dialysis technician has that knowledge, don't puncture the vein, but you have to give the instruction to the nursing staff as well as the lab assistant who always puncture the cephalic vein and they want to do the job easily. Never puncture a vein if patient is a renal failure patient. They can go for a smaller vein for punctures. So clinical examination, tap test, if there is a good conductivity of the blood column, then it's a good vein, whereas multiple punctured veins, there won't be a good tap test. As well as the tourniquet, you can see how it is distended, and road mapping can be done. Even if it is clinically not access, we can go for a Doppler examination if we have doubt that this fistula is not going to function. Once the patient spends thousands of rupees to do a fistula and it is not functioning properly, it is a problem both for the nephrologist, the technician, as well as the confidence of the patient is also damaged. So for such of those patients, if you have doubt, you can ask the radiologist for a vein and arterial mapping.
Okay. What are the common causes of access failure? The most important thing is stenosis. Again, it all lies in the technician's hands, how they handle our fistula and how they cannulate. Because most of the patients, if we see the failure or thrombosis happens in the first 4 or 5 dialysis. So that is the time when the fistula is very new, the veins are not really used to the multiple punctures, and those times are the one in which we should be very careful to cannulate the fistula, and proper sterile technique should be used and proper compression should also be given. So if these are all not done, then the fistula tends to either thrombose or get occluded. After 4 or 5 punctures and after regular dialysis, I think the vein gets matured enough and it is cannulated is quite easy. Then the puncture related problems are much less. Then the stenosis related problems come. The most common stenosis we give is juxta-anastomotic, that is just after the anastomosis at the AV fistula. Sometimes it can happen in the arterial side, and especially in AV graft, we get stenosis at the venous end of the fistula. So thrombosis, as I mentioned, happens initial first few dialysis, and central vein stenosis is not very rare. We see it very frequently now, especially because patients, most of the time their first dialysis through the central line, and they keep dialyzing in it for about 2 months, 3 months, and once we create a fistula, they come with swelling of the hand, problem with cannulation, improper dialysis. So that is why we always advise fistula first in all the patients, especially either in CKD 4 stage itself, so that we avoid the central venous cannulation. And other common complications related to any surgery like infections, seroma, lymph node collection, and puncture related complications like pseudoaneurysm or infections. So how do you identify whether the fistula is failing or there is a problem? You have to refer to a vascular surgeon. So first thing is excessive bleeding. When you give compression or you apply tourniquet after the dialysis, if the bleeding doesn't stop more than 20 minutes, then there is probably an obstruction in the vein which is causing the higher pressure and increased bleeding. So, and again, when there is a change in the thrill, most of the time patients themselves, they say, I used to hear the machine sound, now the machine sound has come down. So those things are all easily picked up by the patient, and if these things are there, then better that you refer to the vascular surgeon. And changes, as I mentioned, in the brewery or sound or in the volume. Earlier we are used to 300 ml, now we are getting only up to 150 or 200. Those signs, if you see when you are doing dialysis, or alarms, excessive venous pressure or excessive arterial pressure, don't wait for the fistula to get blocked. Refer it. When these signs appear itself, we can easily salvage the fistula through fistula angioplasty or balloon angioplasty or revision anastomosis. So once the fistula is fully blocked, then it is very difficult to salvage. If these early signs are picked up every time during dialysis, then we can salvage almost all the AV fistulas. Next. I think this madam has already discussed. We don't really use much of forearm loop grafts, because if we have a vein in the elbow and the artery in the elbow, most of the time we do a basilic vein transposition or a fistula itself. So forearm loop graft is not very commonly used, especially in our population. So we don't really use these terms, red thumb, blue thumb. And fistula versus graft, I think already sir has mentioned, always native tissue is best, native tissue is infection free, native tissue is cheaper, and native tissue lasts much longer than the graft.
What is steel syndrome in vascular access? As this word specify that steel, the blood supply is still through the vein. So this usually occur in a brachiocephalic fistula due to some technical reason. If the brachiocephalic fistula or brachiobasilic fistula or a synthetic graft, if the surgeon technically he had made a bigger arteriotomy or venotomy, then it may end the graft size is more, then the blood that is going towards the finger is diverted and it is stolen from the tissue, peripheral tissue towards the central circulation. So usually these patient complains about finger pain, tingling numbness, and slowly this patient may develop fingertip ulceration. In such of those patients, if there is a definite steel phenomena, then that can be surgically corrected, and that is more complicated. So the best strategy for such thing is to avoid. That should be done by the surgeon in the initial first surgery itself.
That is, I think we have covered most of the questions. One more thing I wanted to add is, because as soon as we do a brachiocephalic fistula, sometimes the patient may develop weakness of the hand, not able to move the fingers. That is not steel syndrome if it happens within 1 day or 2 days. That is due to nerve neuropathy, which is called ischemic monomelic neuropathy, where the median nerve is damaged. But we don't know the exact reason why it happens. But if the patient, like immediately after the fistula, the next day you see patient is not able to move the hand, fingers, then it needs to be immediately referred to the surgeon, because only way to salvage that function is to ligate the fistula. If we wait for 1 or 2 days, even after ligating the fistula, the function may not recover. So that is not steel syndrome, that is more of a neuropathy which has to be corrected immediately. So if there are any other questions, you are welcome. Thank you.
Thank you to all our panelists, Dr. Sarita, Dr. Radha Krishnan, and Dr. Ilancherilata. Thank you. We will now take a few questions from the audience. If you have any questions. I am inviting Mr. T.J. Seelan, President SDTP, will now honor our moderator and panelists with a token of our appreciation.
Our next presentation is on the unveiling of DORA 6000 HT machine titled a Modern Marvel of Innovation and Safety. I would like to invite Mr. Harish A, Area Sales Manager and the Clinical Manager, South India at DORA to the stage.
Good evening, delegates. I hope it's been a long session actually. I think within 50 minutes or 30 minutes session is going to over. I'm not taking much time of them. I'm from Harish. I'm from Dora Medical Trading Private Limited, working as an area sales manager and clinical manager of South India. Today I just came here to launch our hemodialysis machine in front of you people. I know many of you people have visited already my stall. I'm very happy with this presence actually. Anyhow, I just want to take few words of our machine actually. In India, we launched last year, August 2023, and January 2024 onwards, we started selling this dialysis machine. Currently, we have 557 installations, and we have 123 centers overall in India. Last month, we got Maharashtra government tender for 480 machines. Tamil Nadu and Kerala, we have around 23 installations. Karnataka, we have 6. And mostly we are selling in north and west part, and south we are growing month by month actually. This is a basic hemodialysis machine with all modern features like automatic priming and automatic blood return, automatic draining. Other dialysis machines will drain only blood tubing actually. In this machine you can drain dialyzer also. No need to keep the bucket and all beneath the machine for draining the whole circuit actually. So these are all the highlights of a machine just to showcase what are all the parts that is present in the machine. We have a large 15.3 TFT touchscreen actually. Very easy to operate, no need training actually. By seeing itself you can see what's going on actually. If anything you want to change, just click in the window and it will give you the calculator like window like it's showing, see. So that you can change the data input, that's it. This is heparin pump. Again, this is also, it's not recommended, only 20 ml syringe can be used actually. You can use 10 ml, 20 ml and 30 ml. According to the diameter of the syringe, machine itself will detect whether it is 10 ml, 20 ml or 30 ml. And whole setup will be on the left side. We have a whole circuit actually. And this is the air detector, this is the clamp. And this is a dialyzer coupler, so we don't have a right side actually, it is in the center of the machine itself. Beneath we have A and B port, how the existing machines have like stick form itself. And we have endotoxin filter also. This is the window, you can see all treatment displayed showing in the one screen. So anything goes wrong, you can directly maneuver in the screen and you can change the data and proceed with it. This is the return and this is the priming and this is the disinfection mode. Both rinse, pre-rinse, disinfection can be customizable. There is a limit will be there actually. That limit you can't able change, but you can increase or decrease, you can change. And this is a sodium profiling we have. And we have, this is the hydraulic design, how the all existing hemodialysis machine have the same. And our dialysis machine can be opened in 3 ways, left, right and center. So for technician intervention and biomedical engineer intervention, it is very easy to operate and repair the machine as fast as possible. This is the real-time monitoring of the each and every valve of the entire whole hydraulic machine, hydraulic circuit. So anything goes wrong, you don't need to open each and every part what goes wrong actually. So in this diagram, flow diagram itself, it will show you where is the error is happening and it will mark in the red color. There you can open and intervene and just close as much as possible. So it's time saving for the technicians also to intervene when goes wrong. So we can able to say after opening this flow diagram in the machine, sir, this is the number where it shows red. So our engineer will tell you what needs to change or what you need to do in the machine. That's it. Thank you.
Please remain in the stage, sir. I am inviting Mr. M. Sudhakar, Executive Member SDTP will now honor Mr. Harish.
Our final presentation of the day is on clinical outcomes of reprocesses. I'd like to invite Mr. J. Singh Parab, Production Manager at Diacare Solutions, to share his insights. Let's give him a round of applause.
Hello? So good afternoon everyone. I would like to thank for organizing committee for giving us this opportunity to showcase our world-class product at this beautiful stage. Okay, so start with today's topic. It's clinical outcome of dialyzer reprocessing. So basically we are going to do some comparative look at the quality and consistency in automatic as well as the manual reprocessing. So before we start with, we need to see what are the elements of the dialyzer reprocessing. So basically there are 4, that is cleaning, testing, disinfecting and record keeping. So basically for the dialyzer reprocessing, we must clean the dialyzer, then we need to test the dialyzer, but basically it is eligible for the next use or not. Then we need to disinfect, so make it safe for the next use, and then we need to keep all these records so that we can ensure the accountability if any mishappens. Okay, so we are going to in detail, we are just going to run through what are the elements of the dialyzer reprocessing. So basically in manual cleaning, what operator needs to do is he needs to do the exact repetitive process for all the dialyzers. So basically the action and the timing has to be repeated every time. Okay, so as this is a very repetitive procedures, it is more prone to the mistakes and shortcuts. Like if the workload increases, there is a quality and timing that might get reuse. Okay, so as all the processes are done by the operators, they are also more exposed to the harsh chemicals being used for the dialyzer reprocessing. Okay, so what we need to do in dialyzer cleaning. So we need to ensure that all the blood residual parts has to be removed from the dialyzers. Then we need to try to restore the maximum function of the dialyzer membrane by cleaning itself, which has been clogged by the blood. Okay, then there are 2 types of cleaning we used in dialyzer reprocessing, that is the water alone and the diluted parasitic acid. So for the water alone, we what we do we flush it with the help of the reverse ultrafiltration and these things. So with the help of the water, we try to open up all the pores inside the dialyzers. Okay, so the problem with this, not many residual products are not soluble in the water, so it is limited effective. So just to increase this effectivity, the parasitic acid and hydrogen parasitic acid based chemical can be used. Of course, this can restore the membrane functions a little bit, but it comes with its own problems. Like if you increase the dilution of it, there are high chance it can precipitate more blood protein onto the dialyzer, which becomes more difficult to clean. Okay, so then in cleaning, what are the challenges we might face while doing the manual reprocessing? As you might all know that the TMP of the dialyzer is close to 600 mmHg. We need to maintain that effective, basically 12 psi of the water to ensure that the membrane is not ruptures. And the flush timing as well as the reverse ultrafiltration timings are inconsistent, and it depends on the workloads. Okay, then the other problems with the if we use the paracetic acid based solutions, the first of all, it has to be made fresh daily, and if the timing, that exposure of the to the membrane of this chemical has to be monitored very closely. So this can lead to some problems. Okay, then the major function comes, that is we need to ensure we need to check the remaining efficiency of the dialyzers, and that if we do it manually, which is very tedious process. Okay, and then after which we need to check the fiber integrity of the dialyzer also, which is also all the products what we use for this kind of a testing are not meant for this kind of a job, so it may lead to inadequate results. So then basically this is mentions like how the dialyzer has to be clean. So we has to remove all the waters from the dialyzers, then again fill it up, again remove it, and it is a completely manual process. It is user dependent. So there are mistakes can happen. Okay, then same things with the fiber integrity test. The products what we use for this, it is not validated for this kind of a job. So there, of course, there can be some mistakes can happen. Okay, then basically there are some thumb rule we consider into a dialyzer reprocessing, that a dialyzer has to be filled to 90% with approximately 3 times its blood volume. Okay, so sometime it might have achieved with the, and it of course dependent on the user. Also to make that dilution, the user is also exposed to that particular harsh chemicals. So these are the problems. You might have seen this kind of a job in gravity filled Stirland containers, which is usually kept on the top. There is a high chance it may fall on the user, and user might break into this. So this is also create some problems. So then the most tedious job is the record keeping. So as the accurate dialyzer of records for each dialyzers and each reprocessing, we can't maintain that traceability. So it is quite difficult to miss, and of course we can't track down. So this is how it makes it more tedious to have a manual data keeping and into these things. So what is the option for this? So that is, we came up with an idea of the automatic reprocessors. So the major thing is, what are the shortcomings of the manual reprocessing, which basically outcomes that with the help of the technology. Okay, so the water pressures and flow rates in the automatic reprocessing are continuously monitored. The timing is consistent, and it is completely independent of the operators. The chemical concentrations does not require to be pre-diluted, so it is more, the user is also more safe about these things. Critical factors, like as I mentioned in manual reprocessing, the critical factors like time, pressure, flow are not affected by the workload. So machine is going to take 12 minutes for 2 dialyzers, it is going to take 12 minutes for the 2 dialyzers, no matter what is the workload is there. Then the TCV, that is we call the total bundle volume, total cell volume. So there are so many terminologies for that. So it is already, it's consistent, and if the dialyzer is failed to achieve the minimum TCV, the machine will warn the user about these things. Basically, this is a medical equipment specially intended for this kind of a job. So all the products are used in these machines are medical grade. Then pressure decay rates are automatically adjusted corresponding to the low flux or the high flux, which is not at all possible into the manual reprocessing. So as I mentioned, the punchline here will be the total bundle volume and fiber integrity. It's not operator dependent, and the accuracy and consistency is also completely independent to the operators. So then Stirland fill. So we in DieCare, we have a sensor in place for this kind of a job. So first of all, we make sure that all our dialyzers get filled up with the minimum 3 times of it TBV. And of course, we have sensor in place to check whether every dialyzer has filled this time with the proper chemical or not. So, and the major thing is that very little exposure, because all the main job is machines takes care. So the operator is not basically exposed to any harsh chemicals. Then the record keeping, which was the major task in manual reprocessing. So you get the reprocessing results like this every time, where the patient name is boldly marked and the result of the dialyzer, whether it is passed, fail, and this label contains all the necessary equipment, necessary information which is required to verify that reprocessing was completely without any problems. Of course, this same reports can be found into the machine's report sections also. So in short, there are, if you put it into the tabulated from the manual versus operated, the quality is the major concern which is taken care into the automatic dialyzer reprocessing. Then the second point, all the equipments are validated for the intended use, so you can get the proper quality. The chemical concentrations are consistent. Paroxy-LP requires basically no pre-dilutions, so basically little exposure, and data is accurate and available all the time for the users. So this is the basic summary. I'm just quickly running through it. What are the elements? 4 elements: cleaning, testing, sterile and fill, and record keeping. Then quality, of course, it's not dependent on the users, validated equipments, and then it is completely no pre-dilution required. So this is our die-care dialyzer reprocessing systems, which offers the automatic reprocessing consistency, accuracy, repeatability, and safety at the affordable price. Thank you. If you have any questions, we have stall there. You can get in touch with us anytime. Thank you for a good listening.
Thank you, Mr. Para, for your informative presentation.
Thank you.
I'm inviting Mr. A. Netaji, Organizing Committee, SDTP, and Lecturer Srihar will now honor Mr. Jay Singh Parab with a token of our appreciation.
Takita takita takadina tattaka 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 takita takita takataka.
At this moment, we would like to extend our heartfelt appreciation to those who have played a vital role in the success of SDTPCON. So I now invite Mr. R. Sindhil, Founder and Secretary SDTP, to honor Mr. L. Shivamani, Pattern SDTP. I request Mr. L. Shivamani, Pattern SDTP, to honor the following people. Mr. R. Sindhil, Founder and Secretary SDTP. Jayashilan, President SDTP. Mr. B. Ruben, Vice President SDTP. by Aragya Das, Joint Secretary, SDTP. Mr. A.T. Srimugundan, Treasurer, SDTP. Executive Committee members of SDTP, Mr. T. Parthiban, Mrs. A. Kalpana, Mr. M. Sudhakar, Mr. M. Rajendran, Mrs. K. Nalini Kumari. Organizing Committee, SDTP, Mr. B. Niranjan, Mr. P. Kumaran, Mr. S. Krishnaraj, Mr. E. Tamildevan,
Drop the bass.
Mr. A. K. Saravanan, Mr. A. Netaji, Lecturer of Srihar, Ms. A. Hemalata, Mr. S. Silambarasan, Mr. V. Mudiyarasan, and Mr. Shivakumar, Gobi Hospital, Salem.
Spinning TV.
Organizing Committee of SRM, Asvika, Sadhana, Kirti, Yes, Chief. Can we invite Manju on stage? We have had a day filled with knowledge sharing, insightful discussions, and networking opportunities. I would like to express my sincere gratitude to all the speakers, panelists, and participants for making this conference a resounding success. Your contributions have enriched our understanding of the field. As we conclude this event, I request everyone to stand for the national anthem. Please be seated. On behalf of SDTP, I extend my heartfelt thanks to each one of your being for being a part of this enriching experience. We hope this conference has provided you with valuable insights and knowledge. Let us continue to collaborate and work towards improving the lives of dialysis patients. Thank you once again. Have a safe journey home, and we look forward to seeing you at future SDTPCON events. Thank you and goodbye. Can the SDTP committee members assemble on stage for a group photo?
takita tu takita